This, there was a piece in the anterior chamber. I don't know where I did the mistake. So, you have to be ready. Again, the same patient for which my heart was beating so high. So, open the main incision by the iris spatula and very slowly ate up this nucleus under topical anesthesia, because in these cases if you give peribulba, you can have a peribulbar hematoma and all that. So these are two things I want to share with you. Thank you very much. Any question?
It was a very nice presentation. Just one question, sir. You said you should be ready with all your armamentarium when you are expecting some problem in intumescent cataracts like this. So, what do you think more we should be ready with?
As I said, that because the patient is waiting and waiting and waiting, you can have anterior capsular fibrosis. So many cases you have to use a vitrectomy cutter to do a rhexis, right? Number one. Number two, you have to keep your vitrector ready, because if there is any problem in the posterior segment like this, you had a thick posterior capsular plaque. So you don't have to put the the trocar cannula. If you put the trocar cannula, the pars plana, reaching at the posterior pole of the posterior part of the capsule is very, very difficult. So don't use that cannula. Just give a stab incision so you can direct your tip of the vitrector towards the posterior pole, absolutely, at the plaque. So this is easier rather than putting a trocar cannula, because you are going to put it once and then do it and come out. And number three, be prepared in the sense that you have to talk to the patient that, well, I'll do my best. I do not know what will happen. So, in the next case, you saw that, everything went fine, but from where did that nucleus came out? I don't know. I never heard. So in second case, if that happens, you should know. Do you put pilocarpine to keep the nucleus in the anterior chamber? Or do you dilate the people to know where this nucleus part goes? So you have to judge. You have to be ready.
Great, sir.
Thank you for such a nice and
Thank you, ma'am.
videography and talk and information. Sir, very nicely explained how to manage the posterior capsular opacification through the pars plana route, and also you have well managed how to do the capsular rhexis in intumescent cataract, in which the intracapsular pressure is very high. Even you have not used the vitrectomy cutter right now. Do you use the vitrectomy cutter in your video?
No.
No. To manage the intracapsular back pressure and to prevent the extension of the rhexis. You have not used right now in these videos.
In both the cases, I have used the phaco machine, the phaco probe, for rhexis.
Yes, I have seen, but very well managed, very informative. Sir, nice videos. I like it. Thank you, sir.
Thank you, ma'am. Thank you, ma'am.
So Dr. Kashyap is a very renowned surgeon from Ranchi, and he says he's now third generation there. So now the next speaker is also very known to person, Kiranjit. Kiranjit sir se we have just met yesterday, but now I think we are very good friends. And he has so many innovations. You see, in Indian ophthalmology, you'll find innovation absolutely burgeoning all around. So he's very energetic, very, I will say, not friendly to the, not very outspoken person, but he's a very dynamic surgeon. And I'm sure Kiranjit will show something interesting to us.
No doubt, excellent surgery. Take home message is this. We learned two things in your video surgery. Sir, one thing, we can use the vitrectomy cutter to manage the extension of the rhexis, to prevent it, how to prevent it. And second is we can manage the posterior capsular opacification through pars plana route also. Most of the anterior segment surgeon usually try to polishing the capsule or such things. Yeah, I'm getting the point. Okay, first I want to give you our introduction. I am the Dr. Shanti Pandey, Professor of Ophthalmology, Government Doon Medical College, Dehradun. And sir, well-known personality.
I am a practitioner from Kanpur. My name is Dr. Malay Chaturvedi, and Dehradun is very close to my heart.
Who is the next speaker, sir?
चालू है ना प्ले करूँगा तो चल पड़ेगा क्या हाँ चला
Our next speaker is Dr. Bharti sir.
So
Bharti Kashyap.
I am supposed to talk.
Okay.
I have two topics and I have merged them both. So I'll be talking for around 12 minutes. Please tolerate. So in this era where the debate is around glued lens, Yamini technique and CMT flex, which one is better and which one is not, I am going to talk about a lens or a device which is quite outdated, that is anteriorly fixated iris claw lens. And like Dehradun is close to his heart, this IOL interior fixated, this is very close to my heart. So everybody must have seen corneal complications with it in the cases done in 1980s. But I have modified this lens into a very inert thing. So why I call it a device? Because it not only caves aphakia, it constricts the pupil, keeping dilatation intact, opens the angle, helps control IOP, and it does anterior chamber reconstruction. So this is a lady who came from Srinagar to me. After the PCR, the doctor had put the IOL half in the anterior chamber and half in the posterior chamber, and there was vitreous everywhere in the wound also. Possibly it was a SICS, and the haptics were cut, and later on the optic was removed. So this is a place where a lot of synechnias were there, so I had to cut it with the scissors. So this is the lens, multi-claw, iris claw lens, which will help me do a pupilloplasty. It will open up the angle, and usually the tendency of the synechia is that they reform. But when this device is in place, the synechnias are not going to form again. And the IOP from on the higher side, it became normal. So the latest design which we have come across is a rounded appearance with 4 claws. And I'm going to show you a patient whose mother came to me 21 years back. This is she came with already done PPV, PPL, and she came for secondary. Her both eyes I did the small iris claw lens, and presently she has 6/6 vision and endothelial count is 2200 after 21 years. So this time she brought her child with her, and that too for secondary IOL implantation. So I inserted the lens through a 5 mm incision, held the optic with the Clayman forceps, and with the help of a bent 26 gauge needle, I enclaved all the 4 claws, or you can say I enclaved iris into the claws at 4 places. And in such cases, it is very mandatory, the viscoelastic is being washed away, and in such cases iridectomy is a must to avoid pupil block. So the next post-op day, this was my first patient with this device or lens. He had 6/6 vision, and dilatation is not a problem. With pupilloplasty, the problem is the pupil becomes small, it cannot get dilated. So with this device you can dilate the pupil as well. So this is a patient of PCIOL dislocation in the anterior vitreous bag is there, but is not conducive for implantation. So the same thing I am going to repeat. Under Helon I prefer, because it comes out of the eye in a bolus and does not cause any reaction in the eye. So I think it just takes 1 minute to do so, all the 4 claws. And the problem with the previous iris claw lenses was the pseudophicodinosis, which caused corneal problems, but that problem has been fixed. So this is the angle spotted lens with iris Bombay and because of pupil block from Kashmir only. So simply take out the lens. I did a YAG laser PI before I posted the patient for the surgery. So simply at 4 places and it is done. No drilling holes in the ciliary body area and doing vitrectomy. So this is a patient of ulcer who had a therapeutic grafting done elsewhere. And as you know, the synechia are bound to get formed after few days or months of therapeutic grafting, and they reform, and the patient gets blind because of this high IOP. So this device will take care that the synechias, they don't form again. So this is the post-op picture, and this is I am told the patient to move his eyes, and there is no pseudophicodinosis. So this is a lady, 76 years old, and she is moving around with very big thick glasses, and she has come for secondary. And this is a beautiful technique showed by Dr. Amar Agarwal. Hats off to him, and it has, I think, saved so many eyes from getting blind. So once this thing is done, I am going to do the same maneuver, which may have started to look slightly boring now for all of you. And the best part is there is no pseudophicodinosis. So this girl, she has had this traumatic cataract done. She got this trauma, I think, 15 years back, and she's after my life. Please do a cataract surgery. I don't have anything I can implant. Your bag is not going to be okay, and if I put something in the anterior chamber, it is going to harm your endothelium further. So the anterior capsule was very thick. I had to use Vana scissors again and again to cut open the bag, and everything was fibrosed. Even the capsular bag was not fit for implantation of a PCIOL. So it had to be pulled out with a plain McPherson's forceps, and so it is being pulled out, and the interior vitreous has not been disturbed. Now I have a very big pupil. Either I do a pupiloplasty, 4th row pupiloplasty, but I have this device in my hand. What I am going to do is, I am going to pull the mid-peripheral iris into the claws at 4 places. So it will do a pupiloplasty, and it will take care those synechias which I have broken, they don't form again. And she had 6/12 vision post-operatively, and she is not happy with me because she is having diplopia. So again, a blast injury from Srinagar comes to me. The primary repair has been done over there, and now there are synechia vitreous in the interior chamber in the pupillary area, and with the help of vitrector I could break open the synechias. So now this, if the patient is able to see, he is comfortable, then you need not do anything. Otherwise, we can go ahead with the PKP. The recipient bed is made. So this is a patient in which there is fibrosis on one side, and the rest of the the iris is missing in the area where fibrous band is there. And so in this case I am doing a oval rhexis because you can't do a round rhexis over here. So with a phaco probe all the cataract thing is out, the fibrous band I am cutting with a Vanna scissors. So now here what I did was I took a 15-degree blade and I made a slip in the fibrous band. So that is a slip which I am going to pass through the one of the claws. So it is fixed in this area, and rest 3 areas I am going to put the iris in the claws. And little bit of vitrectomy because of some old blood in that area. So after the vitrectomy I have done, you can see the air bubble very nicely fitting into the interior chamber, and postoperatively this patient presently has 618 vision. Few more examples. So this is a patient with pellet injury, VR surgery done elsewhere, Somering ring, iris Bombay. I put the lens, the patient has 6/6 uncorrected vision. Again a blast injury from Srinagar, pupil lost, iris lost. So all these, I took the help of 4-throw pupilloplasty as well. And this is the last video I am going to show you. The girl with the phakia, she has divergent eye and the vision is with +10, she is 624. And this is the look of the eye, and the eye was soft because VR surgery had been done elsewhere. So thanks to Dr. Amargawal, this is a beautiful thing. So I could make the pupil small. And these Clayman forceps, they come in pairs, left-handed and right-handed. And this girl, she later on she underwent squint surgery also, and the vision she got was 6/6 partial vision, and which even I cannot believe. After squint surgery, she is looking like this. So is this device endothelial friendly or endothelial toxic? I think it is endothelial friendly, because this is a patient of iris claw lens done in 1980s. He has come to me, so what I do is I exchange the lens and send the patient to my DSEC surgeon. So this is for the better air tamponade. So what happened, after 1 month his cornea started to clear up, and he has presently 636 vision, and I hope his vision will improve. I think this is all I have to speak. Thank you very much.
I have two questions for you, Dr. Kiran. Where are these lenses available?
They are not presently available. I have got them made for myself, and I have put papers for patent. And if you need one, I can always need 1 or 2. I can send them across. That is not a problem, because presently they are not commercially available.
Great. The second thing is, you're tucking through needle.
Yeah.
Is there a forceps available for that?
No. Forceps, you will have to take two limbs of the forceps inside. For that you have to make a bigger incision.
Okay.
So that will make the anterior chamber shallow, and you may need to put suture over there. So I just take a needle, wrap some iris around the tip. I don't burrow my tip in the iris. Just wrap the iris around my needle and pull it through the claw. So there is no injury to the. Yeah, very right. 20
How long follow-up?
These patients, they are just 3 months old. This is the follow-up, but the process had started around 5 years back, when a girl came to me with with an IOP of 47. So I have shared the pictures with Dr. Pandav also. So that was a girl who had gone, she had steroid-induced cataract and glaucoma, and her cataract was taken out, but I think the lens was not in the bag. So because of some inflammation, she got high glaucoma. For that, she got a trabeculectomy done from somewhere, and it also failed. And when she came to me, she had a IOP of 47, and with all AGMs, with Diamox and occasional mannitol. So I got this type of lens made without a optic with 5 claws, and I forcibly enclaved the peripheral iris into those claws, and that opened up the anterior chamber angle to some extent. And presently she has IOP of 19 with AGMs and half Diamox morning and half Diamox in the evening. So that gave me the idea actually.
Very interesting, sir. But are there any specular follow-up studies? I mean, have you started?
No, I have not started. But the last 3 pictures which I showed you, they prove that even if you have a offending lens in the anterior chamber and you just remove it, the cornea is going to get clearer day by day. And same thing happened to my case. The cornea was totally edematous. I exchanged the lens, and he has got 636 vision in spite of the fact he has CME also. And I think in a month or 2 months time, his cornea is going to get more clear. That proves that it is not anti-endothelium, this lens. And I actually, in the last series, I did endothelial count. It was only the endothelial loss during the surgery which happened. Otherwise, they remained stable.
Very promising, sir.
Thank you.
So I think before we go to the next presentation, Dr. Kiran, why don't you follow up these patients with endothelial count and macular thickness?
Okay.
So I think you will get your answers very fast. Maybe with every week you will be wiser in taking decision. So these 2 things, if you are taking care, will have many answers.
Actually, I have done a pre-op endothelial count, and I think I just missed out on doing post-operatively.
Yeah. So suppose if we have a series of 20 cases where we have a weekly count, so each week, even though long-term follow-up is not there, but each week is making you wiser in decision making. Maybe you may refute your lens yourself, or you may actually, if you are convinced, then we will all be following you. Never know.
The actual reason was that these all cases were very, very difficult cases.
I know.
And my focus was only on how to manage them. So I missed out on this post-operative endothelial count, but I have done endothelial.
And also macular thickness, central macular thickness.
Central macular thickness?
Central macular thickness
for
CME.
For CME. Okay, so nice tips.
Right.
No, I am do very less of posterior iris claw. It is my brother who is doing more of posterior iris claw lens. And now I have got some success with the anterior fixation, and I am going to shift to posterior chamber also. But I need a patient who is poor and there is visual prognosis is guarded. I am going to experiment first on that patient, then so I have that thing in my mind also.
In the posterior, if you do it, posterior iris, this is me speaking. Posterior iris is in fact very reactive, anterior iris is not. So I do not know in how these posteriorly fixated iris claw lenses will fare in future, because I am actually very skeptical about this, and I feel that there can be long-term inflammations in these cases.
I think
posterior iris is very reactive.
He has put forward a very nice point, because when you do a posterior fixation, there are chances of vitreous getting tucked into the enclavation also, if you have not done proper vitrectomy. So that can lead on to some retinal problem or CME. So, and anterior surface of the iris is very inert. It doesn't react. The posterior one does.
In fact, the way you were saying, Dr. Chaturvedi, you need to do for these cases, actually we have to, it's a scientific world, we have to prove it by specular and CMT. There's no way out without this. And in case we are doing some study on the posterior fixation, we should do the aqueous flare count. And only then it has to be accepted scientifically, because otherwise it can lead to a lot of inflammation.
I observe one most important thing in this procedure which sir has done. Sir, very nice surgery, but if we are implanting on the entire surface of iris, one most advantage of this technique is it is everything is visible in the very nicely visible, and to manage the things, to tuck the iris on the hook is very easy. If we are doing from the posterior side, everything is and nothing is visible. By the जब pluckering होता है तो then dimpling on the iris, so that we confirm yes it is tucked or not. If you are implanting on the anterior surface, it is we are very much sure yes it is there. And one new thing we have learned was the sir use the needle. Basically, when we do the iris claw, we mostly use the dialer to tuck the iris on that. So, sir, we have learned two things from you, and very nicely, nice presentation. We are very informative. We are thankful. We are fortunate, sir. Thank you very much, sir.
Thank you, ma'am.
Now I request to Satansu Mathu, sir, Dr. B.K. Oli, sir, please come on the desk and chair the session, sir. Sir, please, sir. Please come, sir. Dr. Sushil Oja, please come. Dr. Sushil, please come on the desk and chair the session. I also request Dr. Bharti Kashyap ma'am, please come. She will present. Please come
So Dr. Bharti Kashyap is a very prolific surgeon from Ranchi. She is also president of Nari Shakti, and she is chairman scientific committee of Jharkhand Ophthalmology, and she has many other laurels. She will come out with her presentation. Let's enjoy the presentation.
So good morning everyone, and first of all I am thankful to the organizing team and the scientific team for giving me this opportunity. So my topic is flax pulse for lenticular pulse. There are some key questions. Does flax improve vision? Does flax use lesser energy in the eye? Does cornea heal quicker and it is safer? Is flax better when implanting premium lenses? Is flax better if it is a complicated case, subluxated lens, wide cataract, dense cataract? And there are a lot of questions coming in the mind that the final visual outcome depends on many factors such as formula, type of IOL, astigmatism. So, is there any current level 1 evidence that there is an advantage of flax over phaco? Yes. There are latest randomized controlled trials and meta-analysis since 2017. It has shown that though there is no difference in vision 3 months post-op and cornea recovery 1 month post-op and cystoid macular edema, but there is a definite advantage of lesser ultrasound power used in flax, and it is significantly less than in phaco. And there is a level 1 evidence supporting that the posterior capsular rupture rate is 0.65%, which is significantly less than in phaco. So the flax pulse for black-brown pulse, lenticular pulse are, we have to optimize the laser fragmentation parameters. We have, and this leads to less ultrasound energy and less effective phaco time, which leads to less anterior chamber inflammation, quicker recovery, and reduced endothelial cell loss and less corneal edema. So there are studies which have compared the optimized versus standard femtolaser phaco fragmentation pattern using automated cataract density grading to reduce effective phaco time and total case time. The automated cataract density grading of LENSAR laser is comparable to the cataract density grading of LOC3. So this is the laser automated cataract analysis. So pre-optimization versus post-optimization. Phaco fragmentation when performed using optimized laser parameters cause appreciable reduction in the overall mean effective phaco time compared with the pre-optimized phaco fragmentation. And compared with the default unoptimized phaco fragmentation setting, the optimized phaco fragmentation parameters cause considerable reduction in effective phaco time when analyzed for different cataract grades. And the post optimization, the mean total case time was 8.54 minutes. The surgery of 93.3% patients were completed within 10 minutes. So this is case 1. This is a black cataract, and we have used the grid pattern and the spokes. So optimization, the size of grid can be from 200 micron to 500 micron, number of spokes 4 or 8, and maximum lens lysis area is 6 millimeter. There are two options, 3 millimeter grid with spokes or 6 millimeter only grid without spokes. So you can see now after the laser we are doing phaco, and the CDE is only 20. So limitation is the number of pulses with the grid pattern are very high, it takes longer time, energy is high, more bubble formation and increased intralenticular pressure. This is case 2. This is a hard cataract. We are using 3 cuts and 2 cylinders, and you will see the laser optimization has been done by 3 cuts and 2 or 3 cylinders. And here after phaco, the CDE is only 16. So if we compare various lens lysis pattern, the least number of pulses are used in CHOP and the highest number of pulses energy are used in grid pattern. The highest bubble formation and highest lenticular pressure is found in the grid pattern as compared to the other two, and the fastest treatment and least suction time is in CHOP, and the slowest treatment and highest suction time is in grid. This is a brown cataract I am doing on Centurion Vision System, and you can see the difference here. The CDE is around 99.90, it is 100, more energy, more fluid, more turbulence, more time. And you can see the first day post-operative slit lamp pictures, there is a lot of corneal edema, vision is 6/18, and the same black cataract done by femto, assisted phacofragmentation, and the vision is 6/6, and cornea is clear, no edema. So the flax pulse for black-brown lenticular pearl is that we have to optimize the phacofragmentation parameters, which causes considerable reduction in effective phaco time, leading to less anterior chamber inflammation, reduced endothelial cell loss, and less corneal edema and quicker recovery. There is a benefit in terms of complication, that is the posterior capsular rupture rate, which is less than 0.6% in every large study of flax. No significant visual improved visual outcome, no cystoid macular edema post-op, corneal clarity, all is comparable at 1 month and 3 months. But there is a emerging evidence that flax may be of benefit when using trifocal or toric lenses, when lens tilt and decentration becomes more important for long-term visual stability. So a posterior capsular rupture rate and this the CDE after the femto is much less. And for flax pulse for white lenticular pulse, the pre-doc registration is successful, but the post-doc registration fails because of the reflection of the 6 LED lights from the white cataract. The reference landmarks are not detected, pupil iris margin, iris limbal margin. So after suction manually, the limbal centration has to be done. So we use white cataract setting for white cataract cases, and the moment the anterior capsule is cut, the fluid in the bag oozes out, and the following events occur: overall drop in the anterior capsule position as pressure in the bag drops due to fluid exit, cloudiness in AC because lens matter is released. So the fluid can also obstruct the path of the laser while firing for the capsular axis. This may not give the desired cutting of the capsule and can lead to uncut areas or the tags. So energy and delta up, delta down have to be increased in white cataracts. So white cataract settings are different. And you can see here fluid trap between PI and cornea, then fluid trap between PI and in the cataract also you can see here it is there, fluid trap between PI and cornea, and in cataract also. Here in the cataract. So for white cataracts, we use the white cataract setting on lens X, no need for post-doc registration, use trypan blue before removing the rexis in phaco OT to identify uncut areas and tags in the rexis. So take home message is, go with the latest technology with level 1 evidence of best safety. Hardware and software improvement is combating hurdles and cost is going down. There are common platforms available for use without investing in the femto technology. And I think it may allow a surgeon reaching his or her 60s or 70s to continue performing surgery instead of taking early retirement, because it really assists with some of the more difficult and critical steps in the surgery. Thank you.
Thank you very much. Yeah. So I think the list is like this with me. Kamal Kapoor, Dr. Kashyap, Dr. Kiranjit, Dr. Bharti, Dr. Gaurav, myself, Rohit Om Prakash and Arun Jain. So, Dr. Gaurav, are you ready? Okay, so I will make my presentation and then you can make it.
Any question from the audience side? Thank you. Okay. Doctor, what is it? I request to Dr. Kashyap, please come on the desk and chair the session, please. Thank you, Bharti ma'am, for such a nice presentation. Thank you.
So, good morning. Thank you very much. So basically, while traveling through the journey of cataract surgery, I have learned certain things, and then I thought that we should be making something which is right in the crux of the matter. And these are the 4 points which came to my mind. Do we have things to show? Pointer? Right on the top, there is a 3-dimensional thinking. On the left side, lamellar structure. On downside, lateral separation, and then there is a Y component. These are the 4 key features which will decide how to crack the nucleus. And this is the beautiful photograph which I took when I was driving through to the Uttarakhand. So the surgery should be predictable and it should be reproducible. And earlier I used to think that stronger things or more difficult things I show, I become a hero. But actually surgery is not about heroism, but it's about predictability and reproducibility. So can we produce a crack every time in every hand, in every type of cataract? And if we are reaching to that point, I think we have reached to the code how to crack. And the point is that cracks are produced in mind. If you know what you're going to achieve, you will achieve. So we have a main port here. I do 2-port surgery, and this is a main port and this is a side port, and we tend to get a crack in between. This photograph has taken my lot of interest. These are the pre-existing lines on which we are going to produce a crack. Now the question is, what happens to a lens when it gets cataractus? So this is the photograph taken by from the eye of a pathologist, and you will be surprised that these lamellar structures, they continue to stay even when the cataract matures. Even in this Niagara you have that lamellar pattern. These are the lines of hydration on which the water moves on the path of least resistance, and these are the lines on which we will be producing a cataract, a crack. So these are the phaco tips which have produced a crack. That means anybody would, any tip would have produced a crack. These are the machines which have produced a crack. That means any machine would have produced a crack. And these are the techniques and choppers, and I was so amused that uske paas hai, you can take that Mohan Rajan will have a sharp chopper to tear the abdomen, and somebody in Lucknow will be operating through a Sinsky hook, and both are good surgeons and both are able to produce cracks. So that means the trick is not here, but trick is somewhere else. So I go through a video. Trick is in the lateral separation. In 95, when Paul Koch came out with first book of phacoemulsification, he did talk about lateral separation, and if we know how to do lateral separation, the job is done. What is my contribution is that if you pronate your hand, the crack goes deeper. Because you saw the video of Dr. Kashyap when he was showing a crack he was making a lot of pull. Just to reduce that pull, if you pronate your hand, the crack will go deeper. So here is a video, if it runs. Yeah. This is just a small video which takes you through various types of cataracts. And let me see if it runs. Can you make it run? Now, in case if the video does not run, what will happen? I'll just explain. Till he is coming up with the video. See, but basically the thing is, in due course of time, you tend to make a program that I will do this, these steps, and I will achieve nucleotomy. And whichever machine we use, whatever techniques we use, I always ask my surgeons, what is vertical chop, what is horizontal chop. So it really does not matter which chop you are using, which machine you are using, but what is matter is that ultimately we are achieving a crack because of lateral separation. And I was surprised. I always thought that I am a practitioner and I have very less institutional support. So we did a program with, it was a web program, and that SN lady was ultimately, she said, ultimately it's the lateral separation which produces a crack. So this is a useful information, because especially for those people who have to purchase a machine, who have to evolve in the field of cataract surgery. And especially when we are in difficult situations, then this understanding is of key importance. The cataracts which we saw yesterday were easier to crack, relatively. In live surgery, even easier thing becomes difficult. That's a different story. But as Mohan Rajan was showing, that was a difficult case, and he chose difficult case because he thought he was capable of doing it, and actually he was. When pupil is dilated, getting, you see, these are the initial videos of my life, and you will realize that although lateral separation is there, but I am doing a lot of pull. Especially if the zonules are not very good, then this lateral separation, that pull is really the problem. So what I realized in due course of time, that I'll go directly to the video which is of importance. So like you see, this is a case in pupil, expander pupil is small, and if you really know how to crack, then you will be able to crack. Like this is a suboptimal situation. Here again, that concept is of tremendous importance, because you will be actually operating blindly. And yesterday I was talking with Kiran that when I was young, Dr. Ravijit showed a surgery where it was a small pupil and he could operate. And why he could operate? Because he knew what he has to do. And he, even if he, see, the amount of stretch which we are producing here is too much, especially in these leathery cataracts. So I thought that if we make circumferential movement, maybe we will be better off. And now, this is a 2 minutes more are left, and here I will try. So basically what is happening, you just engage, embed, and when you are laterally separating, you pronate. And how do you know that the thing is pronating? Is just watch the aspiration ports. And embed, engage, lateral separate, and pronate. So with very relatively much less stress, you can actually produce a crack. These are 2-3 examples. And okay, I think my time is up, and I think I have been able to convey my message. Thank you very much for giving the time. And Dr. Nitin, please come and take your.
Thank you, sir.
Thank you, Dr. Malay, teaching us about management of heart cataract particularly, and what is your experience about crack, the development of crack in heart cataracts. Thank you so much. So I'll request Dr. Arun Jain to present his paper on choice of EDOF IOLs for enhancing near vision.
Excuse me, I will request to all our speakers, please be stick on time, on allotted time. Okay, thank you.
Yeah.
Dr. Naren Shetty, yeah, please go ahead. So what's the topic, sir?
So basically, it's some novel markers to identify endophthalmitis.
Great.
Fantastic.
So Dr. Naren is Vice Chancellor of Narayan Netralaya, a very prolific surgeon, and we are very lucky to have him here. We look forward to listen from you.
Yeah, thank you, sir. On this onset, I'd like to thank Dr. Gowda, sir, and Dr. Vinod also for giving me this opportunity. Today, I'm going to talk about certain novel biomarkers to identify endophthalmitis. These are my financial disclosures. So I'm sure each one of us have had cases where post-surgery, we look at the eye and look at the reaction, and during the early stage, we keep wondering, is this an infective? If it is an infective, is it bacterial, viral, or a fungal? This is the early stage. And some of us decide, okay, let's wait and watch and see how things change. But eventually you get a picture like this, then immediately you rush the patient to the OT, and you do a very invasive AC tap or sometimes even a vitreous tap and send it to the microbiological lab. This is, very invasive and time consuming and very inconvenient for the patient, and definitely, this patient and his family members won't end up coming to us again. So in these kind of scenarios, a missed or delayed diagnosis can lead to blindness or loss of ocular architecture. So early detection is the key. So the research question is, can we have a non-invasive, quick, simpler, and more affordable treatment? So we found something very novel. We call this the TED. TED referring to tear endophthalmitis autoimmune detector. The aim of the study was to do a tear endophthalmitis detector of any infective etiology and its correlation with conventional microbiological testing. So these are the objectives: to study the tear profile and correlate with endophthalmitis, to study the microbiological profiling using a standard lab test, comparison of these results with the microbiological diagnostic methods, and lastly, study correlation with the tear profile using metabolomic profiling. These were the inclusion criteria. We excluded any kind of lid abnormality. When you come to methodology, we did a detailed ocular and systemic examinations. Sample was collected of the tears of aqueous and vitreous, and analysis was done. So these were the tests which was done, which was gram stain, culture, PCR, and also mass spec was done. Because shortage of time, I won't go into too much details of the sample preparation. This is how the preparation was done, and also the data was analyzed. And when you look at the expected outcomes, was we were trying to quantify and identify metabolic regulators and also identify key metabolic pathways. So when you look at the results here, you can see differentially expressed metabolites in bacterial endophthalmitis. And here you can see a supervised cluster showing a distinct separation pattern. And when you look at the heat map, shows major differences in expression of metabolites in control and bacterial endophthalmitis. These were the altered metabolites. We found a similar kind of unique altered metabolites in viral and also in fungal. So what was already known was diagnosis of endophthalmitis is based on clinical examination and supported by microbiological investigation, which was a very invasive and time-consuming process. What this study adds is an altered metabolic pathway in which in tears in endophthalmitis cases, which correlate, which is found in aqueous and vitreous, Tear metabolite profiling may be able to identify endophthalmitis and may serve as an early diagnostic modality, obviating the need for an invasive test. So how do we translate all this to our clinics? So we are devising this diagnostic kit with the help of which, let's say next time you're suspecting some kind of infection in the eye, you collect the tears with just the Schirmer's tears in your own clinic, put it into this diagnostic kit, which is very affordable and portable, and in 30 minutes you'll have the report with you. With this, you can catch these infections on the very early stage, and that way you can treat the patient very specifically, and the patient also doesn't realize something has gone wrong, and you'll have very good outcomes. Thank you for your time.
Although I have been asked not to ask for questions, but are they inflammatory markers which you are looking for?
So basically metabolites, sir. So the thing is, in the past, people have tried to culture the bacteria of endophthalmitis or any kind of infection which is happening. They've not been successful because it's not possible because of a lot of this one. But what we, just a small idea which came to me was, maybe we can look at the metabolites of the organism. In the sense, basically, it's something like if something is going on, let's say if there's bacterial infection, there's something, the organism will be like releasing certain things or some, metabolites. If we pick on those things, we are able to identify what organism is going on. I mean, what infection is going on. So that is the key. And for all, I mean, right now, any test we have to do, we have to take the aqueous or the vitreous. What is beautiful in this is we are able to detect the metabolites from the tears itself. So it's a more of a non-invasive way of looking at it.
So the only point was, how will you discriminate whether it is infective or not?
That's the point, sir. So we have identified these, if you see those altered metabolites, sir, once we have identified that, so it'll be like your MMP9, we have a small kit, we are trying to devise a kit like that, where you just collect again the tears from the tears with the Schirmer's and then put it into it, and then you'll have, okay, you'll have different markers, okay, it is, if it's this color, then it's bacterial, if it's this color, it's viral, then it's fungal, or it's not. Also, there'll be no indication.
And how much is the correlation? How well it correlates?
Oh, right now it looks very good, sir. But definitely, I think once we have a diagnostic kit and we test large numbers, I think we should have, ready for the market, sir.
Great. I think it's a fantastic idea, and it was expected from you.
Thank you, sir. Thank you, sir. Thank you for the opportunity.
Yeah.
Yes, ma'am. Sorry, ma'am. Yes, ma'am. That was the key thing while we are trying to investigate. So we have to make sure that there is nothing else, especially the lid abnormality is one of the main reasons why the normal flora can have a lot of abnormality. So we are trying to, we are very strict on the protocol, because first we need to identify what metabolites signifies what. Because even if you have, let's say, post-surgery abnormal flora, if you are able to pick up that much of bacterial metabolites, even if it is the surface, it's not good for infection. I mean, not good for the post-operative period. That infection actually is dangerous for the eyes also. But the point is, once you have identified these metabolites, which are very specific during this testing phase, later on these normal flora or normal, we can easily segregate those two.
Thank you, sir.
Yes, ma'am. So what we are doing is we have control group where it is normalized. So we are comparing normalized with infective eyes. So when we compare the two, we are trying to.
I think, Dr. Sethi, we can to compare. It's better idea to take the culture from the opposite eye. So you can judge, yes, which is the normal flora. Say if you are comparing with the same eye, how you can compare taking the culture from the same eye. You can take the culture from the opposite eye, so you can say, yes, this is the normal and this is not the normal flora. This is
yes, ma'am. We are not taking cultures, ma'am.
We are taking the culture from the opposite eye, then we can compare it, no? That's
yes. We are taking the tears, ma'am.
Okay.
We are taking from the other eye also.
Yeah, you are taking the culture from the other eye also, so that you can compare.
We are not
from the same eye, you can somewhere you are taking from the inferior fornices, then you are taking from the upper lid, and then you are comparing from the same eye. That's not the right idea, I think so.
We are not taking cultures, ma'am. We are
Yeah.
only collecting the tears, ma'am. We are
Yeah,
collecting
you are
the tears
taking
from the
tears,
other eye
same
also.
thing, you are sending
Other eye
for
we
the
are taking.
PCR and everything, culture or whatever you want to do. Yes, it's fine. I think it's better idea to take the culture from the opposite eye also, so that
We
you
are
can
taking, ma'am.
compare the normal flora.
We are already taking, ma'am.
Okay, thank you very much.
Thank you, ma'am.
Dr. Naren. Thank you.
Thank you, sir. Thank you.
So, after giving 6x to the patient, now there is turn to give better intermediate near vision. So, what options we have, Dr. Arun Jain is going to tell us.
Thank you, Dr. Oli. And at the very outside, I'd like to thank Uttarakhand Ophthalmological Society for giving me this opportunity to present my talk on EDOF IOLs for enhancing IOL vision. So as we know of late, these extended depth of focus IOL has been in vogue for correcting near vision for various reasons, because there are a lot of photic phenomenon involved with the multifocal IOLs. As far as the presbyopia correcting IOLs are concerned, this is how the evolution in different types of presbyopia correcting IOLs have come, and EDOF IOLs are in the latest on the evolutionary scale. These are the latest sort of set of IOL which correct near vision to near or intermediate vision and has much less photic phenomenon compared to the traditional bifocal or trifocal IOLs. And of late now we have the latest technology of hybrid multifocal with EDOF, which increase the range of vision. So as far as technology or on what basis these EDOF IOLs are based, there are basically four principles on which they are based. One is tweaking with the spherical aberration, which we normally have in most of the aspheric IOL. That also gives depth of focus to the tune of 0.5 diopter. And then we have these enhanced monofocal from one company, which is basically not a EDOF, but it enhances the near vision. And the second principle used is diffractive type of EDOF. Then we can have a diffractive. So there is a combination of different technology, and fourth technology used is in these cases using a pinhole effect. But in these cases the contrast sensitivity goes down quite a bit. So these are not in vogue. So instead of describing each IOL, we'll stick to one type of IOL so that we understand the concept of enhancing near vision with these IOLs. So this is again a classification of different techniques. We use pinhole effect. These are the various range of EDOF IOLs available to us in the IOL. We have Vivity, we have enhanced monofocal, we have Triumph, Lara. There's so many types from different companies. So recently we did a study with the enhanced monofocal from one company which has we presented this study recently at American Academy. So we will present this study here to just show how we can enhance near vision with these IOLs. Can you play it? Sound is not coming.
Siri here. Let me know if I can help.
Practice of modern cataract surgery
Yeah.
with increasing patient demands and spectacle-free improved experience for routine day-to-day activities. To compensate for this, enhanced depth of focus or extended range of vision IOLs has been devised based on the principle of single elongated focal point to enhance the depth of focus, unlike single focal point in monofocal IOLs or multiple focal points like that created with multifocal IOLs. Thus, EDOF IOLs combine advantages and overcome the limitation of two types of lens design that enhance the intermediate vision function of monofocal IOLs and minimize the disturbing photic phenomena of the multifocal IOL. One such design is EYEHANCE, which, as the name suggests, IOL with enhanced
What happened? Why?
Siri here. Let me know if I can help.
from periphery to the center of the optic that provides an effective add of 0.5 diopters at central to mm for intermediate vision. Review of literature shows that this Enhanced IOL as compared to its monofocal counterpart from the same manufacturer has better intermediate visual acuity and more spectacle independence for intermediate distance with similar distance visual acuity, contrast
Siri here. Let me know if I can help.
that
I don't know if there is synchronization is not there. Just
Siri here. Let me know if I can help.
rates of perception of halos and glare.
okay.
Thus, we came up with an idea of utilization of old age concept of pseudophakic monovision, initially described for monofocal IOL, to be applied for this novel IOL with the presumption that extended range of vision to a larger extent can be achieved encompassing distance, intermediate and near vision without need of spectacles or any compromise of visual acuity. So this was the aim of subjective outcomes of pseudophakic mini monovision with this IOL targeting emetropia in one eye and 0.75 to 1.5 diopter myopia in the other eye. This was a prospective non-randomized interventional study comprising 20 patients where the patients underwent bilateral cataract extraction with implantation of IOL within 1 to 2 weeks gap, and the patients with corneal astigmatism of more than 1.5 diopters and preoperative high myopia and hyperopia or irregular eccentric pupil were excluded from the study. Our results from the study showed that binocular longmire visual acuity at 3 months was 0.02 longmire for distance, intermediate visual acuity was 0.01 and all patients,
There is a login of WhatsApp in this.
whereas for intermediate vision most of the patients were satisfied with requirement of glasses for operating mobile phones was by only 3 patients, and for routine activities no patient required glasses, whereas for near vision 5 patients required glasses for reading books or the watching television. Subjective depth of focus curve for uncorrected binocular visual acuity showed that the defocus curve was smooth and wider with visual acuity better than 0.2 logmar from 0.5 diopter defocus to minus 2.25 defocus level, suggestive of good visual acuity or up to a defocus range of 2 to 2.5 diopters. This, when compared with objective depth of focus as measured on eye trace, showed binocular effective range of focus of up to 2.2 plus minus 0.63 diopters. In terms of vision quality, 3 patients reported glare and halos, where 2 patients had only mild glare which was intermittent and didn't cause any difficulty in their daily life, whereas 1 patient reported moderate degree of halos during night driving despite good visual acuity without need of glasses. Mean stereo acuity for near was 64 plus minus 15.3 seconds of arc. These are the few examples from our study where in this patient there was ametropia of 1 diopter and binocular vision was good with achieved effective range of defocus of 2.46 diopter, and patient didn't require glasses for any of the distance without any complaint of halos and glare. Similarly, this is another patient with ametropia of around 0.95 diopters, and patient was satisfied with complete spectacle independence and effective range of focus of around 2.1 diopter. The subjective defocus when also coincided with the objective
Just
defocus
last
curve
slide.
of the
Yeah.
eye trace. So to conclude, this newer enhanced monofocal IOL is an optimal
Yeah.
for intermediate distance without impairment of visual quality, which if combined with monovision can extend the range of vision to a greater extent at an affordable price, and is also a good option for patients with ocular or systemic diseases such as diabetes, hypertension, where multifocal IOL is not preferred. Thank you.
Yeah. Thank you. Sorry for the glitches. I mean,
I know you.
yeah.
Sir,
Any
thank you
question?
very much. It was a very nice presentation. The only problem is the companies tell you that the lens behaves like this. It has got bicurve and tricurve and multifocal and trifocal. But you have promised the patient that this is going to happen this way, and if it does not happen, who is going to be blamed? You are going to be blamed. You said that you will see the far vision. You said that you'll have a near vision and an intermediate vision. If that does not happen, you had it. So whenever we counsel the patient, we must counsel the patient accordingly, taking care that anything can happen. Any can go a little upside or downside, and patient may have this kind of problem. So what I generally do is I ask the patient that, look, in 90% of the time this thing happens. In 10% it may deviate. So we have to be little careful about while counseling the patient, because it may not happen exactly the way the company has promised you or the company has shown in the literatures.
Yeah, I think the counseling part in these patients is very important, because there is a plethora of EDOF available to us, ranging from 0.5 to 3 diopter of extended depth of focus. As the EDOF increases, the side effects of the photic phenomenon is much more common in refractive type of EDOF. So we have to discuss with the patient depending upon his professional needs, requirement. You have to counsel the patient before surgery. Otherwise, they are not going to be satisfied. If they are more worried about the photic phenomenon, maybe it's a better idea to put these EDOFs which are tweaked with the spherical aberration rather than a diffractive type of EDOF IOL. So counseling part is very, very important in these cases.
Yeah.
Like in BPT, we have also done a study comparing the BPT with the IC, and the mesopic contrast of the noble non-diffractive IOL, that is BPT, is significantly less than IC and other monofocals. So the patient before at the time of counseling must be explained that the mesopic contrast sensitivity is less, and of course it is good that trifocal for night drivers that does not have that amount of halos and glare, but mesopic contrast is less. And the other thing is that the pupil size does affect the post-operative outcome of BPT. If you have a large pupil, young patients, you have a resting room size, light condition, if the pupil is more infiltrated, just pick up a IOL power targeting 0.5 diopter might be. If it is 2 millimeter pupil, the radiometropic power will have a post-op iris. If you do this diffraction, you will find everything normal or post-op. But the two things are very important: mesopic contrast and pupil size.
Yeah.
Taken very well. Taken very well.
Yeah, that depends upon again the modulation transfer function of these IOLs. We have so we have to explain. I mean, counseling part is very important.
We'll proceed to the next speaker, none other than Dr. Rohit Om Prakash sir. Please give your talk. He'll be talking on subluxated cataract, some pearls. His pearls are very important and known all over the world. Welcome, sir.
Hello. Yeah. Thank you, sir, for the kind words. And I would like to thank Dr. Vinod Arora for the invitation. So I would be taking up some part of subluxated cataract, the pearls in use of hooks and rings in subluxated cataracts. So whenever we are talking of subluxated cataract, the basic fundamentals we have to realize, and these are: first, conserve the intact zonules; second, complete the different steps of phacoemulsification; and third is implant IOL with back fixation to the sclera. So I'll be primarily taking up the first two steps. So let's see a few videos. Let's see this video. It has zonulopathy of more than 180 degree. Site of incision was very important. It had not to be on the area where there was zonular dehiscence. And after instilling viscoadaptive, the initiation has to be farthest away, so that you are putting less stress on the zonules, and it had to be towards the area of zonular dehiscence. I continued as long as I could, and then I realized that enough was enough. I have already overdone it. So I introduced artificial zonules in the form of capsular hooks, which go right up to the equator, and this was introduced right across the area where capsular rhexis had already been done. Then after immobilizing and after creating, the rhexis was completed. You will see that the rhexis was centering the lens rather than the pupil for that matter. Now the fourth capsular hooks is in place. Then comes the hydrodissection, measured one was done. CTR implantation is very important in these patients. It had to be from the area where the zonules were intact to the area where the zonular presence was not there. Definitely we should not try to, it would have been better had I introduced it in the clockwise manner, but nevertheless it served my purpose and I continued with phacoemulsification, and these were the pearls which were associated with this video whatsoever. So I'm just re-inflating the bag. Next is another video wherein I would like you to see, now you will see that I have not introduced anything till now. Now what was the basic cause of my not introducing? Well, the basic cause was that there were three things which I could have done at earlier stage. I could have used the capsular hooks, CTR, and used the nucleus scaffold to the advantage. Now what is this nucleus scaffold? You will rewind and you will realize when these hard nuclear fragments were in the area of zonular dehiscence, they were providing an anterior, posterior and a horizontal support. So the most important thing for the use of the nucleus scaffold is that it has to be a hard nuclear fragment, because then only it will be able to provide a three-dimensional support. So once that was done, so this helps in delaying the introduction of CTR. Had it been a soft cataract, I would have definitely, this is an older version also, I would have used capsular hooks up front, because those help to delay the insertion of CTR, because CTR insertion early on has quite a few problems associated with it, which I would be talking about as and how I move. Site of incision farthest away from the site where the the zonular dehiscence is there, a calibrated site port incision, rhexis initiation towards the area of zonular dehiscence, centering the the lens rather than centering the pupil for that matter. Here I found, since it was a traumatic cataract, that I was able to continue without putting any less stress to the zonules, and I could continue the rhexis by all means. And here you will find mild hydrodissection being done. Capsular hooks have been introduced, and once these capsular hooks have been introduced, I am delaying the insertion of CTR in this patient, and I can delay it as long as I want till I find that I am reaching a situation where if I don't introduce capsular hooks, it can create problems. So in my surgical procedures nowadays, only in soft cataracts, after using capsular hooks, I introduce CTR. So next we move on to another video wherein I would like to you will see again in this video the site is farthest away. Site of insertion, site of incision. Now let me show you how CTR is being introduced. CTR here is being introduced from the area where the zonules were intact. So you should definitely not introduce where the zonular dehiscence is there. There is only one exception to the rule. If the zonular dehiscence is less than 90 degrees, in that situation you can introduce the CTR even from the area where the zonular dehiscence is present. So this is what I would like you to see. So you can use capsular hooks, the capsular rhexis forceps also to provide support, but this is not my preferred technique. This only Chi Soon Fake is doing, wherein she is using the second capsular forceps to act as to provide immobilization of the bag. This is another case where I would like you to see. You can see the the site of incision is farthest away. I'm using a pointed tip to create an opening in the anterior capsule. I'm moving it, and you will find how much stress I'm creating to the bag. So I will go around 2 clock hours and then insert the capsular hooks. The trick in this situation is you go across 1 clock hours, and prior to the end of the flap, you introduce the capsular hook. So I've introduced 2 capsular hooks. I'll go farther along, go around 2 clock hours, stop it here, introduce capsular hook, so that I'm able to immobilize part of the bag, which is previous to that, to the point where the end of the capsular access flap is, and it is going to continue, and I would be able, yes, another capsular hook coming into force. So I have immobilized 3/4 at that area where the zonular dehiscence was expected. So this is what the trick is, and this is what the great Dr. Kumar doctor shows. If you find, you could see those capsular striae were there. If by any means you find the capsular striae, you will find in that case, if you use CTR, that provides the capsular support. So capsular tension ring also helps in cases where there is a posterior capsule striae. Iris hooks, a big no, because they just give you a false hope. But then situations where you do not have capsular hooks, it's better than doing nothing. So iris hooks can be planned. So what are the factors influencing timing of CTR insertion? Capsular hooks I've shown. If the lens density is soft, then capsular hooks, then CTR implantation should be done with capsular hooks, because in the area between the 2 capsular hooks, because of the fluid, because of the aspiration, you can eat away or you can emulsify the capsular bag in that area. So in soft cataracts you can. So early CTR implantation, visco dissect 360 degrees, but then you have to realize it is more traumatic. So the click in all this story is that capsular tension ring implantation should be as late as you can and as early as you must. Thank you very much for your kind attention.
Thank you very much, sir. It was a nice presentation, and we have learned a lot of new tips. Sometimes it is difficult for CTR to put in. Sometimes the CTR slips away from your Sinski hooks, or sometimes it gives way when the forceps, it slips away. That is point number 1. And point number 2, the animation you had shown in the first place about 2 forceps. So it becomes very, very crowded to manage holding the capsule and doing the rexis.
Absolutely correct you are.
Yeah. And sometimes when you are using capsular hooks, while doing the phacoemulsification, when there is a intraocular pressure little increases by the flow of saline or BSS, sometimes this capsular hook gives way. So you have to be very, very careful. Keep on watching where are the capsular hooks. That's very important.
Yeah. So what was the first point, what you said? There were so many points in it.
So 2 instruments. First point was 2 instrument in AC is...
Yeah, absolutely. This is one of the most difficult thing, which I already said. It's only Chi Soon Fake who does it, wherein she used, the 2 capsular access forceps. But then, taking the aid of capsular hooks really helps, and that is the click in the whole story, because those immobilize the bag, provide anterior-posterior support, and that is the click in that, the most important part. And as far as, when you are implanting the CTR, the one part of the question was, definitely an automated system, with the injector is less traumatic. But then, in Indian conditions, it is very expensive. That is the most important factor. The second important factor is why it is very important, because that gives way because of OT assistants not being careful. So if you have to use CTR, some people advocate using CTR through the side port incision. Well, in my case, I showed 3 or 4. The most important click is that you have to gradually dial it in. That is the first click. The second most important thing is that the bag should not be shallow, and it should not be overly distended also. So those are the 2 clicks when you have to implant a CTR through the main incision. And if it happens to be a 2.2 millimeter or a lesser incision, that makes it more difficult. A 2.8 millimeter incision makes it better to put a CTR through the main with adequate depth of the AC.
So thank you very much. We are not taking more questions because of scarcity of time.
Yeah.
Thank you.
You're welcome. Thank you very much.
Since you're a very expert person, excuse me, sir, one very important question. you have shown a lot of cases with subluxated lenses, but there are some subluxated cases where the anterior vitreous is disturbed and it comes to the anterior chamber. Then your management is going to differ.
Absolutely. You know, the most important thing is triamcinolone staining is obligatory and mandatory at the start only. And if there is vitreous, you have to clear it up. The more important thing is herein you have to go through the posterior route, because when you go through the posterior route, the whole vitreous gets aspirated from behind. Doing it through the anterior approach is slightly tricky because you are not able to clear off the vitreous. So triamcinolone staining is very important in these patients to exclude or to see whether the vitreous is present.
Thank you.
Excuse me, sir. One question, sir. Iris hook and capsular hook are both are same or they are the different?
Sorry?
Iris hook and capsular hook are the same or
no? They are absolutely different. Iris hooks, they don't go. What is the basic concept? Let's try to understand. The basic concept involved is whenever you are using these hooks, or be it the iris or the capsular, which we have to decide, we want to provide immobilization of the bag, and it should go right up to the equator. Iris hooks, they do not go right up to the equator. They just tent it up. Only the capsular hooks go right up to the equator and they act as artificial zonules. Iris hooks should not be used.
Okay, thank you, sir. Very nice. Yeah, nice presentation.
Thank you.
Most important reaction should be proper
Now
do the every step towards the
come to the
intact
last
genule, from the
presentation.
side of the intact genule. Thank you very much.
Now we come to the last presentation of this session. Listen to Dr. Gaurav Luthra, what he has to say about laser vision correction.
Thank you, Dr. Oli, sir, and a wonderful presentation by Dr. Rohit. Those are micro graspers, MST micro graspers, which Dr. Chi uses. They are not micro rhexis forceps. They are micro graspers, so they are very less traumatic, and you can hold the bag with them. Yes. But wonderful videos, sir. So I'll be talking about laser cataract surgery in challenging situations, and I think it's very appropriate because what Dr. Rohit sir was showing, those amazing videos with so much control where he was doing the rhexis in those subluxated cataracts, they are highly amenable to good rhexis, very easily done with the laser, and those are one of the prime indications for using laser cataract surgery amongst the various challenging situations where laser surgery has become useful. So sharing one of them, this was an indication which many people might think is not a great indication for doing femto-assisted surgery, is post-RK eyes. And I get to do a lot of post-RK eyes which have very flat corneas and very difficult to get suction on them, and of course multi-cuts on the cornea, and you might think that because of those cuts the laser will not make a continuous capsular rhexis, but on the contrary these eyes are ideally suited for laser assisted cataract surgery because rhexis in 99% of the cases is almost complete, or it can be completed just by tugging it a little bit, and you have to be just careful that your direction of tear is correct. And why it's useful is because you can see here that the cornea is so flat, and usually the chambers are deep, and RK eyes have very deep chambers. They are usually high myopic eyes. So you don't want many manipulations in RK eyes when you're doing your cataract surgery, especially lateral separation, forces of doing a rhexis inside these big eyes. All manipulations which happen through the sections will put stress on the incisions and lead to incisions opening up later on, and then you might have to suture them. So when you have pre-done several of these steps like the good capsulotomy and good nucleotomy, the forces of required inside the eye are so much less, especially because the direction at which your instruments are going in is going to be almost vertically down, because these are big eyes and you stretch the incision a lot. So when you go into a deep eye and doing lateral separation of the nucleus, your forces of both the instruments, the phaco handpiece and the chopper, will be almost vertically down, and you are stretching the incisions. So that's why I realized that for RK eyes this is a blessing, and the trauma to the incisions is much less. And of course you have to be a little careful. So let's see here, this was an RK operated eye where we managed to get this out of the way. It was a fairly hard cataract, and you'll see that there are lots of cuts. I get to do at least 1 or 2 RK operated eyes every week and I end up using the laser if possible. And of course, these incisions, there's almost no place, so you tend to make a limbal incision or even a scleral incision sometimes. And I use a 2.2 incision, so very often, it becomes difficult to find a place where to place your incision. And as you can see, these incisions are the RK incisions are so close that just the forces of your phaco handpiece insertion and removal, and those small movements inside will put so much stress on these incisions that you will end up needing to suture them later on. And but if you've done a femto-assisted surgery, the requirements of operative maneuvers inside the eye become much less. So anyway, here, in spite of our best efforts, we did get this cataract out, and I think this particular case we did have to eventually put a suture, and one should not shy away of putting a suture. In fact, most often my incisions will get stretched only at the time of IL insertion, because that's one place where you can't help it. The IL has to go inside, and your incision will tend to get a little stretched. So I don't remember whether this particular case I sutured or not, but definitely it was a hard cataract, and here femto did play a very great role, and the rhexis is not much of an issue. And in these eyes, because it's difficult to seal the wounds, I usually do a trypan blue test to check for the integrity of the wounds, and put a drop of trypan blue to see if the wound is leaky, and that helps you identify any small leaks. I prefer, especially I do a lot of pediatric cataract surgery where this is very useful, not laser but the trypan blue test. Now this was another situation like Dr. Rohit was showing. When you do a rhexis in these dangling lenses, you tend to pull a lot, and you increase the amount of zonular dehiscence that you might cause. And if you do a femto-assisted surgery, you can actually be very atraumatic in creating the rhexis and not increase the amount of, and I think Dr. Rohit didn't purposely show, he does a lot of femto-assisted surgery for his subluxated cataracts as well. I've seen some excellent videos. So this is one good indication. In this particular case, of course, the main thing to show was that, doing the femto-assisted rhexis for a subluxated cataract. This was about 3 to 4 clock hours of subluxation, so it was easily managed with a CTR. We didn't have to fixate the bag. And then of course this patient also had a traumatic mydriasis, so we went ahead and did a single pass 4-throw pupilloplasty, I think if I remember correctly, yes. So here we are doing a single pass 4-throw pupilloplasty that really helps in these big eyes, in these big pupils which are refractory. And I use the 26 gauge for my technique, where I use the cattle tracking kind of a thing, or where I use, rather than hold it with the forceps, I tend to just stabilize it with the needle. It makes life much easier, and then you can complete the pass, and once you've completed the pass, you can quickly tie it and make the pupil much smaller, and if you want, you can make a second one as well. So going on, this patient had a very small pupil, and here we utilized phenocane to make the pupil a little larger. So some of these eyes now, because you don't want a big incision, so putting in a Malugin's ring or a B-hex, you require a little bigger incision. So I tend to use phenocane and see if the pupil will dilate beyond what it dilated with tropicamide and phenylephrine. Sometimes the pupil will dilate well, and then you can use femto-assisted surgery again for such eyes. So small pupils are also amenable, and you can increase the size of the pupil on the laser machine to a little bigger than what it detects, and then get a good rhexis. If I get a 4mm rhexis, I'm happy. It allows me to complete the surgery fairly well. And it has been a savior in some situations, especially very small eyes, small AC depths, high hyperopes, where the risk of iris prolapse is very high and upthrust is very high. If you get a rhexis in these small eyes, it makes life much easier. And these are another indication where I would prefer to use that. Now this was another patient who had a big coloboma here. It's a patient with a coloboma and a lens coloboma as well. So the laser will detect these eyes fairly well. And you can see here that the lens is missing over here besides the iris. So of course the detection of the landmarks may be a little difficult in such eyes, and however you have to change those landmarks a little bit because the laser may not detect them correctly, and again becomes much easier to go through with these eyes. Let me take you to the point where we went through with the surgery. So again, because of these bags which are quite mobile, there may be zonular laxity. Having the pre-cut or pre-chopped nucleus becomes much easier. The stresses on the bag are much less, and I'm here using a preloaded CTR injector. I was going to tell when Dr. Rohit was showing. These have become available. They are very cheap. They are from Madhu Instruments, and I use these quite a lot, and they come in various sizes and both sides, like right and left injection. Sometimes they malfunction, so you have to be careful. Sometimes when they reach the end, they will not disengage, so you have to be careful, and you have to use a second instrument to ensure. So, but they are obviously much cheaper than those very expensive injectors which are titanium and which come from the international companies. They are not available in India. But these our own disposable injectors from Indian companies are nice. I think 1,000 rupees or something is what they are charging, or something less than that. But I found them very useful. But here we've removed. We've managed this, and I'll bring you to the end of this surgery. Here we were going to place a toric lens as well. So getting an atraumatic surgery. There was a small bead of vitreous which under infusion I just snipped it. And I think sir was talking about vitreous presentation during these subluxated cataracts. You have to manage it with triamcinolone, as sir said. And here, of course, it was visible nicely. It was floating around in the anterior segment. So we were able to do this surgery fairly well with femto-assisted. It makes more predictable, and life is much easier. I'll come to my last case. Sometimes another big indication for me is intumescent cataracts. So let me just take you to the last one. This was one patient with an ICL with an intumescent cataract, where we had to bilateral cataracts. ICL done 5-6 years back, got bad uveitis in both eyes during COVID times, post COVID, and came back with very bad fibrinous uveitis in both eyes. Was treated over 6 months, was lost to follow up several times, finally went on to develop a cataract. So there was a young lady, and we had to do this thing, and there was a PI done with the YAG for our Iris Bombay, which became so big later on. Anyway, so for this eye, and since I'm out of time, I'll just show you a quick video. We had to explant the ICL. We did it under infusion because I wanted to stain the capsule, and I don't like viscoelastic inside when I want to stain the capsule. So under infusion in the left hand, I was able to negotiate the ICL out of this rigid pupil, and then stained the capsule, and then explanted the ICL. I have not introduced viscoelastic so far, and now I've introduced viscoelastic, and I want to decompress this lens. So just see, as I go to decompress the lens, it goes into a flag sign. And this is one big issue with intumescent cataracts. They do what you want, sometimes do an aspiration, do whatever you want, spiral rexes, puncture-rexes. Sometimes if they have to just burst, they will burst. So I found the femtosecond laser as a very useful tool. So for the second eye of this patient, we use the femtosecond laser, but the problem with the ICL is that it will be difficult to detect the landmarks. So the laser does not know that there is an ICL inside. It detects the ICL as the anterior capsule. So you have to reset the landmarks, which I did here. And after that, doing a femto-assisted rexis under the ICL is a great way to get the rexis done. And once that is done, it becomes much easier to deal with these cataracts. So I'll finish by showing you the last part. And here we've done the rexis under the ICL, explant the ICL. So this has become another indication for me to get these eyes out. And so laser has its role in many tough situations, and it saves the day. Pseudo exfoliations, very shallow chambers, intumescent cataracts. I think it has really worked well for us, and I enjoy doing it for many of these indications that I showed you today. Thank you.
Thank you, Dr. Gaurav. In situations like hard brown cataract, small pupil, raised intralenticular pressure, and posterior polar cataract, white cataract, subluxated cataract, probably this is the list where the laser cataract surgery is helpful to us. We'll take up only one question before glaucoma session. Anybody?
Thank you, Gaurav. Very nice presentation.
So what I meant is that the manipulation, the docking is 99% not difficult. It's only in a rare eye where docking will be a little difficult. So I think the number of manipulations inside the chamber is minimized by 50%. So cracking a hard nucleus and doing a rexis, or everything that you do inside requires you to go through the incisions, right? So and every manipulation you do through your side port or your main port is going to stretch the incision a little bit. So I find that my incisions, I make my incisions with a regular blade as well. I don't make femto incisions on the cornea. You can't, in RKIs you can't make femto incisions. So when you're making these incisions, you are anyway very close to those RK cuts, or maybe even going through them. So the number of things that you can minimize, the phaco time, the amount of time spent trying to chop the nucleus, break it into two and rotating and everything is minimized, So the time inside the eye is just about 2 minutes. So, obviously, and the number of maneuvers are much less. So I've realized that I used to do a lot of RK when I didn't have the femtosecond, and I do a lot. I used to end up suturing my incisions more often before, and I hardly have to suture them now because my incisions are mostly left very clean even after at the end of surgery. That's the difference I think it's made. Yeah.
So thank you, Dr. Gaurav. I think glaucoma guys are becoming now impatient. We are almost 10 minutes late, and that's the best I could do with this session because there was initiating was an issue. Please take over, Dr. Madhu et al.
I'll request Dr. S.S. Pandav, Dr. Madhu Bhadoria, Manavdeep Singh, Dr. Rajesh Tiwari and Shalini Mohan to take over, please.
Hello, good morning everybody, and we are already late, so I think we'll start right away with the session. And we have Dr. Madhu is gone to the other hall. She had another lecture actually, so she'll come back after her talk. Dr. Manavdeep Singh is with me, Dr. Rajesh and Dr. Shalini. So we are all here, and I welcome you to this glaucoma session. I think we are already late, so let's start with the first session. The first talk, Dr. Madhu will be taking later. I think we can start with Dr. J.S. Bhalla. Dr. Bhalla, are you ready? Yes, please. So, Dr. Bhalla will be speaking to us about glaucoma suspect, workup and confirmation. All the speakers, please stick to your timings. Dr. Bhalla, please.
Yeah. Thank you, sir. At the outset, I'm thankful to Dr. Gaurav Luthra and Dr. Vinod for having me here. I'm going to talk on workup of a glaucoma suspect. As we all know, glaucoma refers to a group of diseases having common characteristic of progressive optic neuropathy with associated visual field loss, and raised intraocular pressure remains the single most important modifiable risk factor. So what is a glaucoma suspect? It's defined as a person who has one or more clinical features or risk factors which increase the possibility of developing glaucomatous optic neuropathy in the future. So glaucoma suspect really means that there is not enough evidence to label it as a patient of glaucoma. So is defined as an adult who has one of the following findings in at least one eye: either disc suspect, that is disc findings suggestive of glaucoma, or visual field abnormalities suspicious, or elevated intraocular pressure greater than 21 millimeter mercury, also labeled as ocular hypertension. And usually if two or more of these findings are present, diagnosis of POAG is supported. So Shields textbook defines it as ocular hypertensive with IOP more than 21 millimeter of mercury, as they have higher risk of developing POAG. Chandler and Grant label it as glaucoma suspect as a patient who has early OAG without damage, and Schaeffer consistently elevated intraocular pressure more than 21 millimeter plus optic nerve features suggestive of glaucoma with suspicious visual field defects. So two varieties, open angle glaucoma suspects and angle closure glaucoma suspects, and open angle glaucoma suspects could further be subdivided into OHT or NTG suspects. So POAG suspect, the clinical finding which I already labeled in my previous slides. What is the incidence? In specialized glaucoma clinic, about 1/3 of the patients attending, and for general ophthalmologists, they make up to half the glaucoma patients seen. So glaucoma suspect has been classified as type 1, type 2, type 3. Type 1 is the one with normal IOP and no damage, and if they have risk factors like strong family history of retinal vascular occlusion, exfoliation, angle recession, pigment dispersion syndrome and other factors, then how do we manage? We monitor them periodically and inform the patient of need for regular follow-up. Type 2 is the one with normal intraocular pressure and possible damage, and if they have these factors like thin cornea or suspicious disc, RNFL or visual field, then we confirm the findings by repeated testing and if needed with suspicious visual fields, and if the patient demonstrates increased intraocular pressure with these visual field changes, then we treat them for glaucoma. Type 3 is the one with high IOP and no damage. And how do we manage these patients? If they have IOP more than 35 millimeter mercury, then since the risk of damage is great, we definitely do treat these patients. And if IOP is between 25 to 30 millimeter of mercury, we treat if the other eye has damage or these risk factors are present as labeled here. And if IOP is more than 25 millimeter of mercury and very narrow angles, then we can undertake laser iridotomy in these subgroup of patients. Type 4 is the one with high IOP and possible damage. How do we treat these patients? If they have pass and narrow angles, or if there is notching, local rim narrowing, early arcuate scotoma, then we generally treat such eye, especially if the other eye has damage. So what are the risk factors associated with POAG, which we have been talking about in these slides? Based on epidemiological investigation, clinical trials, one is age, which older age more than 70 years, there is family history, thin central cornea, high myopia more than 6 diopters, disc hemorrhage, large CD ratio, higher pattern standard deviation, history of retinal venous occlusion, steroid use, history of ocular injury, low ocular perfusion pressure, systemic illness like migraine, diabetes, hypertension, and race is also another important factor. Since high IOP is the single most important modifiable risk factor, it was found in OHTS that 1 millimeter mercury increase in IOP was associated with 10% increase in relative risk of conversion to POAG, and this study also found that 22% decrease in IOP in the treatment arm versus 4% in the control arm was associated with decrease in the development of POAG from 9.5% in controls to 4.4% in the treatment group. Family history is another important factor as stressed by the epidemiological and genetic studies. History of retinal venous occlusion, they pose additional risk factor in patients labeled as glaucoma suspects. Disc hemorrhage, presence of disc hemorrhage in a patient with OHT increases the risk of conversion to POAG by 6 times by univariate analysis and 4 times by multivariate analysis. And epidemiological studies like Blue Mountain Eye Study, Barbados Eye Study, and Beaver Dam Eye Study have found positive association of POAG with increasing degree of myopic refraction. Studies have shown that higher prevalence of PACG in hyperopic individuals, especially when above 2 diopters. Age is another important factor which I have labeled, and central corneal thickness was found to be a powerful predictor for development of POAG in ocular hypertension treatment study, and relative risk of POAG increased by 81% for every 40 micron thinning of the cornea. These are various conversion tables which I do not normally use. I just see whether the patient has thin cornea or thick cornea and accordingly modify my treatment regime. Corneal hysteresis has been found to be another biochemical parameter besides central corneal thickness to be an important factor. And what is the importance of optic nerve head signs? The table on the right suggests that of the various findings in the disc, neuroretinal rim notch, diffuse or concentrically thin neuroretinal rim, RNFL defect, and disc hemorrhages are very strong predictors for development of glaucomatous optic neuropathy in these subgroup of glaucoma suspects. So stereo photographs of optic discs are ideal, or you can just draw disc diagram whenever the patient comes for follow-up. Yes, automated perimetry needs to be done, and these are the various field strategies. We have to remember few important things in visual field changes. Visual field defect which appears suddenly is unlikely to be glaucoma. In such cases, rule out conditions such as anterior ischemic optic neuropathy. And since perimetry remains a highly subjective test, on average 3 visual field assessments should be done in the first years, and progressive visual field loss is the hallmark sign which separates a true pathology from glaucoma suspect. So screening IOP value of more than 21 millimeter of mercury, please do skilled optic nerve examination, do perimetry, and the SWAP and FDP was supposed to be early predictors of than the standard automated perimetry. So IOP, optic nerve diagram, and visual field is very important. So workup of glaucoma suspect, I'll just summarize. So history taking, clinical evaluation, and investigations. So risk, based on the findings of the patient, risk assessment of developing glaucoma is derived. Clinician and the patient can together decide if the risk warrants the inconvenience, cost, and potential side effects of the therapy. Risk and morbidity of therapy should not exceed the risk of the disease. Additional factors that may affect the decision to start ocular antihypertensive treatment include patient desire, compliance, reliability of fields, and ability to examine the optic disc. And when we have to treat depends on these factors. So stratify your patients. If the patient has high risk, suggest treatment initially. If moderate risk, can initiate the treatment. If the risk factors is present, or monitor closely, and if low risk is present, monitor IOP as well as optic nerve structure and function, and treat if evidence of progression is there. So Possible indication of treatment are in these glaucoma suspects: one-eyed patients, young patient with high pressure for many years, case with strong evidence favoring glaucoma like disc notch RNFL defects, thin cornea, retinal venous occlusions, inability to have timely follow-up, glaucoma in other eyes, IOP more than 28 millimeter of mercury, high diurnal IOP variation, compromised circulation, and patients who is better off with starting treatment. And what drug to be used in these patients? I think my drug of choice is prostaglandin, as it decreases the pressure by about 35% and also offers the diurnal decrease in intraocular pressure. So if patient is left untreated, what should be the follow-up protocol? Do IOP, diurnal IOP at the baseline and repeat every 6 months, objective record of optic nerve head by photographs, and perimetry, 3 perimetries as a baseline, and every 6 months or yearly thereafter. Thank you everyone for your kind and patient hearing.
Thank you, Dr. Bhalla. I think you have covered a lot of ground as far as glaucoma suspect is concerned, but I'm sure there would be some questions. But to save time, probably we'll take up the questions at the end of the session if time permits us. One quick question I'll entertain, however, till the time Dr. Shalini is setting up her slides. Dr. Shalini, next speaker, please. Any one quick questions? Okay, then we'll go to Dr. Shalini. Dr. Shalini is talking about decision making in glaucoma.
Thank you so much, sir, and good morning, respected chair, and good morning, delegates and speakers from all over the country. At the outset, I would thank Uttarakhand Ophthalmic Society, Dr. Vinod Arora, Dr. Gaurav for giving me this opportunity to talk about decision making in glaucoma. So we know that glaucoma is second most important cause of blindness in the world. Now, important thing is what we tend to miss several times, especially in our busy clinics, is history and examination of risk factors. As Dr. Bhalla was just now emphasizing the risk factors, we should try to make the list of all the risk factors which can be associated with glaucoma, because they tend to bearing on the treatment in patients of glaucoma suspect. So suspect, he already talked about, whenever there is an elevated intraocular pressure, suspicious discs, abnormal visual fields, or an abnormal appearing angle, or combination of any of these, then we have dilemma in our mind that when to treat. Now regarding the disc factor, whenever we dilate the patient and we see the disc, there are several things which we tend to note, and especially disc size is very, very important, because whenever we are examining the disc and if we tend to ignore the disc size, then it's a problem, because we know that the larger disc has a larger cup, and we should note this important finding. Moreover, whenever we are looking at the neuroretinal rim, it is another very important factor to look at it, especially if there is any deviation in the inner margin of the neuroretinal rim. If like the lower rim is thinner, then definitely there is some problem, and if you have an associated notch with it and you see associated RNFL defect, then most likely we are dealing with a case of glaucoma, and we cannot miss this very important finding. Now another important factor is that we should always dilate the disc and see and do the examination, because sometimes in non-dilated people we might miss a small subtle hemorrhage like this, or do we have a pointer? Or sometimes a bearing of circumlinear vessels, as here we can see there is a superior bearing of circumlinear vessels which we might tend to miss. Now especially it is very important in cases of progression of glaucoma, because if there is enlargement of cup, then you might see that the bearing is enlarging, and then that can be a sign of progression. So we should note it down also, and if we can take a fundus photograph, that is the best we can do. This is the disc hemorrhage, and again a bearing of circumlinear vessel. This is another large disc hemorrhage, but smaller ones, they can be missed. Another important, very important thing is about the color of disc, because if there is pallor which is more than the cup, then definitely we should look at it, because it is definitely going to be some other cause or a neurological cause if there is pallor which is more than the cup. Now coming to American Academy of Ophthalmology algorithm for treating a primary open angle glaucoma suspect. So whenever we have suspicious disc, there are 3 categories which can happen: a normal intraocular pressure, an elevated intraocular pressure, or in between the two. Well, if it is a normal, then obviously we are dealing with an NTG suspect, and if it IOP is 28 or more, then we need to treat these patients. Now what will happen if we have a patient which is in between? we need to do a visual field examination, and that at least two visual field examination. If they are normal and there are no risk factor, then probably it is a physiological cupping and we can follow up these patients. But if 3 or more risk factors are present or there is a visual field defects, then we have to treat these patients. Now if IOP is less than 22, that is a NTG suspect, and there is a disc and a suspicious disc and an open angles, then we need to do a dial nerve variation. This is another important thing which we tend to miss, but in places where we are like for private practitioners, office dial nerve variation is another good option which can be done in several days time, calling the patient at different times, and then you can record these findings. So if abnormal intraocular pressure is present, then consider these patients as primary open angle glaucoma suspect. Now in NTG suspect, if visual fields are normal, you can go for imaging, but imaging is not a basis for starting the treatment. If imaging is abnormal, then these patients need to be closely monitored for subsequent problems in the disc or visual fields. But if imaging is normal, then obviously it is a physiological cup and we should not treat these patients. In cases where abnormal visual field are coming, then obviously we need to rule out the mimickers, because sometimes we might see a photograph like this where there is an optic disc pit, and which might give this pit which might give you an a diagnosis or a visual field defect. This is a morning glory syndrome, or here optic disc coloboma. So once you rule out these problem, and if the visual field is still abnormal, then you treat these NTG suspects. Now coming to primary angle closure suspects, if you have an occludable angle and there are signs of intermittent closure, that means if goniosynechias are present or peripheral anterior synechiae are present, or you find subtle iris rough atrophy or pupillary rough atrophy, then these are signs of intermittent closure, and then we can do YAG-PI in these patients. The important thing is, if you have occludable angle, there are no signs of intermittent closure, don't rush to do YAG-PI. YAG-PI is not required for all your patients. So just look for other signs also. Now if the angle deepens, you can treat these eyes as primary open angle glaucoma, but we need to be careful because there is anatomical problem which cannot be rectified. So we need to repeat gonioscopy whenever required at a certain interval. These eyes will never become an open angle eyes, but after YAG iridotomy, we can treat these eyes as primary open angle glaucoma. If angle doesn't deepen, that means we need to revise our diagnosis, then look for a double hum sign of plateau iris, and if it is present, go for iridoplasty. Now in case there are no signs of intermittent angle closure, then we need to observe these patients and follow up these patients. Now coming to decision making in target therapy. Before starting the treatment, we need to establish a target intraocular pressure for our patients as per the European guidelines. In cases where there is early glaucoma, that is mean deviation less than 6 decibels, the target intraocular pressure can be in higher teens. In moderate glaucoma, it can be in middle of teens. In advanced glaucoma, it can be lower teens, and in terminal glaucoma, it should be in single digit. Now to establish target intraocular pressure, there are certain more important factors which we should look at. Like I said about glaucomatous damage, if it is advanced glaucomatous damage, then obviously the target intraocular pressure should be on the lower side. Similarly, if the life expectancy of patient is longer, that means the glaucoma has been diagnosed at an early stage of his life, then obviously the target intraocular pressure should be lower. Now in patients where untreated intraocular pressure is low, again we should have a lower target intraocular pressure. If additional risk factors are present, we should have a lower target intraocular pressure. And then another important thing is rate of progression. If patient is having faster rate of progression, we should have a lower target intraocular pressure. I will skip this. So to establish the progression, it is important to have a trend-based analysis where we can, in newer models of Humphrey's visual field, it is present, and we should have at least 2 baseline visual field, and then subsequently it plots the visual field index against the age, against the years, and then you can, it also gives a tentative rate of progression. Here we can see the rate of progression is there, and we can actually assume that what will be happening throughout this period of time, whether the patient will actually go into the blindness or in the severe visual disability. So we can actually assess. Right, sir, right. So now, regarding medical therapy, we all know prostaglandin analogs are the drug of choice. In surgical therapy, several times we actually have to maintain a balance between risk and benefits of the surgery. So when to shift? So if there is unacceptable risk of glaucomatous progression, if we are unable to achieve target intraocular pressure, or there is poor compliance or adherence on the patient's part. So trabeculectomy is the gold standard, but in eyes where there is inflammatory glaucoma or secondary glaucoma or twice failed trab, where you assume that trabeculectomy it has already failed or is going to fail, tube shunts are good surgery to perform, but then you should be well versed with the surgery, and if not, it is better to refer to a specialist. Now, last word about PACG with cataract. There is always a question arising whether we should go for only cataract surgery or not. Now, this is guidelines from World Glaucoma Congress that whenever there is a mild cataract with mild to moderate glaucoma, we can go for cataract surgery alone. But in cases of advanced glaucoma, we should always go for combined surgery, and we should never resort to only cataract surgery. So, to end, I would say that though our current tools and understanding might be less perfect, but by applying them effectively to our patients in clinical decision, we can preserve the visual fields and vision of our patients. Thank you so much for your kind attention.
Thank you, Dr. Shalini. Now I invite Dr. Ina Chaudhary. She is a prolific cataract glaucoma surgeon, and she is from Noida, from Eye Care.
Thank you so much, sir.
And, just a quick comment on the previous talk, that the two hallmarks of glaucoma diagnosis are progression and asymmetry. So whenever in doubt, without treating, follow up the patient depending on the risk factors, how closely you have to monitor. So do not start the treatment unnecessarily when it is not required. So follow up, because this disease is very slow progressive. Delay of treatment, except in advanced cases, whenever you are in doubtful cases, in very early cases or suspect cases, a delay of 2 months, 3 months, 6 months, even 1 year is not going to matter much. So please follow them up and only then take a decision, because it's a lifelong decision. Thank you, Dr. Ina. We will have questions later.
Yeah.
(22 and 25 pressures are at least should look at the disc of the patient. Suppose disc is absolutely normal, then we should never start treatment. You can do a pachymetry. If pachymetry is also normal, that means that amount of intraocular pressure is not damaging the patient's eye. Ocular discomfort can be very commonly due to other factors like dry eyes, and it is very, very common. You just stain the ocular surface and you will see that there is significant amount of dryness, and that tends to increase with anti-glaucoma medication. In fact, several of the patients, they come to us in which they have been started anti-glaucoma medication for ocular discomfort, and they become even more uncomfortable with those medication. So it can, as Dr. Manavdeep very rightly emphasized, that patient is not going to become blind in a day with the glaucoma, especially with 22 to 25 pressure, and it is a lifelong decision. So before labeling the patient as glaucoma, we should be very, very careful, because it is not just the treatment, it is also going to affect the psychology of the patient. Not just patient, whole family, that this blinding disease has happened to it. So starting treatment just for discomfort, better to go for other medication, maybe a lubricants, which will help the patient more.
The short answer is that not to be treated at 22, 23 pressures. Everything is normal, but you have to keep in mind the angle closure disease. If it's a PSC, that would be a different story altogether. All right? Okay. One quick question, please.
I myself have a pressure. I keep a pressure of 23, 24. My family history is extremely strong. I have got 7, 8 members of the family, but I am normal. I don't have glaucoma. I am getting getting regular checkup, 6 monthly, 1 yearly, I don't have glaucoma. And the moment you tell even a person to even take a consultation about glaucoma, his quality of vision, quality of life goes down, because it's such a psychological pressure. Please do not start treatment unless must.
Yes, please.
So applanation tonometry is the gold standard, and it is always good to do applanation tonometry in all our patients. Now, for us it is easier because we can admit the patient and we can measure the pressure at various times. But in a private setup, patients can do office diurnal variation, where they can call patient at different point of time and then record the IOP and also mention the timings for that particular.
Right, you said the applanation tonometer, you are taking in a sitting posture. But see, actually ocular pressure rises mostly when you are lying down, and especially when your venous pressure is going up. So what do you do? Because you may find normal pressure with the applanation, and 10 hours patient is lying down. So that could be that particular, during that time the pressure may be going up. So how do you rule out the...
Your question is actually very valid. I think IOP pressure recording is not really perfect science. That's kind of a well accepted. So whatever we have, the standard protocol, most of the times they'll get on a slit lamp. There's a sitting or kind of upright pressure basically. This sleeping pressure we don't have for most of the patients, except...
We used to do Shear's tonometry in your...
Yeah, but the Shear's tonometry itself is very inaccurate, so it actually doesn't have
so that is possible in lying down actually, because the lying down pressure is very, very important.
We have actually applanation also lying down, like Perkins tonometers. We do
see,
that
because
for...
then you can use the Perkins
we
check
do
the
that
pressure,
for certain,
not the sitting posture.
certain patients, but the standard practice is on slit lamp, and that's in upright position. But your question is, I think your point is very well taken, and I think that's well understood. Next, please.
Shall I start?
Yeah,
next thank you so much. So basically, I'll be talking about OCT use in glaucoma diagnosis, and we all know that glaucoma is defined as chronic optic neuropathy, where the retinal ganglion cells and the nerve fiber layer is getting lost, and we also know the structural changes are seen before the field defects develop in our patients. And OCT has become a tool which is available to all of us in our clinics and can be very helpful, and even WGC has now said that, sorry I don't have this slide, that OCT remains a good tool to try and detect early glaucoma and also follow up for progression. As I was mentioning, that's a very important information that we need in our clinic when we look at glaucoma patients. What I want you to take you through this is that when you look at a OCT printout, don't just look at the green and red and yellow and decide what's going on. Please try and look at your parameters step by step. Make sure that the signal strength is good. Look at the retinal RNFL thickness map, which gives you a very good idea how thick is your RNFL superior inferiorly, which is the normal anatomical location for the thickest RNFL. This is basically nothing but a deviation map. It tells you that when you look at this patient's RNFL and compare it to the normative data, how different it is. More gray means more normal. Anything abnormal will flag out as a yellow-orange patch over there. Here you have the horizontal and the vertical cross-section taken over the optic nerve head, which gives you a very good idea about the three-dimensional you can imagine as to what the cup is looking like. You also have the 3.4 millimeter diameter ring that you have over here, where the RNFL is measured, opened up and shown to you as a 2D scan. This is where, very interestingly, in the new series, you have the neuroretinal rim being opened up and projected for both right and left eye. So really, really good information out here, because it's a neuroretinal rim, as Dr. Shalini said, what we are looking at, and not so much the cup. You have the retinal nerve fiber layer here again shown as right and left eye values. These are nothing but the averages in the quadrant and the clock hours, and then very interestingly you get the average RNFL thickness, you get the symmetry between the two eyes, and please pay attention, you have the disc area here. So if you have patients which have asymmetric disc size leading to asymmetric cupping, can also be picked up very easily on the OCT, and it gives you the vertical cup disc ratio and average cup disc ratio and the cup volume, which is another interesting value to look at, especially in younger patients, and I'll show you some examples to highlight that. You also have the GCC, where we are looking at, so we are scanning the central macular area, because we know 50% of the retinal ganglion cells are there at the macular area, and it can also help us detect early glaucoma, and sometimes in late glaucomas also the macular GCC can be helpful in trying to monitor progression. This is how the GCC printouts will look at, and please remember that the anatomical spread of the RNFL does not cross the horizontal raphe, and hence typical loss in the GCC will very often show you this tortoise shell appearance on the GCC, where what you have is, let's say the inferior GCC is getting lost, and because the RNFL stops abruptly at the horizontal raphe, the defect will have this very, very stark horizontal line showing up. In the advanced stages, of course, this might not be visible, and here again in the deviation map, the area which is abnormal gets flagged out. As I said, the WGA also, the consensus series says that OCT does provide a good objective and quantitative approach to detect and monitor glaucoma, and it is quite a valuable tool in our armamentarium. Please remember that in initial stages, the function might not pick up your disease, it's the structure that it will, and in very late diseases also sometimes the macular scan can be helpful. Nowadays, you can actually try and get a superimposed printout of both structure and function together, like you can see over here. You have the field report visible, you have the RNFL and the GCC map and the average quadrants and the clock hours, and they project it on this structure function map where the OCT values are reversed. The inferior values are overimposed onto the superior field and vice versa, which will allow you to understand if what you see as a defect in the field is correlating with the OCT damage or not. Can be quite helpful. Looking at some examples, as you can see, this patient is a glaucoma suspect. The left eye is clearly showing us some neuroretinal rim loss inferiorly and enlarged cupping, and let's look at what the fields look like. They look not too bad at all. Right eye almost nearly normal, some few scattered spots here and there. Even the left eye, we do have these two spots looking slightly depressed, about 25 is the sensitivity over here, so we're not very sure what's going on with that much of rim loss over there. Let's do the OCT, and what do you get over here? We get a lot of information which is confirming that in the left eye, if you compare, the bright RNFL inferiorly is missing, and you can see it in the deviation map. The neuroretinal rim here is getting lost inferiorly in the left eye, so is the RNFL dipping, and you can see that your clock hours are also picking up that defect. Look at the GCC. You typically have your inferior GCC loss also corroborating with your diagnosis that this patient has glaucoma and needs treatment. Let's look at again, just to superimposing these values, and you can see that these two depressed points are falling into the RNFL loss inferiorly, but they were so subtle that sometimes you need more information to confirm what's going on in this patient. So hence structural changes can sometimes be quite helpful in early or to just confirm diagnosis. Again, a patient over here which is looking like an obvious optic neuropathy in the left eye, and look at the difference here. You again have an inferior loss here, but look at the amount of field loss that this patient is showing. So sometimes the structural damage corresponding to what you see anatomically can be variable in different patients, whereas the right eye has some amount of superior maybe edge defect or early defect. And let's look at what the OCT is looking like. Left eye, clearly you can see the yellow-red RNFL is missing inferiorly here. The deviation map is picking it up, but also it's showing you some early RNFL loss superiorly, which we somehow missed in the clinical observation. But interestingly, you can also see the right eye, which we initially on the cursory look thought maybe it's okay, but you go back here, you can see there is an RNFL defect visible in the thickness map, also subtly being picked up in the deviation map, but the areas over here are green. So the important message to give you is that don't look at the green, yellow, red. Go step by step and you will not miss this defect, and come back to the fundus. You can actually also see this RNFL defect in the fundus photograph. But sometimes these are very subtle and you're not able to pick it up, and OCT can always help you detect these early defects. So the green disease, as I call it, that all that is green in the OCT not necessarily is normal, and all that is red in the OCT may not always be disease, and I'll show you that example too. Another case where you can see the right eye, the cupping is enlarged, the inferior rim looks lesser, and also there's a small disc hemorrhage, if you can appreciate, inferiorly in the right eye. The left eye looks more or less all right. Let's look at the OCT. OCT is quickly picking up the loss of the RNF. There is no red yellow areas here. You can see the deviation inferiorly. Please don't get taken aback by these green zones over here, because it's nothing but picking up the normative data and comparing it there. But if you were to look at the neuroretinal rim, you can see the right eye is dipping down here inferiorly, and so is the RNFL. So you know this patient has developed inferior retinal nerve fiber layer loss in the right eye. And if you were to do the field defect, you might find a defect superiorly or you might not. Left eye seems more or less all right, although generally the RNFL is not as thick as you would see in patients of this age. Just showing you how everything was getting highlighted here. This is an interesting case to see a young 14-year-old boy with Sturge-Weber with one eye pressures going very high, and look at this photograph, the right eye looks fairly healthy, and in the left eye what you have is a very deep cup which looks larger as compared to the right eye, but the silvery striations of the RNFL look fairly alright. What do we get in the fields? The fields are fairly okay, just a little bit of generalized depression in the left eye. Look at the OCT. You do have some artifacts. Sir, can I take 2 minutes? Can I take 2 minutes?
Please wind up. We're already running behind the time.
Yeah, so you can see over here the volume of the cup is very deep, and in young patients the lamina cribrosa can be quite not rigid and always bow back due to the pressure in the eye. This is interesting. I'll just show you one thing, that sometimes the eye, the disc might be torted a little, which means the retinal nerve fiber layer pattern when it's coming out is not the same when the eye is vertically straight. And in this area you'll see that there's a deviation showing over here, whereas everything else seems okay. What's the matter here? Look at the axis. This is the vertical axis of the disc, and in the left eye actually the axis is tilted by about 20 degrees. But the normative data doesn't understand that, because normally the RNFL fans out like this. So it shows you that this is abnormal, but this is not abnormal. If you were to look at the same patient, it's nothing but a torted or slightly oblique nerve in the left eye. So I'll skip all of it and just show you that even in glaucoma progression, you can see in this patient the field is absolutely rock stable. It's an ocular hypertensive patient, but you can see the retinal nerve fiber layer over a period of time is continuing to get lost, and the inferior defect is becoming more and more prominent, with the patient still maintaining good field. And this patient is getting treated, though, because of a very strong family history, but you can choose to monitor them and decide whether patients require treatment or not. There can be some red patches in the eyes which could be even artifacts, so everything that red should not be taken as a defect. As you can see, there's a large floater here, blink artifacts in the left eye. Everything that's red is not abnormal. This is a patient with toxic amblyopia due to the damage in the papillomacular bundle. That's why the temporal area is deviated from normal. But look at the healthy RNFL. So this patient does not have glaucoma.
Please wind up. No questions
Yeah.
we left for that question. Time will be left for questions later.
Thank you.
Thank you very much, Dr. Reena. May I invite Dr. Manavdeep to speak on drug-induced glaucoma.
First of all, I thank the Uttarakhand Society for having me here. And drug-induced glaucoma is more of a social problem. So this can be without angle closure or with angle closure. With angle closure, it can be without pupillary block or with pupillary block. With pupillary block is nothing but primary angle closure disease. So the two things that we will be discussing mainly in this talk will be the steroid-induced glaucoma and angle closure glaucoma without pupillary block. So there are many agents which can cause increase in the intraocular pressure, and topical cycloplegic agents, they cause the primary angle closure attack. Even water is not innocuous. So these are few of the drugs which can cause acute angle closure. So let's come to the point, steroid-induced glaucoma. The clinical features are just like that of open angle glaucoma. There is high IOP after a successful TRAB is possible in these cases, and they can be anti-GM occurs when the steroids have been stopped. In adults, it resembles primary open angle glaucoma with all typical changes, and in children it can resemble like congenital or juvenile glaucoma and even can cause ophthalmos. It's very common in cases of VKC. It can masquerade anti-G, as I said. Interface in the corneal edema can be secondary to steroid-induced glaucoma, and it can simulate diffuse lamellar keratitis following LASIK. The management is opposite, so one has to be careful. The extent depends on the route of administration. Topical drops are the most common. The periocular injections, they are the most notorious because they are difficult to manage because once it has been given. All routes can lead to glaucoma, and rarely even endogenous steroids can cause steroid-induced glaucoma. It can take days to years. I have seen just with fluoromethalone within 1 week patient getting pressure of 40. So it depends on the responsiveness of the individual, the dose and the route. it has been shown that nearly all primary open-angle glaucoma, they are responders. And in the general population, high responders are 5 to 6%, and about 1/3 are intermediate responders. Who is at high risk? As I said, primary open-angle glaucoma, their first-degree relatives, people with baseline high IOP, high myopes, diabetes, and connective tissue disorders. The relative risk depends on the strength of the drug, the most innocuous being loteprednol and fluorometholone. The genetics is similar to that of primary angle glaucoma. The mechanism is the reduced facility of outflow. Intravitreal triamcinolone can cause very resistant glaucoma even in a single dose. A lot of cases have been reported, and once these are increasing, I'll not be surprised if we can get almost an epidemic of severe and intractable steroid-induced glaucoma because of this. There is a case report from literature where severe visual field loss has been shown by intravitreal triamcinolone. The prevention is a social problem. We need to minimize the steroid usage, avoid depot preparations, education of family physicians, stress on this during the MBBS course, education of chemists, campaign against self-medication, because in BKC this is very, very common, enforcement of law restricting the sale of medicines without prescription. The management is just like that of primary open-angle glaucoma. However, the withdrawal of the drug is the most important thing. So this is a case showing subtenon depot steroid which has been excised, and this is my case in which we found it extremely difficult, in fact, to remove this totally. Small little part will always remain. This was a patient in which there was steroid-induced glaucoma and cataract. It required cataract surgery which could not be done so well done outside, and then we had to resort to AGV type of surgery. Even trabeculectomy was not going to be successful in this case. So this is a case showing disc damage because of this. Another case which had intractable steroid-induced glaucoma and required AGV surgery. So the other thing is the idiosyncratic acute angle closure glaucoma without pupillary block. It is not dose dependent. Mostly it comes after a few doses have been given, and the pathophysiology is the drug metabolites, they bind to the proteins, and these altered proteins are perceived as foreign and induce immune response. The mechanism is ciliary body edema with anterior rotation of iris lens diaphragm, and iridotomy is not effective because this is not pupillary block glaucoma. Lot of drugs have been implicated, topiramate being the most common. Sulfas are the other group which is more common. Even estrazolamide, which we give as a treatment for glaucoma, has been implicated. So what is the clinical situation? Bilateral, and in patients not at risk for ACG. AC is generally deep with open angles in the beginning, and it is associated with acute onset myopia. The acute idiosyncratic reaction, the diagnosis can be, it occurs hours to weeks following the start of the drug. Recognition of the condition and high index of suspicion are very important. UBM, if available, can be helpful in the diagnosis. Management is stop the offending drug and control the IOP. PI has got no role, as I said, and also myotic should not be given. Another case showing idiosyncratic AC shallowing, which is open after the treatment, and ultrasound shows choroidal thickening. Escitalopram is another drug which is used for depression, which has been implicated quite often. PI was performed in these cases because this is an old case. That time people did not know much about it, and they used to do PIs. So this is on presentation and a week later after treatment with cycloplegics and steroids. Another case with for galactoria cases with drug gabergoline. Estrazolamide has also been reported in IGO. Indapamide, this is a case which we received recently, in which the patient was earlier known to have no myopia of -0.5, but there was an acute onset decrease in vision which had fallen to 636, refractory error became just slightly increased. Normally we see -5 to -7 in these cases, but this patient had only -1.5. Fundus were normal, IOP was moderately raised, and AC was not much shallow. But it became much better within 4 or 5 days. So all these cases are not very severe. Thus, to summarize, steroid-induced glaucoma, common cause of avoidable visual damage. Ophthalmologists, physicians and healthcare workers, they all have the responsibility in prevention. High level of suspicion is the key to successful management. Ophthalmologists to be aware of idiosyncratic acute angle closure glaucoma caused by sulfa and other drugs. It is not essential that idiosyncratic glaucoma will always be severe. Thank you so much.
Thank you, Dr. Manavdeep. Any quick questions from the audience? Thank you for finishing in time. I think the drug-induced glaucoma is actually a very important entity, and there are many drugs which can induce glaucoma even other than steroid, and sometimes they can present acutely also. So it's very important to actually recognize the condition, because as ophthalmologists sometimes we forget the general condition of the patient, and we actually make a mistake there. So it's very important to keep these things in mind. Thank you, Dr. Manavdeep.
Sir, I had another talk which was in the serial. Should I go there or will I take it later on?
No, right now. There's another talk by Dr. Manavdeep. Second talk, please. Projection. Okay. One before this.
So it is also important that whenever there is drug-induced glaucoma, you have to dilate the patient. So that is contrary to how we treat acute angle closure. And never do YAG-PI in these patients who have drug-induced glaucoma.
This is showing Dr. Pandav's name. I have another talk before that.
This is another talk of Dr. Manav.
Number 6.
Sir, I think you take over. I'll clarify the matter, and sir, I'll speak later on. Okay. Thank you so much. So this is regarding the shallow anterior chamber from which everybody is worried and afraid. This is how it happens. People start thinking and start calling their relatives and friends, those who can guide them. So why flat is so scary? Because the two most important reasons are leak and malignant glaucoma, and both are very, very serious. Post of day 1, what do we desire? Slightly shallow AC, IOP slightly less than 10, no leak, no irritating sutures, no touch, no hyphema, well formed bleb, and PI should be visible. So these are the desirable conditions in the early and post trabeculectomy. So the causes of the post-trab flat AC, they are with elevated IOP or with low IOP. With elevated IOP, the ciliary block or malignant glaucoma, suprachoroidal hemorrhage, and retained visco rarely. With low IOP, overfiltration, wound leak, choroidal detachment, and aqueous suppression. Flat AC with low IOP, something which is most common and most important and worrisome. Incidence of overfiltration as well as leak has increased due to the antifibrotic agents which are now used almost in 100% cases. Incidence is decreased with the use of releasable sutures. This is another positive point in this. Grade 1, 2, 3, I think this is more of a PG level talk. I'll skip this. The principles of surgical treatment are in grade 3, it's a surgical emergency. That means when there is a irido-lenticular touch, corneal lenticular touch, it can lead to cataract, anterior and posterior synechia formation, as well as endothelial cell decompensation in hours. Please, I repeat, in hours all these things can happen. So this is a very serious situation. The treatment, immediate treatment is AC reformation with air in leak and viscoelastic in overfiltration on the slit lap immediately as soon as you see. Through the paracentesis, that is almost universally done nowadays in trabeculectomy. Resuturing or definitive treatment can be done later on. So the bleb leak, intraocular pressure is generally 0 or 2, 3 maybe. AC may be shallow or flat, bleb is shallow or flat. Bleb is also shallow, and the diagnosis is confirmed by Siedel's test, which is shown here. You can see this leaky fluid. So the treatment is generally in the beginning conservative. Stop topical steroids, start oral. Gentamicin, tobramycin, they help in healing. Strong cycloplegia, atropine, padded bandage, large bandage contact lenses, autologous bloods have been described, not of much use. The surgical treatment can be done by laser after staining the area of the leak with gentian violet or trypan blue and then using argon laser. The suture removal sometimes can be helpful. Remember, sometimes the suture is there in between the leaky areas, and that removal of that suture may induce healing which will otherwise not heal. And the most definitive treatment is the resuturing. There can be rapid cataract formation, as I told you, within hours endothelial cell decompensation and cataract formation can happen. What are the problems related to bleb leak? Everything leads to bleb failure ultimately. Excessive healing as topical steroids are stopped, prolonged bleb fibrosis, synechial formation, rapid development of cataract, and failure of, ultimately it all leads to the failure of trabeculectomy. Hypertony maculopathy can occur if it stays for few weeks, 4 to 6 weeks or longer, and it also adds to the risk of infection. Hypertony due to overfiltration is not that disastrous. It is relatively innocuous and generally settles on its own. And the IOP remains, if the IOP remains long for less than 6 for a long period, then it can lead to hypertony maculopathy. So one needs to do a definitive treatment in less than 6 weeks. So this is a case of overfiltration. You can see a large bleb out here. The management is mostly conservative. Stabilization of the blood aqueous barrier is the mainstay of the treatment, that is atropine. Add oral steroids, may need intracameral injection of viscoelastic sometimes to build up the pressure. It may require palm bug suture, which I will show you next if large bleb is there. Argon laser photocoagulation from the sides can be done if bleb is more than 3 to 4 clock hours, again by staining the area. The surgical treatment is the tightening of the scleral flap, which may lead to filtration failure occasionally. So this is a palm bug suture, which you can see here. Something very important is one has to take the suture in the sclera and in the cornea. Unless it is taken in the sclera, this suture will become leased and there will be no pressure in the period of time. Ciliarochoroidal detachment, it may be the cause, but more often it is the result of hypotony and not the cause. It is hardly visible on UBM. It can be very little, maybe very mild, which may not be visible even on UBM to kissing choroidals. Reduced visual acuity may be an early sign. Generally, in case post-TAVR, you find everything appears normal and the patient, and you don't have UBM, and the patient has got low visual acuity. The reason is generally ciliarochoroidal detachment. Give atropine and it will settle in few days' time. Nothing to worry. Flat AC with elevated intraocular pressure, the causes include the pupillary block, malignant or ciliary block glaucoma, suprachoroidal hemorrhage, and the confirmation of diagnosis can be done by ultrasound. Flat AC with elevated IOP expected in first 1 to 3 days, and the pressure should be 6 to 10. Expected IOP if AC is shallow due to leak or overfiltration is 0 to 6. Although IOP is generally very high in malignant glaucoma, but it may not be high. Even 13, 14, 15 pressure, so-called normal, may be high for these cases. So malignant glaucoma can happen with 14, 15 IOP also. So there are two mechanisms. One is caused by ciliary body detachment and anterior rotation. AC is flat and lens iris diaphragm is rotated forwards, causing mechanical angle closure. Here the treatment is mainly medical, surgery only if it fails. The other cause is aqueous misdirection without ciliary body detachment. AC is flat and lens iris diaphragm is rotated forwards, causing mechanical angle closure. They are differentiated only by UBM and nothing else. Treatment is surgical rupture of the anterior hyaloid phase. I will not go into the details of this because time is very short, and you may be able to see on ultrasound even the aqueous pockets. So this is a case of ciliary block glaucoma following cataract surgery. There is in the left image you can see the central anterior chamber is very shallow and peripheral is flat. On the right side picture, you can see AC deepens following YAG laser capsulotomy and anterior hyaloidotomy. Similar situation can happen following trabeculectomy also, and may require even vitrectomy in case the patient is phakic. The management is generally medical first initially and only successful in 50% cases. Strong cycloplegia, atropine 1 to 4% 4 times a day. This is the only indication when we give atropine 4 times a day along with phenylephrine. Aqueous suppressants, systemic hyperosmotic agents reform the AC if there is no response. Lasers can be used, but I have few things, sir, very important things to talk. Aspiration of the fluid can be done, vitrectomy can be done, occasionally lensectomy may be required. Thus to summarize, the summary is very, very important in this case. Post-op flat anterior chamber is a serious complication of incisional surgery for glaucoma. Mostly one of the 4 reasons of flat AC, 3 with low and 1 with high IOP. IOP decides whether it is malignant glaucoma or otherwise. In clinical setting, most cases can be managed conservatively. Iridolenticular cataract is a contact. Iridolenticular contact is a surgical emergency. Although YAG laser capsulotomy with anterior vitreous phase break may help in pseudophakics, vitrectomy may be required in malignant glaucoma. Eyes with malignant glaucoma may require lifelong atropine. So this is very important. These patients may require lifelong atropine. And fellow eyes, this is the most important thing. Fellow eyes are also at high risk of malignant glaucoma, and prevention is the key to success. Immediately start atropine in these cases on the day, on the surgery, on the table itself. Thank you so much.
Thank you so much, sir, for covering this very important topic. And now I would invite Dr. S.S. Pandu, sir, for keynote address on angle surgery for glaucoma, a practical approach.
Before I start, I thank Uttarakhand Ophthalmology Society and Dr. Vinod Arora, and particularly for inviting me for this meeting and for this lecture. I have no financial interest in any of the techniques I mentioned. Glaucoma surgery has evolved remarkably in the last 10-15 years. We started from TRAV, which has been there for a long time. It still exists and still is ruling, and we have tubes, deep spectomies and some other procedures, then canal-based procedures, external, internal, and finally the trabecular meshwork-based procedures. So canal-based and trabecular meshwork-based procedure are also kind of labeled as minimally invasive surgery these days. So why this is there is because there's the problem with the POAG particularly is that there's obstruction to the outflow, and this is usually at the level of the trabecular meshwork, which is kind of a juxtacanalicular trabecular meshwork. That's where the problem is, and therefore it makes sense to deal with that area. But sometimes the problem could be the Schlemm's canal or even the collector channels, and even outside it. But those are different situations. So therefore, it makes sense to target the trabecular meshwork. So there are a number of procedures and approaches have been adopted to to bypass this or to reduce the effect of this obstruction. So there are 4 essential approaches. One is basically to improve the functioning of the trabecular meshwork, and this can be done by treating the meshwork with the lasers, and that we have been doing laser trabeculoplasty for a long time. And initially we had ALT, but now it's practically replaced with SLT, which is become the de facto standard for laser surgery for trabecular meshwork. Second approach is to bypass the trabecular meshwork by using some micro stents, and eye stent and hydrus, you're all aware of these procedures. So they have become quite a common talk these days. And the third approach is to remove the trabecular meshwork, just strip off the trabecular meshwork tissue so that Schlemm's canal is directly exposed to the aqueous, to anterior chamber, and aqueous can flow directly through this. And in this we have trabectome, Cahouk's double blade system. We have bang and also GAT procedures. Then the next approach is to bypass everything. That is, you bypass the trabecular meshwork, Schlemm's canal, collector channels, and even and there either you drain it into the suprachoroidal space, or you can drain into the subconjunctival or subtenonal space like we do for trabeculectomy. And here we have Zen, and in focus is now Pressa flow, and some more devices are there in this range. So talking about the SLT, that is the treatment of the trabecular meshwork to get better results. This has been there for a long time and actually is quite useful. And if you look at the available literature, it suggests that the SLT actually works quite well. At least it can reduce to 20 to 30% IOP in most cases, and it's almost equal to what drugs. Now, the best case scenario, you can say SLT is equal to latanoprost, but that may not be true all the time. But in my experience, it certainly equals to timolol if when it works. There would be some situation that it does work at all, but when it works very well. So I think this should be used, and I have a feeling that we are kind of underutilizing it. The reason that we kind of tend to think that maybe it doesn't work in our population, but probably that is also not entirely correct, because we have published a few studies now in open angle glaucoma and even in angle closure glaucoma after laser iodopy, and have seen a significant reduction in IOP after laser therapy in these eyes. So iStent and Hydrus, so this is the second approach where you're bypassing the trabecular meshwork using microstents. So now iStent actually has two forms now. One is the L-shaped, which I have shown. So what it does, it actually basically is a kind of a conduit which connects the anterior chamber to the Schlemm's canal, so that the trabecular meshwork resistance is bypassed. And some similar approach is also used by the Hydrus implant, which is a bit longer one. It provides a bigger scaffold. So the problem with the iStent is that if it's not put in the vicinity of the collector channel, it will not work properly. So the Hydrus actually addresses that problem, and you have better chances of success. So there's enough literature now available to suggest that both of these devices, they actually work. They have a IOP lowering effect, and this particular study also suggests that there's also a kind of a dose response curve there. So if you are putting one stent, you expect about 20% reduction, two about 30%, and three stents about 40% IOP reduction. So this is a little bit of simplification, but again, there are because most of these devices both of them are actually done with the cataract surgery. So there is also a thought the cataract surgery itself also reduces intraocular pressure. So what is the real benefit? But I think the literature is now more or less clear that it has a IOP lowering effect over and above the IOP lowering that can be attributed to cataract surgery. So these are also important armamentarium in this. And if you look at the Hydrus versus iStent, now this particular study suggests that Hydrus probably is a little better than iStent in terms of IOP lowering efficacy. And Hydrus and SLT, if you look at the data, it also tends to suggest that they are also probably similar. So SLT, Hydrus, iStent, they're probably somewhere in the same range as far as IOP lowering is concerned. But the problem here is that the cost is very high. iStent is now available in India, and it would cost something like 70 to 120,000 plus cost of the surgery. So that's actually quite a steep price to pay for our patient, and Hydrus is even more expensive. So practically speaking, their utility is very limited in our populations. Then we go to the trabectome, KVD, bang and GAT procedures. So these are the procedures which are available to us. Trabectome is now actually marketed in India. It has some initial investment, but the cost to the patient is not as much, and we can add about the running cost for the patient would be about 20 to 30,000 in addition to the cataract cost for the cataract surgery. So it is still in a reasonable range. The KVD is very cheap. The bang is basically a bent internal needle goniectomy, and this is just a 25G needle which doesn't cost much, and GAT is similarly uses a Prolene suture, so it's a very cheap procedure in that sense. So I'll just show you our experience with this is with the trabectome. So trabectome is also available, easily available now. So what you do is you made a port entry. This is goes through the 1.8 millimeter port, and this has the trabectome has actually this electrode. There are two electrodes. So one this will go into the trabecular meshwork, and when you press the foot pedal, this will, high frequency, it's kind of a high frequency cautery which will, remove the tissue. So you engage into the Schlemm's canal and just sweep it across while pressing the foot pedal, and it will remove the trabecular meshwork along the length that you treated. So normally you need to treat around 120 to 140 degrees, and that gives you a fairly good IOP lowering effect. So if you look at the results with the trabectome, it reduces IOP by almost on an average of 9 to 10 millimeters of mercury, which is fairly good and is definitely more than the control group. That is, control group here is basically just the cataract surgery without the trabectome. So the Indian data from India is also now available. Dr. Sunita has from Sunita Dubey from Delhi. She has just published the data very recently on this, and kind of suggestive of that you have this is effective in Indian eyes as well. So I'll show you a little procedure with the bank. This is very kind of a cheap, very easy to use and also very cost effective way of doing it. So all you need is a 25G needle. You create a side port incision, inflate the eye with the viscoelastic, and put the bend the needle a little bit towards the bevel side, just about and then you insert on a direct gonioscope. I'm using this as a Swan-Jacob lens. So then you can, like you did for a trabectome, you can do similar procedure, but here you don't need any specific equipment. You can see the needle tip is actually engaged in the trabecular meshwork, and it can be used to strip the trabecular meshwork along the length of the treated portion of the trabecular meshwork. So this is again, usually we do it for about 120 to 140 degrees. The trabecular meshwork is removed, and after this is done, you can continue with the cataract surgery. Go ahead with the IOL implantation, and post-operatively the IOP will be in the first day you have to cover for any spikes because the remaining viscoelastic or some hyphema, but later on the pressure drops down. So there are not much data on the bang available as of now, but IOP reduction for all glaucoma patients can be seen in about 20% to about 20% IOP reduction has been reported in early cases, but I think we are still building up this experience. And this is our early experience of about 30 eyes, 29 eyes, where you can see the IOP reduction is there about from 15 to 11 millimeters of mercury. So there is a significant reduction, but more important is the number of the drugs that were used before surgery and after surgery. It has markedly gone down. So there is a significant improvement in terms of medicines required to control intraocular pressure. Then these are the other way, the fourth approach, where basically you bypass everything. So I'm not going to discuss in detail about these. So to summarize, there are a number of angle procedures are now available to glaucoma patients. SLT is an useful and is perhaps underutilized modality to reduce intraocular pressure for our people. Trabectome, KVD, GAT, and bang are effective, safe, and affordable options for our patients, and one can probably explore more into these areas. Eye-stent hydrous, no doubt, have shown their efficacy in clinical medicine, but they tend to be still they are very expensive and kind of beyond the reach of an average patient. Most of these procedures are combined with cataract surgery, but some of them can be done independently also. Thank you very much once again for this opportunity.
Thank you very much, sir. We have our first speaker, Dr. Madhu Bhadoria. She will speak on fine art of finding glaucoma patient in General Ophthalmology Clinic.
Can I ask sir one question in the meantime? Sir, what are the indications of these procedures and which patients we should do, and what about the long-term efficacy of these devices?
I think they are generally recommended for mild to or early to moderate glaucoma. Not for the severe form of glaucoma where you need a more, intraocular pressure reduction. So, that's the indication. Plus open angle. So they can't be done for angle closure. So unless the angle, the trabecular meshwork is visible, you won't be able to do these procedures. So open angle plus early to moderate glaucoma. You can try them for advanced disease also, but then probably that will in itself will not be sufficient. You might have to augment it with some other procedures as well.
Sir, what about long-term efficacy of KBD and bank procedures?
Data is still, I think the long-term data is still not there, but I think up to 2 to 3 years, what data is available, it suggests that the effect at least lasts that much. So I think it's like SLT. So we have 2 to 3 years and we can repeat this procedure, but that is repeatability is probably not. We don't know about these newer procedures. So that part we have to wait. But eye stent has been there for a long time, and I think its efficacy is kind of more or less established. But again, the cost is a deterrent.
Thank you, sir.
So shall I start?
Yes, please.
Right, sir. So now from all these talks, let's come down to first and foremost, we need patients. So from where will they come? They will come from the busy ophthalmology clinics because glaucoma itself doesn't present to us. So there's no limit to power of human mind. And that is the first thing we have to sit down in the clinic with, that, look, I am here to concentrate and find my patients of disease, and here in this context, glaucoma. So we should start looking at the patient when the patient walks in only, and not wait that till I examine. Look at the body. If the patient is short or tall, you're likely to have subluxated lens and this thing. Or if the patient is walking with a hemiplegic gait or a stone-faced patient, look at the file in hand as to how many consultants the patient has already visited. How anxious is the patient, or the patient is depressed. Look at the glasses, high hyperop or a high myope. Eyes large, big proptos. Smart history is very important because the patients don't know about their diagnosis. And IOP of 21 is really a very, very poor criteria because IOP itself is fallacious in so many situations. Then we have to look at the risk factors which are associated and also the drugs which are associated. So in the history, frequent change of glasses is something all the residents know, but what we really should look at carefully is the patient falling more often. Colored halos are again very common, but we don't take the history of body drugs, like a patient is taking beta blockers, steroids, prostate, anti-prostate, epilepsy. Acute attacks again are very infrequent now. So therefore we have to really deep dive and look at the other things. And diminution of vision in a glaucoma patient is the last thing to happen. So that is not the criteria. So we need to focus on the risk factors. The important things have come out is age. If 40 years plus have 1% glaucoma, 80 years old will have 10% glaucoma is the evidence-based study. Therefore, those who are frail people, IOP raised, dissuspects, all these patients are glaucoma patients. Past ocular disease, we must not forget the history of VKC and steroids is a very common cause. Other than that, all the diseases which are listed, trauma is often missed in past. Angle recession will give rise to glaucoma after 10 years, 15 years after injury. Therefore, we should go back in the past if we find a sphincter tear over there. Uniocular glaucomas are secondary glaucomas. Previous ocular surgeries, these retina guys are causing so many glaucomas with silicone oil. Keep an eye on the bubbles and even without bubbles. Then cataract aphakics are definitely a lot more prone. Strabismus is conjunctiva in case scarred. Other than that, the anti-glaucoma medications patient is using steroid eye drops, etc. Examination, most important is clinical suspicion and good observation, followed by slit lamp is the tool that can actually, if you put your mind there, we will not miss any glaucoma patient. We will miss for investigations, not for diagnosis, but for screening onwards for examination of the glaucoma patient. Look for the signs. Look at this one dilated pupil with the red eye, most likely to be an acute angle closure attack. Or look at the lady who's post-PK. IOP is a must. Observations, look at the face. If a hemangioma is there, Sturge-Weber is likely. If the nevus is there, otus nevus, it will be there. These proptosed eyes, we don't bother about the IOP. Patient looks up IOP, apiagus resin, and when the muscles are very fibrosed, every time the patient tries to move the eye, the IOP is raised. This young girl was brought to me as a disc suspect. 80-16, gonio angles, everything open. Now look at the picture. The right eye is big. What? The refraction was not done. She's a myope of 20 diopters, and this is a normal myopic disc. So size of the eyeball, this is something we all know, either a big eye or a small eye. Both of the eyes are very, very, very prone to glaucomas, and they are glaucomas actually. Slit lamp is the best tool, but look at this patient looking all normal, everything fine. But what was missed? Nobody lifted up the lid. The two blebs sitting over there. Conjunctiva, drug effects we all know about, bleb scarring, etc., etc. But we have to really look for it, it is there, and the drugs, glaucoma drugs are the most scarring things which are in the eye. Is microscopic scarring we are not able to see, therefore long time drugs, the surgeries fail. So history is important. This episcleral vessel is very important. These keratoco-cavernous fistulas, or they may be sitting ciliary body tumor behind. These anomalies, Habstria is something very common, you all know. But if you see the anteriorly placed Schwalbe's line on slit lamp and you see pass, if it's 2 eyes, it will be Axenfeld-Rieger's group. And if it is 1 eye, then we should look for endothelium carefully, 25x or 40x. And in case we are able to find these guttators, we have to be careful in all kinds of surgeries. The next thing comes the corneal opacities, and what I'm looking at it is the epitheliopathy. This epitheliopathy is most common with lots of glaucoma drugs, and especially in the patients who are dry eye patients. So other than dry eye also, we have to be careful in looking at the drugs, the number of drugs we are giving. People are giving 3, 4, 5, so many bottles. Maximum is 2 bottles, 4 drugs. Coming to infectious keratitis, IOP is raised in most of them, especially fungal, so this IOP must be lowered, it's not a glaucoma. When we look at this vertical line, Krukenberg spindle, it is a clear-cut indicator that we got to look at the angle, and if you look at the angle, you will find this pigmentary glaucoma. There is no other way to diagnose it. And it's not always on the cornea also, it may be just in the angle. Do an UBM and there will be a classical case. So anterior chamber, Van Herrick's we all know, if there is a grade 2 or less, then we got to do a gonioscopy for must. Look at this iris. There are these focal areas of iris atrophy. These pass a PI somewhere, or look at this cornea, dilated pupil. This cornea showing mild bullies, microcystic edema. These are all the eyes that have had acute angle closure attack and now going in chronic decompensation. Look at this iris, the iris Bombay. We don't wait for the IOP to rise. We do a PI at this stage and multiple PIs. Look at the iris pupillary border. NVIs are there. NVIs are located there. If we have a bump like this in the iris, do an UBM and check it's a tumor behind the iris, or is it is just the multiple cysts. So coming to pseudoexfoliation kind of eyes, you will find this dandruff-like material on the pupillary border, dilate and you will see something like this. Pseudoexfoliation will have this retroillumination, transillumination defect in the center, and periphery, mid-periphery you will have the this thing, PCG actually. So trauma, the hyphema is very easy, but look at the sphincter tear, the second picture, small sphincter tear. Look for angle recession in this patient. Lenses, this microspherophakia kind of lens is very rare to find, but what you will find is a picture on the right side that you see. This will be one subluxated lens, hypermature, or something, you put the phacoprobe and the lens goes down. Or somebody has done the surgery, not declared, and now the lens is coming forward, is sitting in the vitreous. So and with the raised IOPs come to you. Tonometry, these are all screeners, but the important point to remember here is that for screening, we have some criteria. 10 to 20 you can take normal, but we must do an 80 when it's beyond these limits, when the difference in 2 eyes is dark, like one eye is 10, the other eye is 20, or one eye is 10, the other eye is 16. Large difference between the readings in the same eye also. So optometrists should write all the readings and not just the final one reading. So this is good apprehension. This thing, corneal thickness, we should do definitely in patients of OHT and NTGs. Then gonioscopy. Why do we need to do it? If you know, you will definitely do it. So one thing is to differentiate normal angle from angle closure. If angle closure is occludable, once you learn it properly, you can use for therapies also. So when to do? Whenever you have a suspicion in history or in the examination, anything about glaucoma, gonioscopy is a must. And finally, we look at the disc, this beautiful disc under 5 headings, the disc size, disc rim, RNFL. I have not talked about the cup, so it's not the CD ratio that everybody writes. Peripapillary atrophy and optic disc hemorrhage. And if we do all this, I am sure we would not need the disc to tell us, don't let this happen to me. Thank you so much.
Thank you, Dr. Vaduri. I think that was an excellent presentation. Unfortunately, we are out of time. We got the session late, actually, 15 minutes late. So in that sense, we have finished it before time. But thank you all very much. And we have I'm sorry, there's one more talk, Sanjay Kumar Mittal. Yeah, Professor Sanjay Mittal, please.
Good afternoon, everyone. This is autonomic nervous system modulation for control of intraocular pressure in primary open angle glaucoma. It's a prospective clinical trial which I am going to share. There is no financial interest. And this is about the topic which a study which we did and which was published in World Glaucoma Journal, World Glaucoma Association's Journal of Glaucoma, last year, 2021 February. And the concept is based upon our previous study, a research project done, where a study was done to show the influence of ANS, autonomic nervous system, and meditation on intraocular pressure. And long back, around 10 years back, this study was done. And it was found there were two groups. Group A, a control group. Group 2 was age-matched people who were meditators. And the result came out that there was slight pressure was slightly lower. It was just a study, because part of some other study actually. So that actually gave us an impetus to go in for, because the results were that because in meditators was their parasympathetic and sympathetic system was also assessed, and it was found that the parasympathetic dominance was found in comparison to sympathetic. So that led to this concept, and we came up with this idea why not to do it in some primary open angle glaucoma. So autonomic nervous system, we all know that it's a part which controls several effects of the body, and it has two main divisions, sympathetic and parasympathetic. Hypothalamus is the basic structure, and the hypothesis was basically that stimulation of parasympathetic fibers that helps in facility of outflow. So that is the concept which was there, and simultaneously there are various theories that increase in oxidative stress also, which plays a key role in glaucoma pathogenesis by causing mitochondrial damage and apoptosis in the trabecular meshwork, and as well as the retinal ganglion cell loss. So these yogic breathing exercises, it can cause reduction in oxidative stress by increasing superoxide dismutase and decreasing the number of free radicals. Similarly, nitric oxide is also formed in the nasal sinuses when we perform certain breathing exercises like alternate nostril breathing, and that leads to increase the level of endogenous nitric oxide, which is found to lower the intraocular pressure. So the purpose of this study was to do a medical, or like we know that medical or surgical treatments are there to treat such patients, and we know that autonomic nervous system activity also has some influence of intraocular pressure monitoring. And there were two exercises we opted, that yogic pranayam and abdominal breathing. So let us see the effect on the patients by virtue of increasing parasympathetic dominance. So this way we made two groups, and it was a prospective randomized trial. 90 total number of patients were 90, and all age matched patients were taken. Of 50% patients were of all the patients were of primary open angle glaucoma. We made into two groups, and the inclusion criteria were like the patients who were established, who are currently on medical eye drops for medication, and the patient who consented for regular follow-up. Patients who had they had undergone through any intraocular surgery were excluded, any malignancy or systemic disease were excluded, ocular trauma, angle closure glaucoma were excluded, and the patients who were already performing some yoga techniques were excluded. So the group A was on the patients, those who were only on topical medications, and group B, there we added these two techniques of yoga breathing, pranayam, and diaphragmatic breathing, which is an abdominal breathing, daily for 6 months. So this is to show the pranayam is basically, this is also called nadi shodhanam, like nadi means the channels and flow of energy, and shodhanam means purification. So alternate nostril breathing. I hope everyone nowadays is aware of all this alternate nostril breathing. And diaphragmatic breathing is just abdominal breathing, belly breathing, where we involve our abdominal muscles. Normally we use thoraco-abdominal breathing or abdominal thoraco breathing, but intently we focus more on abdominal. Of course, there would be little subtle thoracic breathing as well, but more on abdominal breathing. Simply like whenever in yoga it is said shavasana technique, simply lie down in supine position. So inhale and exhale. Intraocular pressure was measured in such patient at the interval of 1 month, 3 months, 6 months. Of course, with OCT, we took three factors into consideration: intraocular pressure, OCT, RNFL analysis, and visual field analysis. So results, this red color shows the group A those who were only on topical medication, and blue shows that group B, where the topical medication along with these two techniques were adopted. And with this graph, it is visible that there is some decline, better decline. So for the right eye, when we compared across intergroup analysis, the p-value was less than 0.001. Similarly, in left eye also, this was less than 0.001. So there were ultimately 40 participants in group B who completed yogic pranayam and diaphragmatic breathing exercises and showed a 28% more reduction in comparison to group A, intergroup analysis. However, for average RNFL analysis in either group, there was no significant change in OCT findings, and no significant difference was seen in the visual field analysis. So this study actually provides a scientific evidence for lowering intraocular pressure with yogic breathing exercises. And these techniques involve no cost and can easily be learned, can be practiced by glaucoma patient, including elderly, and can reduce the need of medicines. And this can be recommended as an adjunctive therapy for glaucoma patients and not as a substitute for medicine or eye drops as per our study. It may also help in some glaucoma suspect patients. Like Dr. Pragati asked the question about that patient, such patients, it can be tried, such patients, like they are having some symptoms. More research, however, is needed to explore the exciting prospects of yogic exercises in primary narrow angle glaucoma as well, and to see whether these can also serve to reduce or stop the progression of, this optic neuropathy is taking place. So whether it can be helpful, but this has been just a 6 months follow-up study. So a multicentric and a wider group study is required. Thank you very much.
Thank you, Dr. Mittal. I think there's a very interesting study. There's a lot of interest nowadays in how the meditation, yoga can affect health, not only in other areas but also in medicine. And there is some evidence is coming up now, like your data suggests that there's a benefit in terms of lowering intraocular pressure. And there are some more studies from RP Center. Tanuj has done some similar studies on meditation. And he also tends to suggest that there is a positive effect of meditation and these yogic techniques in glaucoma as well, in terms of reducing intraocular pressure or even changing the biology or the genetic expression in the temporal meshwork. And so there's a lot more to it actually than we understand, but I think this is an area still open for research. And thank you very much for for the excellent presentation. I think we are at the end of the session. Anyone wants to any comments? Yeah.
Thank you very much, Professor Mittal. You have rightly said that meditation is important. I think meditation is the best medication for every agitation. So that's how meditation works. And so far as pranayama is concerned, Brahmari pranayama, that is humming, that also reduces intraocular pressure and that increases nitric oxide levels. And another important thing about the yoga is that there can be negative aspect also of the postures, like sun salutation, Surya Namaskar, in which forward bending is done, and also Shirsasana. This kind of asana should not be performed by glaucoma patients. And vigorous breathing exercises like Kapalbhati, Bhastrika Pranayam, they are also bad for the glaucoma patients. This was about yoga, and some more practical tips. In our country, many people take 4 or 5 glasses of water in the morning when they get up. This is dangerous for the glaucoma patient. So if a patient is glaucomatous, we can emphasize this point to the patient. And also, so far as screening is concerned, we must screen all the first degree relatives of the patient of glaucoma so that more and more patients of glaucoma can be diagnosed, because few patients in the family can remain undiagnosed. And stress is important, but deficiency of vitamin D has also been found to have some effect on the progression of glaucoma. And posture of the patient, as I think already told by Dr. Manavdeep Singh, patient should be instructed to lie down on one side. otherwise intraocular pressure rises. Snoring also adds to the low pressure glaucoma, where the etiology may be reduction of the oxygen supply to the optic nerve. So patient should be treated by the pulmonologist. And so far as gonioscopy is concerned, today a patient may be having open angle glaucoma, but in future same patient may have closed angles. So gonioscopy should be a regular procedure even in patients who have been diagnosed as open angle glaucoma. Thank you very much, sir.
So I think we are at the close of the session. Thank you all. Thank you all
Sir,
the
there is
panelists here.
Just a question
Okay.
regarding the bank procedure which you
Yeah,
told
sure.
about the initial patients.
Yes.
So you had 9 patients of angle closure glaucoma. So you
Yes.
treat after cataract surgery or
At the time of the cataract surgery.
at the time,
of
the
you
angle
deepen
without
that. Yeah, you
angle
deepen the
without-
anterior chamber. You
Okay.
deepen the anterior chamber with the viscoelastic, so that opens up. If it's a synechial closure, then it will not
Then
work.
okay,
Yeah, but if
without
the
the
angle is
synechial
just
closure.
yes, yeah.
Okay.
Otherwise, on
Okay.
table you can deepen and do bang, and then do cataract surgery, so that will deepen your
Deepen the angle as well.
chamber.
Okay,
So these are the procedures which are doable. Practically we can do it, and they don't cost much. So yes, please. About 120 degrees. So idea is to go beyond 120 to 140, but 120 is manageable. So you go one side and you go the other side, about 60 degrees each. Yeah. Different quadrant. We can do that. Okay, thank you very much. Thank you, everyone.
Well, after this session, we are going to have cornea session. Dr. Neeti is already there, and Dr. Neeti can invite rest of the chairpersons.
Thank you, sir. So I invite Mr. Vaniti ma'am, Vikas, Dr. Vikas, Dr. Deepak Mishra, Dr. Nishan Devani for the chairpersons. I invite Dr. Ashi Khurana, ma'am, please, on the dais, please. I'm the only one sitting here.
HDMI है इधर
Dr. Tarunum, you can also come here. Ma'am. बाकी जो So we'll start the cornea session. I welcome you all. So the first talk is Cares for Keratoconus, a New Approach, Keynote Address by Dr. Kumar Doctor.
एक मिनट 1 minute. Good morning everybody, respected chairpersons. I'm going to talk on something that new I am doing, and that's all about CARES. I would like to thank Dr. Shivani who helped me to make this presentation. Not that we have a large series, I'm doing intacs with the femto since last 9 years, and we just started doing CARES. So we have if a patient with keratoconus really comes to us, what are our real options today? So one option is of course our contact lenses, which are doing well. If the patient does not want DALC, the only option is a good fit contact lens, and patients can pull on for some time. Then came the era of keratoplasty, which we used to do, and then came the era of collagen cross-linking. So all of you know that collagen cross-linking does very well, and that is the form of treatment. And then I've been doing intacs with cross-linking for quite some time now. And then came the last part is TREC, which is called topo-guided removal of corneal epithelium for keratoconus. And then came the present, which is collagen, which is cornea allogenic implant that we are using. So here what we are doing is we are taking a donor tissue, that's the collagen allogenic intrastromal ring segment, and that is called CARES. This was originally invented and described by Dr. Susan Jacob from Chennai. It's a new modality for keratoconus, and I've just started using this. So just an example, I thought I'll share one interesting case. A 9-year-old male child came to us with allergic conjunctivitis, a lot of rubbing of the eyes, no family history of ectasia, and no surgical intervention. If you look at the right eye, 6/60, not improving with pinhole, neo was N36, not going to school, very unhappy. Left eye 6/36, improving by pinhole to 6/18, N6 at 10 centimeters, and of course with a -3 and -2 at 70 degrees. If we examine the patient on slit lamp, there is a lot of conjunctival scarring all over, thinning and ectasia in multiple areas. So I will show you the topography of both the right eye and the left eye, and the posterior segment was completely normal. Of course, we started the treatment for the allergic conjunctivitis, topical low-dose steroid, sodium hyaluronate, HPMC gel, increased frequency, cold compress, etc. And of course, told the parents and explained the value that the child cannot rub the eyes. Now, if you look at the right eye pre-op, you can see the steepening in the center of 49, 56, 70, and 56 with this extensive steepening in the area of the cone. At the same time, if you see the keratometry, it's 57 and 63. And the cone back is of course -8 and -2. Now the right eye, you can see the steepening, the Berlin-Ambrosio map also showing that the cornea is really thin, 240, 329, as you can see, the thinnest part. Coming to the left eye, which is a little better eye as far as the vision goes, again you can see the cone on the anterior elevation map, 53 and 54 was the pre-op, and with the back cornea back elevation, and this is the Berlin-Ambrosio map showing the keratoconus, but a little good thickness of 470 compared to the right eye. So the left eye was the good eye. This is a slit lamp images pre-op, the right eye and the left eye. So you can see the scarring in the cornea and the periphery. There is a thinning of the cornea in the center. Right eye was more involved compared to the left eye. So now the question is which eye to really treat and which plan will really work. So yes, we had choice of contact lenses, deep lamellar keratoplasty, there are chances of descendant perforation and rejection. Collagen cross-linking, there's some amount of haze and scarring is known. Intrastromal rings intact sometimes is known to exclude. There's a melt and there's sometimes a chance of epithelial ingrowth. So patient was advised C3R with intacts because there was no real other option for the left eye actually. So some of us seen that the intacts do have some own issues. So there is an immune reaction, I've seen this, there is a chance of corneal melt, there is sometimes a migration if we don't take stitches, and there is a chance of epithelial ingrowth. There is also vascularization going through the main channel. So this was presented by Dr. Susan, and she's now doing this since almost 5 years as corneal allogenic intrastromal ring segments, that is called CARES, and combined with cross-linking for keratoconus. So this was originally described by her, and she visited our center, and we are first in India and second in the world to do this procedure on the Z8 technology with the femto. So exactly how does it work? Let us, as I said, I treated only the left eye, and this is a pre-op image of the left eye. You can see that it's 53, 54. Going ahead and treating this patient, again, we tied the planning on the map itself. The beauty of using the femto is you can customize your corneal segment. So you want a tapering end, you can have that. You want a different arc length, you can have that. For this patient, we planned on the incision at the host a 290 depth, an incision at 225, so all of you can understand that 225 will come in one corner. The thickness was 750. The donor tissue that we are going to take is a 750 micron, and of course the width was 750 by 750. Why the width is at 300? Because we did a tapering customized segment. So this is what we planned for this child as far as it goes. Now, as far as the video goes, we are going to remove the epithelium. This is the donor cornea. So first step is to remove the epithelium. And we can make from one cornea 3 arcs. So you can do actually 3 patients. And I was surprised that it was so easy to do it. And if you read here, the resection depth was 829. A suction ring was applied. And this is the dimensions, okay? And this is what is happening. So we made 1 ring, that is 1 donor tissue was cut. And the same eye, we made another donor tissue. And here you can see the OCT of the cornea. The beauty of the Z8 system is that it's got a built-in OCT. So you can actually have the exact dimension. You can actually customize your donor tissue. So this is the arc length that we decided for the child. And this is how the marking happened, and we cut the donor from this. So this is all femto assisted. It's very, very precise. What I want you to notice is the ease with what it comes off the corneal tissue. There was absolutely, I thought there'll be some tissue bridges, some dissection really necessary, but really nothing was necessary. Just take a forceps and you can just pick up this arc length and just put it. Now here we marked. So because we did 5 cases on the same day, we made dots on this. So this you can see the ease. You can see with the forceps, I'm just picking it up and it just comes off. And because this was a patient number 5, and this is, you can see there are 3 cuts, I made 5 dots on the right surface. So because it was patient number 5. So this was just an easier way of doing it. Now this is as I said, a 9-year-old child. It was under GA. I've been doing intact, so making a segment on the recipient was very, very easy. I've never done manual intacts. I've always done femto-assisted intacts, and it works extremely well. It does very, very well because the femto tunnel is beautifully made with the help of the femto laser. This is the Z8 laser that I've been using. And once this is done, we have to put the segment that was cut from the donor into the tunnel. Now here is the tricky part, because the device of instruments that we had used, it's a modified instrument by Susan. It's a Y and a reverse Sinskey hook. And that's how we are pulling it. So you can see that intacts will have only one opening and not the other one. Here we have 2 openings. So this is 225 degrees and this is superiorly. I'm sitting superior. So we have made both the sides the opening. Okay, once that is done, we take the dried up cornea, that segment which was taken, and now we try to insert it into the eye. So the most important thing here is that the segment has to be properly dried. Then only it will go in, otherwise it's not going to really go in. Once it is dried, it can be pushed in like intacts, and then comes the tricky part where you need to take it towards the center. Okay. Now this can be done with the help of a Sinskey, reverse Sinskey, or a Bessett's Y, which is again bent according to the arc length of the tunnel that we have made. Once this is done, now this is the Y that we are using, and we keep pushing the segment ahead. Once the segment is moved ahead, we go from the other end to make sure that we have this is a reverse Sinskey, and then pull the segment towards the center. So you can see that the segment is being pulled towards the center, and then just make it even in the tunnel all over. So once that is done, we go ahead and do the cross linking, of course beyond the level of the segment. So if the arc length is here, this is again the Y, which is bent by her itself. And then use the same to push the segment ahead. Once that is done, just make sure that segment part is straightened, and once that is straightened, we just go ahead again using the Sinskey hook to bring the segment towards the center. Now I want to show you this patient's post-op results. Pretty encouraging. I was not expecting that kind of a result, but we are still doing a little study. We may do another set of patients in January and then see how the results go. Once that is done, we just straighten the segment and make sure that there are no wrinkles, because they tend to wrinkle or fold upon itself or twist and turn. So we have to make sure that they don't twist and turn and they are well spread in the tunnel itself. And once that is done, we just straighten it and do the C3R process that is done normally. So this is the first day post-op image. You will hardly see much reaction, but the segment, as you see, is sitting inferiorly, and that's where the mark has been made. The entry point of the tunnel can be seen quite clearly. So the OCT images, we have an anterion, which is an anterior segment OCT, and you can see that the graft is accepted well, there is no intrastromal haze, and it is sitting quite well. This is the anterior image which is coming from there, and the case segment is sitting quite well, and this is what you can really see. Now let's see the post-op image. So this is what was immediate post-op, and you can see there's not much flattening. What you would expect to get in Intacs is what I have found in my little experience, and I've spoken to Susan about it, but you can see flattening happening superiorly. The steepening segment becomes lesser. But what was surprising to me is the patient's vision improved drastically. So a 52, 53 became a 50. So in one segment there is flattening, and the other segment is 54, which remained the same. So this is the pre-op and this is the post-op. You can see both comparisons after 15 days. And after 30 days, you see the same result. So 53 and 50. Of course, we can have to wait for 3 months to get some idea as to where it is really stabilizing. But what is interesting here is the pre-op vision and the post-op. Patient actually can read 6/12 part with a -1.5 cylinder with some flattening of -3 spherical, which had actually disappeared. So this was, I thought, very, very interesting, and that this procedure really does work. So I think some part of our race is conquered. So I think we have to stay on course. So in conclusion, CARES compared with C3R is a good management procedure that is possible today. Results so far are encouraging, and we on the Zimmer platform been able to customize each segment from the donor because of the possibility of cutting it with the help of the femto. Never be afraid, always try something new, because life gets boring, stay within the limits, and you know what already you can do. Thank you all for your attention.
An excellent talk, Dr. Kumar. I have just one question. Do you give immunosuppression in any form to these patients?
Not really.
It's not required.
No.
And any advantage of CARES over Flex? Yeah, sorry,
Intacs.
Intacs. Yeah.
Cost. But I don't agree to that argument of cost. The reason being the artificial chamber itself is damn expensive. So if you want to use the artificial chamber and then get the software from Zimmer, the overall package is very expensive. So I still feel that Intacs would be a cheaper option. But patients, it's just a modality which I think does work. But there are no nomograms, like Intacs has something set in. So I've been talking to Susan about this for a long time, that tell me if this is the cone. Like if you see a patient with Intacs, the cone centralizes beautifully. The contact lens fitting becomes better. The best fit sphere becomes better. Now there is no data of this on CARES. So this is one hitch, and this is one patient I'm showing you. So I had two patients had hardly any effect.
So you use the same nomograms as you used for
Not
Intacs?
really. There is no
So
set nomogram.
created your own,
Correct. So we are actually, Susan has not laid anything on paper as a chart, that if this is your cone, this is how it should be, this will be a ring segment, this is the size. No, what she does is she looks at the cone, then draws the tunnel, and then decides 70% depth, and then decides the thickness. So I was actually talking to Dr. Kavita, who's also doing the same with Agarwal group, that we should actually maybe need a thicker segment. I cut 750 microns, maybe next time we'll do a 850 microns. To get a better effect, I need to be closer to the optical axis. So this was a little away from the optical axis. So one patient, you'll be surprised, we did it. In 2 hours, we repeated his surgery because it had no effect. But because I had the access that day, we could recut another segment, take the patient back in, remove the segment we had put in, and put in another larger segment.
So have you considered cross-linking, seeing the surgical difficulty in cross-linking the segment that you're inserting?
No, it will automatically get cross-linked.
I mean, the
So if you ask
difficulty
me,
that you're having in the surgical
correct. So if you ask me what's really working, is it the cross-linking, or is it the cross-linking of the segment, or is it the segment alone? So that answer is only possible if we put CARES and do not cross-link. Then we can get one eye that and one eye something else. Then you can have a comparison as to how much effect does CARES actually have by itself.
That would be a great help for.
Yes. Thank you. Thank you.
And so, which one is like more surgically you find it's like more challenging? This thing.
So
CARES or Intacs?
Intacs is very easy because it's a plastic. You hold it with a cups forceps and it just goes in, stays in its form, never changes, etc. Here I have found some practical difficulties. Like when we take the corneal segment off and we keep it for drying, if it twists upon itself, it's like a towel which is twisted. And once it's dried, we are putting the same twisted towel inside the cornea. So it's very important that when we take the segment off and keep it for drying, it should be very straight. That is part one. And then when it actually takes the shape inside the human eye, what is the shape it really comes to, back to how much size. So this is where the confusion is. But over time, I think if we all compile our data, we will be able to get some nomogram in place. Yes, I agree that melt won't happen, maybe rejection may not happen because it's pure stromal, very little, etc. But this we will also know, I feel, I was just telling Kavita, not today, intact complications. I have seen only one melt of my intacts. Over 9 years, only one patient has melted over 4 years. Now, these complications may also appear, but after 3 to 4 to 5 years.
Long-term data basically you don't
Correct,
have yet.
correct. Although Susan has been doing it for 5 years now, 2017 she started. But there is no concrete data.
Excellent surgery.
Thank
sir.
you. Thank you.
So now we would invite Dr. Shalini Mohan for a talk on phaco in post-keratoplasty patients.
Thank you so much, Chair, and good noon to all. Now, as we all see that so many keratoplasties are going on, and that is why cataract we can keep on getting after keratoplasty. So these are the clinical scenarios in which we can get so many of cataracts, maybe from grade 1 to mature cataracts. So what are the pertinent issues whenever we are dealing with these kind of patient? First point which comes to our mind is when to operate, what should be the pre-operative considerations, how to target emetropia in these subset of patients, which IOL to choose, any modification in pre-operative medication, do we need to modify our routine surgical technique, and what should be the post-operative consideration. So time of surgery is always a debate in these subset of patient, because ideally it is 3 months after complete suture removal when the astigmatism stabilizes. But we also have to aim that the cataract should be a lesser grade, so that we use lesser amount of phaco energy. But important is we should not aim before 3 months of keratoplasty. Now, what are the pre-operative consideration? It is important to improve the various ocular profile of the patients, because if we don't improve the ocular profile, the clarity of vision, the comfort and the infections, they may actually trouble the patient a lot. And then we need to have a stable keratometry reading also. So always do a tear film breakup time to check to the staining pattern, to check the ocular surface health, and then improve the ocular surface. Now, another thing is that whenever you have a keratoplasty which has been done after post-viral infection, don't forget to start acyclovir at least a week prior to your surgery, because recurrences are common after second surgery. Now, specular count is another very, very important parameter which we all should understand and do, because this actually defines the results in post-operative period and what viscoelastic you are going to use. And it is good idea to use dispersive viscoelastic with chondroitin sulfate to protect the endothelial cells, and also you have to give prognosis to your patient, and therefore you need to do count. And then corneal topography or a pentacam you must do to see the keratometric reading. Now, achieving emetropia is definitely a uphill task in the subset of patient. So optical biometry you have to do. Another thing is that you can feed in your reading on the website on the drhill.com and then get the accurate IOL power in these patients. For toric IOLs, it is important to check that the astigmatism is regular and it has stabilized. Then only plan a toric IOL, else you will land up in problem. Now, which type of IOL to use? Spherical you have to use. Toric, as I said, there are many patients who have this astigmatism after keratoplasty. Therefore, you have to check the stability of the astigmatism, but always avoid multifocals and trifocals in these subset of patients, because they tend to induce more of higher order aberration, which already the patient is suffering from. Now, silicons we don't use now, but we have to avoid if somebody is using. Now, in pre-operative medication, it is important to give topical steroid covers in these patients to avoid any graft rejection. Plenty of lubricants. In anti-glaucoma medication, I would like to emphasize, because almost 1/3 to half of the patients, they are using anti-glaucoma medication. So any miotics or prostaglandin analogs have to be stopped before surgery to avoid any intraocular inflammation. Then, regarding modifying our routine surgical technique, we should have our pre-operative basket ready with all the pupil expanders, CTRs and Ciones, because we might need all these whenever stuck up during the surgery in the subset of patient. Viscodispersive OVD I already said. Now coming to anesthesia, topical anesthesia can be comfortably used in these patients because already there is corneal hypoesthesia, and if you are comfortably doing surgery under topical, you can also complete surgery here under topical anesthesia, otherwise peribulbar block can always be used. Now it is important whenever you are making side ports, you don't hit the graft host junction because this is the weakest link, so always avoid the entry at the graft host junction. Side ports, if most of the time you have already removed the suture, but if cataract is mature and you have planned your surgery earlier, put your incision in between the sutures. Now releasing the synechia is another important step. Always stain with the trypan blue dye so that you can see the capsule nicely, and do good hydrodissection and delineation in your patients, and you try to use minimal amount of phacoenergy in these patients because corneal endothelial cells are already compromised. Putting a biplanar incision is a good idea to have a good and stable incision. Now here you can see a graft host junction is being hit, so avoid hitting this kind of graft host junction, otherwise you might land up in graft dehiscence. Now this is the first video shows a softer cataract, and therefore you can comfortably complete your phacoemulsification in these patients. Now this is another patient of post-keratoplasty surgery. Synechias are quite common occurrence, and you will see that many a times people also try to constrict. If you are comfortable with the pupillary size, it's okay, otherwise you can use pupil expanders also. So I think this video is not running. Now this is a toric IOL. If you have completely removed the suture, and then you can do your surgery routinely as you would do all for your toric IOLs. Marking is another important thing which you should do nicely. And then putting 1 or 2 suture sometimes is not a bad idea to stabilize the anterior chamber if required. So in post-operative period, steroids you have to use in higher doses than routine cataract surgery. Oral you might decide depending on the reaction of anterior chamber or the graft condition. But generally if you see the first post-op day, if you have done a nice surgery with viscodispersive OVD, it gives you good results. Cycloplegics I give to these subset of patients to avoid any inflammation, but try to avoid NSAIDs. It is not required in post-keratoplasty patients. So to conclude, I would say that proper and thorough insight in the pre-operative consideration is very, very important if you want to get good results. Safe and meticulous surgery and good post-operative management will definitely give you good results. Now this is the therapeutic keratoplasty with mature cataract, and we can see that just on 4th post-operative day, it went off very well. Thank you so much for your kind attention.
Thank you, Doctor. That was a great presentation. A few points that I wanted to ask you also was regarding the refractive stability, because many a times the biggest challenge that we face after keratoplasty patients, doing cataract and keratoplasty patients, is that most of the time we try to let the sutures remain for a very long time. And if we do not have a refractive stability and we do a cataract surgery, so making a choice of whether to go for a toric IOL or any other, that kind of choice is limited. So how do you tackle that?
So as I said that if it has stabilized, then well and good, but as you say, many times the patients are with sutures for prolonged period, so it is always better to implant a spherical IOL, because if astigmatism will change later on, then it will bother the patient. So better to implant a spherical IOL, and then accordingly later on you can manage your astigmatism with spectacles or with any other procedures like LRIs, and then you can manage it later on.
Thank you. So mostly just for the advantage of fellows, if you are removing sutures, give a period of 3 months for the refractive stability to happen before you plan for a cataract surgery.
And I just want to ask one more question. What IOL power formula, like calculation, you use in these cases?
Now, depending on axial length, we can use. Now, what I do, I just go into the mode of post-keratoplasty patients on drhill.com. I feed in data and then get the result and take emetropic power from that only. So that I have felt that gives very good results for my patients.
Case you are calculating of the cornea, of the post-transplant cornea, right?
Yeah, post-transplant cornea.
And what about steroids? Are you like more aggressive in using steroids post-operatively, or just the routine that we are giving to any cataract patient?
No, definitely I am slightly more like in normal cases we give 4 to 5 times a day, but in keratoplasty we at least give 6 to 8 times a day depending on corneal status also.
And you think about systemic as well?
No, systemic generally I don't use, but if there is sometimes maybe graft rejection is a risk, then we might give, but topical I give more aggressively in these patients, and pre-operatively I also start on topical steroids only.
Thank you, Dr. Shalini. So now I'll invite Dr. Kavita Roy for a talk on optimizing cataract surgery outcome in corneal diseases.
Working? Yeah. Please excuse my look due to conjunctivitis, the epidemic which is on. So I'll be talking about optimizing cataract surgery in corneal diseases. I think all of us, whether we are cornea surgeons or even just practicing general ophthalmology, deal with all of these common corneal problems. So that's what I've tried to cover. Starting with corneal ectasia, which is keratoconus, I think the most important question is whether to do cataract surgery alone. If you're combining with cataract with a corneal graft, then in which cases do you do a combined case, and if not, then in which cases you do a keratoplasty first or a cataract surgery later. So when are we doing a cataract surgery alone? Obviously in a much older patient where naturally he is now the cornea is cross-linked and it's not progressive, or in a younger patient where you've done a cross-linking. If there are some patients who are happy contact lens users, even if the corneal ectasia is really advanced, but they still don't want to do any corneal surgery. If the patient is unwilling for surgery for keratoplasty, then you do cataract surgery. Now the question is to use a toric IOL or not. The most important thing is you look at your topography. If the astigmatism is regular, then go ahead with toric, otherwise not. How do you decide? Like I said, if it's mostly central ectasia and not much skewing, then you can go ahead for a toric IOL. The holiday AKR report, whoever has a pentacam, look at that. If you see these kind of readings where the keratometry reading is so varied, I don't think these are great candidates for using a toric IOL. Just a regular monofocal IOL will work with them. And if you have done cross-linking, then when do you do cataract surgery? I think wait for at least minimum 6 months. If you can wait for longer, that's even better, because that's when it stabilizes. This is a 16-year-old female. She had this chronic allergic conjunctivitis which was treated with progressive K-conus. So we cross-linked her within a gap of 1 week and then planned her cataract surgery. Now cataract surgery, it is it's very much similar to doing your regular cataract surgery, nothing different in keratoconus. On the left hand side, if you see lower, if you see like you saw that IOL just rotated, I feel sometimes in patients with these ectasia, they have larger, also deeper ACs, then this can happen. It's a good idea maybe to use CTR, a capsule tension ring, in these cases. So that's the point which I wanted to add. So when are we doing cataract? If you are doing keratoplasty first and then cataract surgery, I think as Dr. Shalini has already talked about, that we first remove all the sutures and then wait for minimum of 3 months till the corneal shape stabilizes, and then only then plan the cataract surgery. Toric IOLs are definitely very useful. Now this was a patient where all the sutures were out. He was 6 months in, but you can see there's a large degree of astigmatism, almost 9 diopters. We did a toric IOL in him and he's really well. The tips doctor has already covered, Dr. Shalini. So use Trypon blue. Make sure you're protecting the endothelium and make sure your incision placement is accurate. She's covered most of these points, so I'm just going to rush through that. You make sure you're using a viscoat and a good viscoelastic, because this endothelium is not like your regular endothelium. It is going to be compromised. Make sure you're not entering at the graft host junction, and then most of the surgery should be in the back. Don't do an anterior chamber phaco, because you're going to damage your endothelium, and then you go ahead and place your intraocular lens. So this was a patient with keratoplasty first, then cataract surgery. You can see all sutures were out and patient is doing well. Now this is another patient where ideally he has a very dense cataract and this non-resolving eye drops. Ideally should have done combined surgery, cataract and keratoplasty, but his other eye also had very advanced corneal ectasia, and that's why I decided to wait. I was not getting any keratometry reading, so I decided to first go ahead with just doing a transplant even though it was a dense cataract. I counseled the patient, then removed all sutures, and then I got a very good result. This patient was 6'9", 6'12" uncorrected, and 6'6" best corrected. So that's a good approach sometimes to be more conservative than try and do everything at one sitting. Now if you've done a DALC also, similar rules apply. First you do your DALC, get all the sutures out and wait for 3 months. This is the patient, and then you can plan the cataract surgery. And also, of course, sometimes these patients are younger and they develop steroid they develop cataract much later, and that's when you go ahead and do your cataract surgery, pretty much similar to any other surgery. And when are you combining? If it is very advanced cataract along with advanced ectasia, like the the earlier patient which I showed, if you feel there is no choice, patient is unwilling, after counseling for doing a 2-step surgery, then you do a triple surgery. Triple DALC is obviously very difficult. It's not easy, because if you're trying to do a DALC, then you come to the almost to the deep stroma, and then you go ahead, you get a good view, and that's when you can go ahead and do your cataract surgery and then do the graft. Now, if you're doing triple PK, obviously the cons are that it's going to be an open sky surgery. So there is a good tip which I'm going to give to beat that. This is a patient again with ectasia scarring, planning a triple surgery in him. What you can do is you can first do an open, do a closed chamber phacoemulsification, and after that you can then refine. So this gives you more control rather than doing an open sky surgery. So this was just the tip that I wanted to share. This was a patient, did very well eventually. Let's move on to corneal scar. Corneal scar, all of us are dealing with that. Depending on the scar thickness, location, you can either use PTK, PRK, whatever need be. And if it's dense, obviously you have to do a PK. Now this was a patient with spheroidal degeneration with cataract. I decided to do a cataract surgery with keratectomy with an amniotic membrane. And because if you see, most of the spheroidal degeneration and Salzmann nodular type of degeneration is right in the center, and at the end of surgery I put in an amniotic membrane in him, and this is how he looked, I think at about 2 weeks in, and this was about maybe more than that, and we did PTK for him at around 6 months, and this was the final result. So sometimes doing multi-surgery, doing it phased stepwise is obviously helps. Now this patient, obviously it's very dense, nothing's going to work in him except doing a triple. This is what we did in him, and he's doing very well. Another tip which I've already given, if you have a failed graft and you are planning a repeat graft, again you can do similar thing. You can first just cut your, to partial thickness, get a view for doing your cataract surgery. Cataract surgery can be done using an endo-illuminator, and then like I said, you can go ahead with doing your keratoplasty. The other, I don't know how short of time I am. So, the other case is iris cyst with cataract. Now, this patient had been advised to go for a triple surgery elsewhere, but I decided to not do that because obviously with risks of glaucoma, and so I thought let's do it phasic. So we just did a iris cyst excision and planned a cataract surgery. Patient eventually did well. There is very minimal corneal decompensation, and even if he does need a transplant, now he can get away with doing DSEC, because at that point with the anterior chamber being so disorganized, it would have been very difficult to do a lamellar surgery. So now, even if he needs it, we can get away with doing a lamellar surgery. So pterygium, I think all of us are dealing with it. If you're whether to do combined or not, especially if it's premium IOLs, then do it like in 2 steps. Do your pterygium first and then cataract. If you're doing combined, then it's just like you go ahead and do your cataract surgery first, because if you do pterygium first, it causes a lot of bleeding. You don't get a good view, and you can mark the graft like that and just use glue and go ahead with doing your surgery. I think I just have one more slide to go. Trauma, do I have time or? So trauma is if you have corneal trauma with cataract, then when do we do combined? Do we do it at the same time? If it is a child, then obviously you're going to address the cataract at the same time. If it is a ruptured lens capsule, and if logistics or if it's combined with VR surgery. So these are a few examples of cases where you're going to do it at the same sitting, like at the left hand side, upper side, it's a child. So you do it at the same time. And this was a graft dehiscence with a total cataract, mature cataract. Patient was not willing for coming back. So that's the reason we did it at the same sitting. This was a patient where both were done at the same sitting. Patient's doing well. This is my last slide. So endothelial dysfunction, this is more I think for patients like cornea surgeons who are doing both. If it's early dysfunction, then please do only cataract surgery, but make sure you're leaving the patient myopic. If you have the patient with endothelial dysfunction, you want to go ahead and do the cataract and then refer to a cornea surgeon also, it's fine, but make sure aiming for at least -1 diopters of myopia so that the hyperopic shift is not affecting the patient. Here, most of your surgery can be done in the anterior chamber because if you're doing combined, because anyways you're going to replace the endothelium. So that's way you do it. You do most of the cataract surgery in the anterior chamber, and most simplest way if you're doing a DSEC is that you can just take your your graft and insert it in with a 26 gauge needle. I think that's the last slide here. Yeah, this is what I wanted to show. It's very simple. If you have a pre-cut tissue, you can just insert this if you don't want to do something more difficult, and you get great results. Thank you.
Thank you, Dr. Kavita. So again, the same question, what gap would you give between doing a cataract surgery and a DSEC in a phased out surgery?
Between cataract surgery and DSEC?
Yeah.
Ma'am, it would depend on what kind of, how is the corneal endothelium behaving. So generally, typically, if the patient's corneal thickness is 700, 750 plus, there's already pre-existing edema, then I definitely go ahead with a combined surgery. But if the patient's corneal thickness is less, like around 600, I think it's just a wait and watch philosophy.
Yeah, my question was, when we are doing sequential after cataract, how long do we wait for referring the patient to the DSEC, or whether you are a corneal surgeon and doing it yourself?
So it would probably depend on two things: the vision of the patient and the corneal thickness. If the patient is happy with the vision, the cornea is not edematous, there's really no reason to refer the patient. But if your cornea is edematous, the thickness has gone more than 650, 700, patient is not happy with the vision, then I think after 3 months, waiting for 3 months, giving adequate treatment, and trying to recover his own endothelium if it's not resolving. And always counseling is the key. You always tell the patient this is going to be a 2-step surgery, because if you've not diagnosed that endothelial dysfunction, then that's where the trouble comes in.
Right. So what I wanted to make a point was that again, wait for the inflammation to subside adequately,
yes,
and give an adequate gap before taking up for DSEC or any other laminar surgery.
Yes, ma'am.
Very nicely presented, and a series of surgeries.
Thank you. Yes, should I go ahead for that? Is it come up?
Audio visual, please help.
Yeah, I'll be talking about the updates in the management of keratoconus. It's a very, it's a very general talk. It's not very specific. I'm just covering a little of everything. These are the few points that I am going to cover. Now, starting with the definition of keratoconus, I think conventionally, especially when you're in med school, you're taught that keratoconus is a non-inflammatory ectasia of the cornea. I think now we know and we can completely debunk that it is not a non-inflammatory, disease. There is a quiet inflammation going on. There are enough and more studies which show that there is upregulation of all of these inflammatory factors in the tears as well as within the cornea. So we know that it's not non-inflammatory. Now, why I'm bringing this point up, because in all your keratoconus patients, it's important to include that in your therapy. Either you give cycloimmune, steroids, whatever, especially in the younger patients who are coming with allergy. This is an important point to remember, because unless you treat the inflammation, the ectasia is going to recur and keep worsening. This, of course, we all know. Pentacam is the latest, or any tomography is essential if you're trying to treat keratoconus. Progression, I think, very, very important to define progression, because nowadays each and every person is cross-linking just about anybody. I think please see the patient's vision, make sure that there is progression, make sure that whatever machine you have, if it has a good repeatability, make sure that there is increase by at least 0.5 diopters and there is a decrease in pachymetry. Of course, if the patient has come with a drop in vision, if his visual acuity and his refraction has changed drastically, then you don't need to look at these points. But otherwise, if it's a more or less stable keratoconus, then I would say this is an important parameter not to be overlooked. Now coming to the treatment algorithm, again, a lot of people are just cross-linking the patient and leaving them with best corrected visual acuities of 618, 624, 636, and you're not really doing the patient a favor by cross-linking him. Either rehabilitate him with contact lenses, do glasses, and because ultimately we are doing the surgery not only to change the corneal shape, everything is done for vision. So here it's just a small algorithm which we could follow, is that depending on whether the patient's vision is fine but he's still progressing, then only cross-linking you can get away with, don't need to do anything fancy. Now if the patient's vision is not improving, like the cases which Kumar also showed and few which I am going to show, if the best corrected vision is 618, 636, then we need to do something. Then depending on the thickness, either you're going to do a topo-guided treatment or trek, or you do cares, intacts, whatever you want. But make sure you're doing something to regularize the cone, otherwise patient's vision is not going to improve. And of course, if it's a very thin cornea, you have no option but to do a DALC. Now cross-linking, again, a lot of terms used. What's new on, we all know it was invented by Theo Seller. He started with using a lot of substances to cross-link the cornea, and then he found out that this basically riboflavin with UV light really works well. This is a point, I think, a slide, if there are any medical students here, I would like them to see that two types of reactions which are happening, type 1 and type 2. This is important because type 2 relies on oxygen, and that's where I'm going to come to that later in the presentation. Now we all know that this was the Dresden protocol, and of course Dresden really works. Now accelerated, why it was brought in? Because obviously no one wanted to sit for so long in the and do surgery for this long, and we found that accelerated really works well versus conventional. So not an issue, even demarcation lines are as deep. Now importance of oxygen, that's the point. Now what is happening is when you're using a large amount of if you're using like say a 30 milliwatt and doing it for a shorter time, the oxygen is depleting very rapidly, so it's not really working. So a lot of things like that's the limitation of the Bunsen law. So a lot of things were thought about giving pulse oxygen, but I feel it's better not to go for a much higher end of cross-linking. For me, in my hands, 3 milliwatt and 9 milliwatts works well. I don't go beyond that. If you have a thinner cornea and you still want to cross-link, this is a protocol, it's been published, you can use that. Make sure that you're then using only 3 milliwatt, it is safer. Even if it's a lesser thinner cornea, say 270, then it's around 3 to 5 minutes of cross-linking can be done. So you adapt the time of cross-linking to the thickness. So it's not that if it's a thinner cornea, you can't cross-linking. And an epi on, epi off, I think this debate has gone on for too long. What is important, this point is that if you see that epithelium is utilizing 10 times more oxygen than stroma. So obviously I think it's a no-brainer that the epithelium has to come off. How do you remove epithelium? Either manually or with lasers. You can use the PTK, either to just do a PTK, which is Creton's protocol, do a topo-guided, or do TREC, where you're doing topo-guided, topo-guided removal epithelium. I mostly do the, PTK, and I don't really do so much of TPRK also now. So these is a few of my patients where we just saw only cross-linking. If you see in cross-linking, in fact, initially for the first 2 to 3 months, sometimes the cornea used to become steeper and actually wonder what's going on. But then later, you do see a steady decrease. This is, I think, 6. In fact, this patient I have almost a 10-year follow-up on. It does work. Definitely cross-linking does work, but we are not doing anything to change the shape like we talked about. But here, if you do PTK with cross-linking, obviously because you regularize the shape of the cornea, it does, patient's visual acuity is much better, much faster. This is at 11 months, this is at 2 years. And what's important is that 60% of them showed a better improvement, like BCVA was better. So that's, I would say, is a huge advantage. What is new, this has been now, Dr. Farhad Afezi has been talking about this, where he's cross-linking at the slit lamp. I think if this comes, it's going to be great, because it's then very soon going to be an OPD procedure. We need to wait and watch. So what's new in cross-linking, that we can vary the time of exposure and even cross-link the ultra-thin corneas, and slit lamp and OPD base is definitely a possibility. Now, moving moving on to the next thing, intacs. Kumar's talked about this. Not going to talk much in detail, like a short video maybe for someone who's interested. Here you make those channels. Then after the channels are made, you use the instrument like incision opener. Here you open up the incision. There's a special forceps for holding the intacs, which has got a groove in it. With that you can, hold the intacs and insert it into the eye. Now, why have we thought about moving on to cares, and why not only intacs? Cost is definitely a huge issue. The artificial anterior chamber which Kumar talked about, we can use a regular Catina's chamber which just costs about $100. So, I think cost is definitely an issue with intacs, extrusion, develop inflammatory deposits. But yes, of course, cares is relatively new, so we don't know. We need to wait and watch. This was post, intacs. Now, cares, I think he's talked about this quite in detail. So, I'm going to run through this. Now, the advantage of cares is that because it's a corneal tissue, we can insert it closer to the visual axis, which is not possible in intacs because it's going to cause glare if it comes closer to the visual axis. That is, I feel, a huge advantage. When you're doing doing surgery or removing the epithelium and the endothelium, make sure to do that. Then you can refine it manually or with femto as Kumar has done, and can be combined with cross-linking. Now these are the instruments for refining the tissue. There are two trifines available, 6.58 and 7.75, 8.75, just 2-3 slides. So when you're using the 7.75, 8.75 millimeters, it's actually refining more in the periphery, so you get a thicker cornea. So it depends on your case selection, you can choose that, and these are the set of instruments. So here the point that Kumar made, that the cornea has to be completely dry when you're inserting it. I agree with him, it has to be completely dry, but after you've got it in the channel, make sure you ask your assistant to put saline, because then it passes much more easily into the eye. So just a few slides about this. This is a pre-cares. I don't have much very long follow-ups. It's just been 3 months since we've been doing it at our center. This was post cares. You can see there is a flattening, and even if, as he's saying, you really don't see so much of flattening on topo, but these are patients who are 6'18" best corrected before surgery, who are now coming to 6'9". I think that is definitely what I'm seeing. Maybe because we are going closer, the optic zone is at 4 mm, we are, that's where we are inserting it. I don't know, but patient's vision is definitely improving. This is another patient. This is a patient, like he said, she just marks it, that's how the planning is done. This is a huge problem. There's no algorithm, there's nothing. We just mark it on paper and we decide, okay, now we're going to put this here. And another issue I think Kumar has also probably mentioned, I'm not sure, is sometimes it twists like this. This was my post-op day 1, and because I used too much of the marking, the marker pen was too much, what I used, I could not make it out on table, and I saw it later, and initially because we went ahead and did the cross-linking, there was so much haze I couldn't see it. So, but what is the most important thing is this patient was 3/60 uncorrected and improving to 6/60 best corrected, and he has come to 6'9". So, and this is like, I'm absolutely stunned to see this kind of result. So I'm not saying that yes, this is the golden mantra, but yeah. So obviously if the cornea is so thin and it's like this, you have to go with DALC. I'll just beat like, and these things for completion, I just wanted to add this. I don't do this Bowman's layer transplant or Bowman's with stromal augmentation. Now the advantage of cares over this is that here you're not inserting anything in the visual axis. So I think that's a huge advantage. So somehow, like he said, if collectively people could pool together their data and find ways to improve, then I think cares is definitely maybe like the future. Thank you so much, and sorry to overshoot the time.
Thank you, Dr. Kavita, for an excellent talk. I think Dr. Vaniti and Dr. Deepak Mishra are not here, so we'll move on.
Thank you so much.
Any questions from the audience? I think she made a very important point that we should not cross-link each and every keratoconus patient, because many of them do not need actually. So I'll invite Dr. Ashi Kurana for her talk for management of corneal perforations.
Thank you. Audible, right? At the outset, I would like to thank the Uttarakhand Ophthalmic Society for inviting me for this talk. And my talk is on surgical management of corneal perforations. A few things that you already must be knowing, but I have the luxury of time today. So I represent CL Gupta Institute of Moradabad. So Corneal perforations, other than corneal perforations, desmatocele also is an ophthalmic emergency, and the primary aim of treatment is to stabilize the globe because of the risk of the sight-threatening complications like infections, choroidals, hypertonic maculopathy, and shallow AC leading to subsequent glaucoma. What can lead to this can be both infections, that inflammatory melts, as well as trauma. And clinically what you see is what can be the features could be an abrupt decrease in the visual acuity and sudden tearing. We all know we'll find a flat or shallow AC and a positive C2s with uveal prolapse and hypotony. And what can be the signs of impending perforations would be radiating folds from the base of the ulcer or a central clear zone suddenly that you see within the area of an infiltrate. So what else we have to be careful about is that in cases where you do not have a positive C2s also may be having a perforation, that is if it is a flat AC with absolutely no fluid in the anterior chamber, but that is also could be having a perforation. How do we manage? Don't patch the eye, always shield it, avoid all topical medications, and you can start systemic antibiotics, although that depends on what kind of infection is there, and operate as early as possible. So what is the basic workup? First, microbiology, because whether or not it appears to be very sterile, it still needs a microbiological workup. And also systemic, all perforation should, one should always have a collagen vascular workup also, unless it is very clear cut, only infectious in nature. So what anesthesia? If it is a very small perforation, give only topical or peribulbar if you feel that the patient is not cooperative. Bigger ones always peribulbar. And how do we give? Small doses, small boluses. Don't give a bulk of injection at one time, and massage has to be avoided. And to increase the duration of action of the anesthesia, you can add adrenaline or bicarbonate. If larger perforations, we have to prefer general anesthesia and try to ask the anesthetist to give hypotonic anesthesia. Okay, so what are the gluing methods? One is the cyanoacrylate glue, which is in comparison to fibrin glue is the preferable method because it is easier to use, it is cost effective, and it stops the stromal melting also in comparison to the fibrin glue. It also gives rise to some formalin molecules which also have a little bit of bacteriostatic effect as compared to a fibrin glue, which although it is more comfortable because it does not create that thick rock-like, stone-like appearance at the end, but it also carries the risk of transmission of disease, and it degrades so fast that the melting process comes up again. And what does the cyanoacrylate do other than that? So I just told you it delays the penetrating keratoplasty if the patient is waiting for PK. So even if it is a clear-cut perforation and needs to be sealed, at least you can glue it for some time and wait for, and mostly we prefer N-butyl cyanoacrylate. And the goal of surgery is to plug the perforation with the smallest amount of glue and under a minimal block so that we don't have more upthrust. Around the ulcer base, 1 to 2 millimeters of epithelium should be debrided. This is for the basic TABCL, but this is the basic technique. But mostly if you have a larger perforation, then you may need another technique, which is like using a sterile drape or a patch, or even you can use a bandage contact lens. You can use tissue pads or AMGs. So we'll just show you a video of how to go beyond a simple TABCL. And if you have a larger perforation for a patient who is waiting for PK, but you do not have a tissue available. This we had to do a lot in the COVID times when we did not have tissue and we had a large perforation. So first we tried to apply TA with the back of the Vexel sponge, but we realized that we are not able to seal the perforation. So what we did, the first thing is that we removed the TA. Now what it gives rise is to increase the perforation size still further, and we take a BCL, we size it according to the size of the perforation, then on top of that we apply the glue at the edges of the contact lens, which is the sterile contact lens. After having applied that, now you can have a watertight cornea, anterior chamber, and then we can continue with, the patient can wait for some time. You're buying time when we do a procedure like this. Complications of any kind of TABCL or a patch TABCL is that you may end up with a cataract, or you may have more infiltration, and it has reaction under the upper lid, and you have you may have more vascularization. So it is not a permanent thing, and the worst thing is that because you're putting a BCL, the patient has to come more frequently for follow-up. As compared to this, the more cornea friendly or more comfortable situation would be an amniotic membrane grafting. So amniotic membrane, you can put a single layer or you can put multiple layers. Single layer will be basement membrane and will be containing only the basement membrane and avascular stroma, so it is very thin and it will not be providing any tectonic support. But it does provide a scaffold for stromal repair, and the other advantage of using amniotic membrane is that because of its anti-inflammatory activity and non-immunogenic properties, we are able to utilize it. So it is going to, if you're using multiple layers, then it will restore the stromal thickness, and it has to be secured with sutures or glue. And this is how we do a multi-layered AMG. So if we have an ulcer, so this is a patient with so much of vascularization. If I do a patch TA on a perforation, it is not going to heal. So what we do here is that first we identify the area, and then we clear up the rest, the surrounding tissue, and then we put multiple layers of AMG, and sometimes we may even stuff the AMG inside the perforation. So with the epithelial side up, one on top of the other, and attach them with glue, and then we may secure it with sutures and then apply a BCL on top of that. Another very useful technique that that was used in the older times, which was very popular but is not so popular now, but it is really useful in perforations where you have shortage of tissue, is conjunctival flaps. And it has the advantage that it brings the superficial blood vessels along with it, and the most useful it will be would be the superior fonicial conjunctival advancement pedicle, or you can also use a Gunderson flap, but this pedicle flap is one of the most useful that we found in central perforations. For some time you can let it be and then operate on it again. I have the advantage of continuing because we don't have speakers
we after have,
this.
Time up till 1:25 and two more speakers.
Right. So I'll just run through the next very interesting. So Gore-Tex patches have also been reported, but not. I don't have any personal experience with it, but this has been reported to be used. A lot of other tissues which have also been used, but the most useful that I found was the Tinnan's patch graft. Tinnan's patch graft that you can see. There are a lot of patients where it can be utilized, like in herpes simplex, neurotrophic, dry eye diseases, cicatrizing conjunctivitis, but it is not going to cause any reaction. Surgical procedure is very simple, that you take out a patch, a small area of Tinnan's from underneath the conjunctiva, and it is like a tissue which is always available. It is not, you don't have to look for glue. So you just take out the small piece of Tinnan's and you place it, stuff a little bit inside the perforation. And then before that also you can have pre-placed sutures, or you can make a figure of 8 suture on top of that, keep it down, and then apply a drop of glue, allow it to polymerize, put in a BCL, and then continue. So this is this incorporates very well with the tissue according to this study which came, actually this has been contributed by the RP Center group, which is given, but later on more institutes have more authors have contributed to the use of Tinnan's patch graft. Histopathologically, it really incorporates into the tissue, and over a period of time, you can see that it fades away. Initially, it swells and it looks really white on the cornea, and then later you find that it improves. So I'll just show you a small video. It is really useful in patients where you are working with sterile cornea. I would not recommend for infectious. So this patient had a perforation, and I have placed some pre-placed sutures, and as you can see,
You don't always have to pre-place suture, and I just take a piece of tenons, stuff it into the perforation site, and after having stuffed it there, this was a sterile perforation that somebody had during the surgery, so I was called for correcting this. And once you stuff it inside the perforation, you apply a little bit of glue and tie the pre-placed sutures, have a figure of 8, and then cover it with the BCL. So this is how it goes. You can have modifications, you can have an AMG overlay, tissue adhesives, you have other options like you have periosteal flaps, autologous lamellar scleral flaps, pericardium. Other materials, as I have already mentioned, you can have corneal patch grafts also, and lamellar keratoplasty, as well as these are, I am just enumerating because of lack of time I cannot go into the details of all the points. Just a few points about what care to be taken in the presence of perforation when you are doing keratoplasty is that you have to avoid the best help would be to use a Fleringer ring and a freehand cutting. There is a risk of expulsion and a positive vitreous pressure. There is a risk of incarceration of iris. So it is a good practice to do a freehand excision of the corneal button. Use suction trephines and use tissue adhesives before trephining, so that you have a good base to operate on. I think I'll end my presentation here. It's instead of crossing over the time.
Just conclude like last 2 slides.
Okay, thank you. So there are other non-surgical managements also. What treatment choice will depend on the etiology, the site, and the depth of perforation. And so this is the slide that I would like to use as a guide to what to do when you have a perforation. Tissue adhesives have the advantage of they bring vascularization, but multilayer AMG does not bring vascularization. Tin and patch graft does not. But corneal patch graft and penetrating keratoplasty have obviously not required for this case. The cheapest option would be the tissue adhesive because it is always available, and there is no dependency on eye bank on the first three methods. And volume replacement, that means the tissue is actually replaced, TA is replacing the volume, whereas there is no risk of rejection in the first 2-3 perforation sites. So when you have a perforation, don't immediately think of sending the patient for surgery. You can have other options just like TA-BCL as well as Tennant's patch graft, which I would say in the presence of infection you avoid a Tennant's patch graft. If you have an infection, go for a TA-BCL. If you are suspecting a melting disorder, go for a multilayered edge. Thank you.
Thank you, Dr. Ashi, for such an exhaustive and a very nice presentation on managing of corneal perforations. Any questions? So we'll move on to the next talk, complicated cataract surgery with iridoplasty, and I'll invite Dr. Vipul Arora for the talk.
Good afternoon, respected seniors and dear friends. Actually, the topic is a little different. It encompasses that topic. I'll just start the video. So I'll be presenting some scenarios of challenging cases. The first is a pre-operative challenge which I faced few days back. So this was a 59-year-old male patient, one-eyed, and had a vision of 3/60, and he was a controlled diabetic with the NS2 with PSC cataract and with a paracentral corneal opacity. And the anterior corneal astigmatism was 1.5 diopters. And the opacity was coming in the way of the Myers. This is the IL Master 700 chart. Here we can see the anterior corneal astigmatism is minus 1.63 diopters, whereas the TK value is minus 3 diopters. So this patient has posterior corneal astigmatism of around minus 2 diopters, which is relatively rare because normally the standard posterior corneal astigmatism is 0.3 diopters. And so the IL cylinder which we have to correct in this case is around 4.5 diopters. So this is the normal scan which we usually see on optical biometers with the cornea and the lens, and this was the patient's where we can see the scarring in the posterior cornea. So we had to choose the best IL for this patient, either to take a TK value and choose a toric IL or a monofocal IL, or take only the anterior corneal value and take a toric or monofocal. And in all these four we have different IL options. Even the power of the lens was different in all the four. So this was a surgery, pupil was not fully dilated and there was a opacity, but surgery was relatively uneventful. The only thing was to make a choice for the IOL, and in this case we went for a TK value with monofocal IOL, that is 24.5 diopters, because the patient was one-eyed and diabetic, and so we didn't want to take any chances in this, and also did not want to redial the patient again and again if we put a toric in this case, and we gained a vision of 6/9 in this case. So we were right about the choice that if we are not sure about toric IL, we should go for a monofocal IL in irregular astigmatism. Second video, this case was referred to be by my ophthalmic colleague, where when he took this case, there was increased intraocular pressure. The iris started coming out, so he had to cut the iris and took the sutures and abandoned the case. I took the case 15 days after this, and here I was seeing whether this corneal opacity, this tag is intact or not. Using iris hooks to dilate the pupil, there was breach in the anterior corneal and anterior capsule also. So using 26 gauge needle, and there was some zonular dehiscence temporally. So completing the rhexis slowly and gradually and using dispersive viscoelastic, as AC was also shallow in this case. We can see there was some wrinkling also present, and it was discontinuous. Using lot of dispersive and cohesive viscoelastics to form the AC, and doing the phacoemulsification in the center, and I am not rotating the nucleus much because it unnecessarily will create stress on the zonules, and bringing the nuclear fragments in anterior at the iris plane and then emulsifying. So this technique help in reducing the stress on the zonules. After completing this phacoemulsification, the rest of the procedure was easy, and removed the suture. The next part of the surgery was to repair this iris, because this tag was relatively healthy, and so I had to do iridoplasty, passing 9-0 proline from one end and taking out via tram track needle technique from the other paracentesis end. And bringing this loop out and passing the distal end of the suture, giving 4 throws. So this 4th throw iridoplasty or pupilloplasty is very helpful because it gives a very good strength to the knot. So this patient did well post-operatively, but what happens when we face an unexpected challenge? This was a topical case, and as soon as the patient was moving his eye, I saw there was zonular dehiscence temporally. So there was 2 options: either I give a subtenon block and continue the case, I give a peribulbar block in this case and continued the case. So we can see the whole, while I am doing the capsular axis, the whole lens is moving, and I am facing resistance while doing capsulotomy, capsular axis, sorry. Putting a CTR in this early in this case, because I want to uniformly distribute the stress on all the zonules. And I'm using double dialer technique to put the CTR. These I'm also using capsular hooks. These are much better than iris hooks, especially in these subluxated cases, because this capsular hooks goes up to the equator, and so it additionally supports the equator of the lens, and the phacoemulsifications become much easier. And as a principle, should use lot of dispersive viscoelastic as well as cohesive viscoelastic, so that we do not get much, we get a stable anterior chamber while operating. Again, the principle remains the same, to bring the pieces in the center at the iris plane and emulsifying using Ahmed CTS segment to temporally support the bag. And so this patient also did well. Yeah, there was a tag in the vitreous. I did vitrectomy and took sutures at the end. The last case is this, when this was a case in the topical anesthesia. The phacoemulsification is over. There is a thin cortex in the periphery, but I think I did a overzealous attempt, and while doing this, I caught the equator of the lens. We can see it in slow motion. Yeah. But the good part was I did not pull the IA probe immediately, but kept it there, used dispersive viscoelastic from the side port. This step is very crucial in this, because if I pull the IA probe, the vitreous will come from that side. So it's better to form the AC first and then take out the probe. Put a CTR. And so the case is completed. So what we all do always isn't always perfect, but we must always do whatever we can in the best interest of patient, and should be ready to deal with unexpected challenges we might face during surgery. At the same time, we should be ready to refer or get help whenever necessary. The important point is to do no harm. Thank you.
Excellent presentation, Dr. Vipul. Any questions from the audience? So I'll call our last speaker, Dr. Ruchika Patnaik, for a talk on surgical management of acute chemical injuries.
Good afternoon, everyone. I'll try to be quick because I'm sure everyone's hungry. So I'm going to be highlighting the surgical management of early stage chemical injury. So let's go back to the basics first. You know, the older classification system which was used for grading chemical injuries, like the Roper Hall, which was introduced back in 1965, was based on limbal ischemia and corneal involvement, and basically grade 4 in this classification system was equated with a poor prognosis. But over the years, with better understanding of the pathophysiology of chemical injuries and management strategies, an eye with even 50 to 75% limbal ischemia can now expect a fair to good outcome. Also, the older classification systems did not take into consideration the conjunctival epithelial involvement, which is of considerable prognostic significance. In 2001, Professor Harminder Dua modified the older classification system, and this is what we use even to the present day. And basically in this classification system, the grade 4 in the older ones was subcategorized into 3 more. And basically this classification system takes into consideration the limbal involvement as well as the conjunctival involvement, and also has an analog scale which is a combination of both. And this gives us the flexibility to basically sort of have a crossover between the grades, and also have a very meticulous documentation of how the case is progressing or deteriorating with treatment. What are the basic goals of management of chemical injury? First and foremost is a thorough and meticulous removal of the inciting agent, controlling inflammation, promoting epithelialization, addressing scleral ischemia, exposure of the ocular surface and the IOP alteration, supporting repair, and last but not the least, preventing complications. Controlling inflammation and promoting epithelialization are mutually inclusive and go hand in hand. Now we all know that the first step when a patient of chemical injury presents to you is to thoroughly irrigate the surface with whatever fluid is available. But many a times, like for example lime, tends to form calcium soaps, and these form plaques which hinder further penetration, but at the same time are not removable with irrigation alone, especially when they are stuck up in the superior fornix, and they act as a reservoir for and leach out chemicals and impede the healing. So they can be removed with EDTA chelation, and sometimes when they are more deeply embedded, they need a surgical debridement. Many a times the underlying cornea or sclera can be thinned out in these cases and should be followed up with either a corneal or scleral patch graft. Now the role of steroids in controlling inflammation cannot be overemphasized, especially in the first 1 or 2 weeks when we need to maximize the anti-inflammatory effect. But after 2 weeks, the deleterious effects can become apparent and may be counterproductive. So this is where we need to be more watchful, keep a close watch on steroid use and also supplement it with either a BCL or amniotic membrane graft. There are numerous agents which promote epithelialization in chemical injuries, but these agents are useful in minor grade injuries. When we are dealing with more severe grade of chemical injuries, we need to have some sort of surgical intervention. This is a very beautiful flowchart which is described in the paper by Iyer et al. From Shankar Nethralaya, and it gives an algorithmic approach to management of epithelial defects. As you can see, larger defects on the cornea as well as the conjunctiva need to be managed either with an amniotic membrane graft or supplementing with a source of cells like alloslet or a mucosal graft. Now, amniotic membrane graft, as we know, provides a basement membrane for epithelial cell migration, adhesion and differentiation, and it also has anti-inflammatory and anti-scarring effects. Let's see this with this case of a 13-year-old boy who presented with extensive Chuna injury. As you can see, there is almost 360 degrees of limbal involvement and more than 50% conjunctival defect. So I decided to go ahead with an amniotic membrane graft in this case. And after 3 to 4 weeks, the amniotic membrane had disintegrated, but he still had a persistent defect, so I had to repeat the AMG. And after an AMG done twice, the epithelial defect finally healed. At 3 months, his BCVA was 612. You can see the surface is quite stable, but there is a significant amount of LSCD superiorly with early symblepharon formation, although the visual axis remains clear. This is another case of a 14-year-old female who presented 3 months post-Chuna injury. She was being treated elsewhere and managed medically. There was no history or documentation of any surgical intervention. As you can see at presentation, the surface is very inflamed. There is 360 degrees of LSCD with symblepharon formation inferiorly and a persistent epithelial defect with granuloma formation. So at this point, I decided to start her on very low dose of steroids and also planned an alloslet, but unfortunately she was lost to follow-up, and 1 month later, to my surprise, this is how she presented. The surface had almost completely epithelialized and inflammation had gone down, and this is her picture 3 months later. There is a 360 LSCD. However, you can see that her eye is now drifting out and she had started developing amblyopia. I had to eventually plan a slet for this patient, and you can see how nicely the islands of epithelium are growing out from the slet bits. And after 3 weeks, her surface is almost completely epithelialized, but the BCVA is 660. Now, the role of amniotic membrane in facilitating epithelial healing and decreasing inflammation is well established, but in more severe grade injuries, like grade 4 and worse, where there is extensive conjunctival involvement, there is a lack of cells for epithelialization, and this is where we need to provide an additional source of cells. These could be autologous conjunctival, mucosal or allogenic limbal, and alloslet provides this source of cells. How is it performed? Basically, the bare cornea is draped with an amniotic membrane, and 4 to 6 clock hours of limbal tissue is harvested from a recently acquired graft, preferably in the last 24 to 72 hours. This could be of a non-optical grade, and unlike an autoslet where we harvest only 1 to 2 clock hours of the limbal tissue, in alloslet we need a larger amount of the tissue, 4 to 6 clock hours. This is because we are implanting the cells in a hostile environment. This is an inflamed eye and we expect most of these cells to fail, and that's why a larger amount of tissue needs to be transplanted. The limbal tissue is cut into small bits and placed in a concentric manner in the mid-periphery, sparing the center of the cornea, and finally a large diameter bandage contact lens is placed. So this is the case of an 11-year-old female who again presented with Chuna injury 1 week later. She has 360 degrees of limbal involvement with extensive conjunctival defect, and alloslit was performed for this patient, and you can see how beautifully the epithelium, the surface has epithelialized with a corneal phenotype with minimal scarring and conjunctivalization, and her BCV at 3 months was 6.9. So in the three scenarios, you can see how the outcome is visibly different when you do an amniotic membrane graft versus an alloslit and when it is medically managed. So promoting early epithelialization of the surface reduces the risk of scarring and inflammation and helps in early visual rehab, particularly in the pediatric population, which is of prime importance. It also reduces the need for subsequent lamellar penetrating keratoplasty, which further alters the prognosis. Severe grade chemical injuries and non-healing defects can lead to significant thinning and stromal melts, which need to be addressed either with a tissue adhesive, a multi-layered amniotic, or a lamellar keratoplasty. Now, Dr. Ashi beautifully showed a video of a multi-layered AMG, so I'm not going to go into the depth of it. So basically, you can take small bits and stuff the area of melt and then patch it with a larger AMG. In most severe cases of melt, a tectonic lamellar or penetrating keratoplasty may be required. Scleral ischemia is another important prognostic factor which needs to be addressed seriously. When it is localized, you can observe it, but if there is further worsening or if it is generalized scleral ischemia, a tenonplasty needs to be done, which is based on the principle of using vital connective tissue within the orbit to re-establish limbal vascularity and facilitate reepithelialization. We all know that sclera is an avascular structure which derives its blood supply from the overlying tenons and episclera. So the tenons is separated from the overlying conjunctiva and mobilized from the post-equatorial or phonesis, and it is then sutured up to or placed with fibrin glue and brought up to the limbus, and that provides a vascular bed for the residual conjunctiva to epithelialize the surface. Another important point that needs to be addressed is exposure. When the exposure is mild, a lateral 1/3 tarsorrhaphy can be done, but in most severe cases of exposure, you may have to do a total tarsorrhaphy along with Eshka cut down and skin grafting. Tarsorrhaphy is a very simple procedure, yet it goes a long way in healing persistent defects and severe grades of chemical injury. As it has a multi-pronged role, it reduces the blink-related microtrauma and mitigates exposure. To summarize, acute phase management is crucial, and it's important to follow the treatment principles and anticipate complications. The treatment in chemical injuries can be time consuming, requiring multiple surgeries and often a team approach. The long-term outcome in chemical injury depends on acute stage management. Thank you.
Thank you, Dr. Rujika, for an excellent presentation, and I think this is a very important topic, especially for the residents, how to manage, because early management will decide the fate of the eye. Any questions from the audience? So I think we'll end up the session, and I'll hand over the mic to the retina session. Yeah.
I know the audience is less, but Professor Jagat Ram has said, let's start, and whatever we'll still discuss it out, and number of speakers also are less. So I'll start this session, and after that I think Malaya will speak, and then Madam will speak, then Tinku will speak. You will speak after that. No? So I'm going to start this session on PDR. Proliferative diabetic retinopathy, I think all of us encounter, but everybody manages it the way they are trained to. So I'll try to convince you how we manage and how we optimize the management of PDR. And at the outset, I still believe that laser is the still mainstay of treatment in PDR. Intravitreal injections which are being pushed by companies, have an adjunct role only. I never initiate a patient of PDR with, although you see in the other hall we were listening that PDR management today is intravitreal. So I'll try to convince you why it is not. So laser, as I say, is the mainstay, and when it should be done in PDR, with HRC always, without delay we should do the laser. Without HRC also, you see, to me, any neovascularization in the retina calls for a PRP. I do not, because the follow-up of these patients is not so obvious. So what we do is any neovascularization in the retina, generally, unless it is small NVE, we call for pan-retinal photocoagulation or a full scatter letter for photocoagulation. And even in patients who have NPDR, non-proliferative retinopathy, severe or very severe, we start motivating these people, and if it is a one-eyed patient or if the fellow is lost because of complication of PDR, we start lasering these patients of NPDR, severe NPDR. And all of you know what is severe NPDR is a 4-2-1 ka rule. 4-2-1 ka rule is very well known to everybody. The other is, suppose I am planning a VR surgery, suppose in this patient. So whatever is the visible area, we will start lasering this patient, because we believe that lasered eyes in surgery do better than non-lasered eyes. So whenever possible, start lasering, but start preparing for surgery very early. Don't postpone surgery for weeks or months. So PRP, as I said, has been the gold standard of treatment for proliferative retinopathy, and this was demonstrated long time back, more than 4 or 5 decades back, and we still have patients who come where we had lasered in RP center more than 25 years ago and maintaining good 6/6 vision. But what has happened recently is this protocol S came up where PRP was compared with anti-VEGF, and what was found was that treatment with anti-VEGF agents results in a visual acuity which is non-inferior to the PRP, and this disturbed a lot of retinologists, as if anti-VEGFs will become the treatment of choice in patients of PDR. But that was not to be. Believe me, I still stand here to say that PRP is the mainstay of treatment. So how do I incorporate in my own practices? I will give you 3 or 4 examples. Jagat Ram ji, the example दिखा रहे हैं. ये एक patient है PDR. You see how much is the proliferation here. This is the front here. So what I have done here is, we gave one injection of this biosimilar, but immediately lasered it very well. And now you see how this patient has responded. The reason I gave this injection was we wanted to shrink these vessels for some time, and primarily because this was a massive front very close to the macula. If you do aggressive treatment here, patient can have ERM formation and sequelae of that. This was another patient, one-eyed patient, PDR. You see, this is the optic nerve, and this is all non-perfused area, and so many fronts are there very close to the optic nerve head. So in this patient again, one injection we gave of Razumab, and this resulted in these fronts are no longer visible. This is the follow-up of the same patient, and then we lasered this eye. But I still depended on laser only. Laser is still the mainstay of treatment. This is a story of another young lady actually, IDDM patient, irregular follow-up, glycemic control not very good at all. And this lady, young lady, this is the right eye of the patient. There is a rapid progression of PDR since 2018 से लेके 2020-21 तक. This lady actually, since this time, 6/9 vision was being maintained. So 6/9 vision, obviously I don't have guts to go inside the eye. You cannot do a daring surgery of vitreoretinal surgery. So then in November she lost this vision in the right eye, and you see there is a combined detachment in both the eyes. This was the time when finger counting we subjected to surgery. So do not show very much aggression in patient of diabetic retinopathy, that you go inside in a good seeing eye. She works in a Google company, and 6/9 vision was very good for her, and there was no problem in her day-to-day work. This was the other eye of this patient, and you see how this was the follow-up from 2018 till she developed detachment and we operated. I'll show you the video of this patient also. Here is example of a lasered PDR, but this patient, a young male, relatively young male, had recurrent bleeds, major bleeds. Every time he will come, we'll have a picture like this, upper left corner. So in such patients, early vitrectomy should be done, because we want to get rid of this vitreous. If vitreous is there, gel vitreous, it keeps pulling, and therefore recurrent bleeds happen. So in such patients, this surgery gives a good result. This is the video of this patient. Surgery does not take much time in these patients because retina is on. You just sever these connections. You see this segmentation is being done from this fibrovascular front at the optic nerve head. You can give anti-VEGF agents prior to surgery. So main job is to this NVD on the surface of the nerve head, and then you do the rest of the clearance of vitreous hemorrhage. You should not be very aggressive in doing base dissection as such. You can just go slightly anterior to the vortex vein or near the equator, but major base dissection is not required in this. And macula is very good. So once you are doing a diabetic vitreous surgery, pay attention to disc and macula. If they are very good, please tone down your aggression. And then we started lasering these patients. Your surgical time was actually 10 to 12 minutes, but laser took 20 minutes for me to do. And laser, I'm not very fond of doing laser in a proper manner, parallel to the vessel, and a good PRP, believe me, endo PRP being done. And at the end of PRP, and since there was hardly any traction onto the retina, we did only air fluid exchange. We did not inject any gas also. But why I want to show this video was the utility of laser, how the laser should be done in such patients, and then do an air fluid exchange and come out of it. That's the end of surgery. And this is the first day post-op patient, air being there, pre-op and post-op compared, the other eye of the same patient also. So this is the story of that young lady which I had shown you, a relatively small pupil, non-dilating, and we did this MIVS surgery, and you notice she has a reg RD also, combined detachment traction as well as reg detachment. So what I started with was, after doing core vitrectomy, just give a small pull on the optic nerve head. The reason of this pull was to insinuate the instrument so that my vitreous curtain can go in the safer zone. So now that there is a small separation between the retina and the membrane, so the cutter can insinuate, so that I can do some segmentation. So this segmentation has been done, and similarly I will do multiple areas of segmentation going in between the retinal folds, but be very careful not to. Then you can employ various instruments apart from cutter. You can have a spatula, you can have an MVR blade, depending on the. I'll take one more minute. And then you do multiple areas of segmentation. And when these 4 islands of segmentation were made, we injected PFCL just to gauge what more has to be done. And then we carried on the peripheral vitrectomy, as you can see nasally, and more membrane dissection. This was an MVR blade just to create a plane again. And then I thought we should go in a bimanual surgery now. So we inserted this 25 gauge chandelier system and took forceps in one hand and scissors, curved scissors, the best instrument actually, and lift up the membrane, and this fibrovascular small stalks which are holding, they have to be cut. The advantage of bimanual surgery is precision, because once you hold, you can precisely cut. The disadvantage of cutter is it can do an inadvertent cutting. So once this membrane is cut, then they take a cutter inside and take out this membrane entirely, and then take care of the bleeders, take out the PFCL, air fluid exchange done, and then injected silicone oil. This is the end of this surgery. Multiple breaks were there which were taken care of, and ultimately this patient had good vision at the end of surgery. So So we'll skip this video. So indications of vitreous surgery in PDR today are not vitreous hemorrhage, but primarily a macular TRD. They are becoming more common than the vitreous hemorrhage. So these are a couple of pre and post examples. Above one is the pre, then is the post, 618, 612 recovery. This patient had bilateral TRDs, fortunate to have 6/6 in both the eyes. This was one-eyed patient who was referred. He recovered 6/18 after doing this vitrectomy from PLPR. So thus to summarize, management of PDR, how to optimize. Laser is the mainstay. Good scatter laser, believe me, has saved many eyes for several decades now, and that is still the gold standard. Anti-VEGF, although studies have shown non-inferiority protocol S, but there is an issue of repeated injection, repeated cost, repeated visits to hospital, which is not cost effective at all. So indications may be small oozes despite laser. You see, if eye has been lasered, good vision, small ooze, you can go ahead and inject. Or as I showed you, posterior pole fronts, which are large fronts, you can do. But otherwise, early vitrectomy for long-term stability is a good surgery. But aggression during diabetic vitrectomy should be calculative, depending on the health of the disc and macula. And don't wait for a very long time. And prognosis, believe me, with MIVS and a lot of instrumentation, small gauge has improved quite a bit. Outcomes have improved primarily because bimanual surgery is possible, and pre-op anti-VEGF you can give in a lot of these patients, not as a routine, but in angry looking fronts you can give anti-VEGF. Believe me, it's not a simple procedure. What looks simple generally may not. PVD is difficult because it is adherent quite a bit, and two B's are important: breaks and bleed. So if you pull too much, and if it's a vessel, it will bleed, or the tissue may get separated, you may have a break. So you have to try to avoid all these iatrogenic issues in diabetic vitrectomy. And solution is work slowly. Do not pull too much. Do a lot of segmentation and delamination, and always have a new probe which has a good cut rate and a very fast cutting rate, and use bimanual technique very often. So diabetic vitrectomy, patience is the key. If it's a diabetic vitrectomy, I will never keep diabetic vitrectomy in the first case. So we'll keep it as a first, either the last case or the only case. And as I said, do a traction test to pull, do more of segmentation, and hemostasis is the key. Never allow the blood to collect, because if the blood is collecting, it will form another membrane, and later on it may take a lot of time to clear this blood also. So as soon as you see blood, do diathermy, raise the bottle height for some time, or raise the IOP. And last, which is most important, is a full scatter laser, even till ora serrata has to be done, because that is the only time you will have a good opportunity for laser. Thank you very much for your kind attention. Any questions by anybody? I would love to. Yes.
If a patient is developing early diabetic retinopathy, if a patient is developing very early diabetic retinopathy and you perform vitrectomy, does it help in stopping the progression?
People have burned their fingers by doing that. You see a lot of people propagated that vitreous is the enemy. If you create a PVD by doing early vitrectomy, then the whole life is safe. But that is not to be, because iatrogenic issues crop up. In fact, people, not only surgery, people also started doing some injections inside the eye just to create PVD. And a lot of this work was done even in patients who had 6/6/9 vision. But ultimately this was given up because the number of eyes which are not doing good ultimately was not much. So in a patient who has early diabetic changes, early surgery is not recommended.
Sir, what are the anti-VEGF you will advise first, second, then next? The lot of anti-VEGF for general ophthalmologists.
So today, honestly speaking, biosimilars are ruling the market. You see, biosimilars came into vogue primarily because of cost reasons. And the Intas Razumab was the first biosimilars which were launched across the globe. Ranibizumab was the first biosimilar made by Intas which was launched across the globe for the first time, first biosimilar. And that, honestly speaking, is the agent of choice today because of cost reasons and efficacy also. You see, when we started using biosimilar a couple of years back, the issue always with biosimilar is safety, because safety is first concern in any drug, efficacy comes next. So because we don't want to spoil these eyes, they are good seeing eyes, middle-aged population. So to answer your question, although aflibercept protocol T shows that that is more efficacious in this, but if you economize, like ILIA for You program has come now, and that cost now has come down equivalent to biosimilar. So if I have to treat diabetic macular edema, I'll start treating with aflibercept today.
So why is it that despite best of the glycemic controls, some patients develop diabetic retinopathy earlier and others do not?
So this, you see all these politicians who keep eating kajus and all these things, they hardly develop diabetic retinopathy. Except Sushma Swaraj, she had a bad PDR and she had to be lasered multiple times, ultimately underwent vitrectomy also at Shankar Nethralaya. So the reason is because diabetic retinopathy is a multifactorial disease. It's not only glycemia. There are a lot of other factors which play a part, which includes blood pressure, which includes lipid profile, which includes kidney disease. So there are multifactorial, even anemia. So all this can exaggerate diabetic retinopathy. Even sleep apnea, people who have short necks and all, if oxygenation does not happen. So there have been studies where it has shown if you give that CPAP, this retinopathy may improve. So the answer to your question is because it's a multifactorial etiology. It cannot, because glycemia is one part of it only.
Thank you.
Yes, Ting. What's the genetics? Yeah, genetics, yeah, true genetics. The reason I did say genetics was genetics we keep blaming, but we have nothing much which we can modify. So that is the reason. Genetics does play a huge role, but we can't modify those factors at all. That is not in human hand. So what is in human hand, we should definitely tackle.
Thank you, Dr. Lalit. Dr. Lalit, thanks a lot. What I like your presentation, I do not understand much about retina. The painting you have made, very good painting, white spots. Even we cannot paint on the paper, the white spot you have painted by the laser. The beautifully painted.
Yeah, the reason.
Well, space was the same, almost all the laser marks. Beautiful. You have not left a single point without laser done.
No, the reason, Sudhanshu, I never wanted to show that video. The reason I want to show was precisely this reason, that laser scatter, a lot of people do tuck, 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 tuck here and there. But if you follow vessel from, say, near the optic nerve till the vortex vein, then follow one more line, this patient, to my thinking, will do very well, because we do not leave, bare islands there. If you do tuck, 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 it does give, but I am very fond of doing laser in a very, ornamental way.
Sir, you have covered the second talk also?
Whatever.
Your second talk also, sir.
Malay does not allow.
You speak, sir. Continue. You speak in continuation, sir. Your second talk. Management of vitreoretinal interface disorders. You continue in the.
There you go. So I'll speak something about the interface pathologies which are becoming very popular also, and lot recognition is being done. Interface pathologies basically are 4 of them: VMA, VMT, macular hole, and ERM. You see, all of us are born with a gel vitreous, 100% gel vitreous. With age, what happens is that this vitreous becomes liquefied. And second thing which happens is that the adhesion of the vitreous to the retina becomes weak. And if these two go hand in hand, that means liquefaction bhi ho gaya and adhesion bhi khatam ho gaya, then you get complete PVD. Complete PVD, then you are immune from lot of diseases. And in this process of complete PVD, you may have flashes and floaters. Sometimes HST formation may happen. But sometimes what may happen is vitreous to liquefy ho gaya, but adhesion is not relieved. So this is a situation of anomalous PVD. This is not complete PVD. Because liquefied ho gaya, but adhesions are still there. That is what leads to all these interface disorders, which are named as VMA, VMT, and ERM. So this is VMA, and VMA, I believe, is there in everybody. Everybody, there is adherence of the vitreous to the retina. But good is that it is not pulling. So if it is not pulling, you don't have to do anything. But if there is a T component, the traction is there, that means the pull is there. Once the pull is there, suppose this vitreous is pulling, so that will cause irritation of the photoreceptors. Then you will have metamorphopsia or decreased vision. So this pull component is not very good for the eye. So then this complaints may occur. So important is, do all OCT diagnosed VMT require treatment? Answer is a big no, because in OCT you will see often VMT is there, but patient is not aware also. And a lot of these patients may have what I call tolerable metamorphopsia. Doctor, he will say, Doctor sir, kabhi kabhi teda dikhta hai. So kabhi kabhi means you have to observe only. And a lot of these times, sometimes if patient is lucky and you are lucky, complete PVD may happen spontaneously also. So I'll show you this example. Right eye of this lady we operate for macular hole. You can see this. Left eye OCT was done, but this was the left eye picture. You see there's a VMT. Patient is not aware. Asymptomatic patient. So obviously I did tell this lady that you have this, but beware of this. That's all. And believe me, this lady is now under follow-up for last more than 10 years. Same picture, 6x6. This is another example of patient. You see, this was the picture in 2016, lower one. Gradually his VMT increased and patient started complaining of near vision issues. So I started, motivating her for surgery because vision is getting affected, near vision and metamorphopsia. But before I could undertake surgery, spontaneous separation of vitreous occurred. You can see this same patient, same section, spontaneously vitreous alag ho gaya. Alag ho gaya means patient got complaint gone. So obviously I don't have to intervene at all. And patient recovered 6x6, near vision improved, VMT, spontaneous resolution. So management of VMT is only if patient is symptomatic. We are not treating OCT, believe me. We are not treating OCT picture. So only if patient is disturbed by metamorphopsia. So always ask patient, aapko takleef kya hai? Don't go for OCT picture. If patient is complaining by bahut teda dikhta hai and he can't carry out the day-to-day activities, then go in. And basic aim is to remove this traction. Whatever is this green line visible here on this pseudo color image, basic aim is to cut this, that's all. You don't have to touch retina at all. Most of us have been doing surgery, but in between came these injections. An injection which came nearly 10 years back, known by the name of Jetria, and it came in a big bang actually, and thought that it will take away all the vitreous surgery from people. Came with a big bang, but went away with a bigger bang actually. Bigger bang. Not only it was expensive, single injection $4,000 US, but apart from expense, the issue was the miserably low success rate. With one injection, success rate is 27% only. Whereas we are used to having success rate of more than 95% in patients of such. So obviously you can't substitute a 25% with 95%. Further, there was complications also. Then this recent study 3 years back where they compared ochriplasmin Jetria vis-a-vis vitrectomy, and what was found was with ochriplasmin 50% resolution only, and in eyes which underwent vitrectomy, VMT is on 100% of the patients. So that is the support for surgery. And surgery today with MIVS has become reasonably simpler also. So some surgery is definitely more definitive, and the only thing you have to do is do a PVD induction. Believe me, not a great job. And role of ILM peel, all this membrane peel is not there in such situations. A lot of people, once they go inside, peel off all the membranes, which is not required. And you all either do a fluid exchange or you, put in a gas. So this is a very old video which hopefully it will play. So we do a core vitrectomy. After that, put some crystals of triamcinolone in the eye. And triamcinolone has the property of they get adsorbed onto the surface of vitreous. And once they get adsorbed, so then you increase the suction, engage this vitreous, and gradually, but keeping an eye on the surface of retina always, because you don't want to cause complications. And once you have engaged the vitreous, pull up to the optic nerve head. The end point is always this signet ring formation at the surface of optic nerve head, because once you are near the disc, you see I am applying more suction, and this roundish signet ring now will form here, round. So this is the end point of PVD creation. So this is a pre and post photograph of patient who had VMT, and fortunately this foveal contour comes after this surgery. And this is another patient of VMT, but you see on the right side how much is the tenting of retina. If you pull this vitreous too much on the upper right side corner, believe me, you will create an iatrogenic macular hole. So don't be blind once you're putting suction. So what I did in this surgery was, after doing a core vitrectomy, we went round and left this central island free. This is known as foveal sparing PHF. You can see the central island, transfluon is still stuck here. We are not pulling this, because if you pull this, believe me, you will create an iatrogenic macular hole. So this was the end of surgery, and you see the same patient I have shown here. This was the traction like this, and at the end of foveal sparing PHF dissection, the contour has returned back. No ILM peel was done, nothing else except air was injected. So in VMA and VMT, the culprit is posterior hyaloid, and ERM, there is a membrane upon the retina. ERM means epiretinal, epi means upon the retina, and in macular hole, ILM is the culprit. Those three membranes are important: PHF, epiretinal membrane, and ILM. So ERM surgery again is not a very difficult job after you have taken care of the hyaloid. Then this is one surgery, This patient has dry ARMD apart from epiretinal membrane. So you do a triamcinolone assisted vitrectomy, and after you have done that, this is a phakic eye. I inject air, make it air-filled eye, and under air, then we will inject 1 or 2 drops of trypan blue. This is posterior pole being dried with the help of backflash needle. Now you inject 1 or 2 drops of trypan blue and wait for a couple of minutes, and then under air I will take out this trypan blue dye. This trypan blue excess is being taken out, and once you take out this, after that the best instrument to use is a 25 gauge MVR blade. Purpose of this MVR blade is to identify the plane, and once this plane is identified, that means you are in the safe plane, then you take hold of any forceps, preferably a card forceps, and take off this epiretinal membrane. Most of the times, 100% of the time, this epiretinal membrane will come in a single sheet of membrane, and then you can do airflow exchange. And this is the pre-op and post-op patient. ILM peel, as I said, we do try, but we don't insist. I will not spoil the retina just for the sake of ILM peeling. The last surgery, I will just show one video only and then wind up, is the macular hole, where ILM peel is the, after you have taken care of PHF, after you have taken care of the ERM, then comes the third membrane, which is actually a part of retina. ILM is a part of retina, and the job has been made easier by the injection of BBG dye. So this is the BBG dye being inserted in this patient, and after you have waited, no longer we use this diamond dusted scratcher because it causes more harm. So favorite instrument now is direct pinch and peel technique, whereby you take this ILM, and in the first go itself you try to peel ILM till the arcade level, because first surgery, believe me, is the best surgery. Second surgery is never the best surgery. So you take off this ILM and then do an airflow exchange. So this is the result of this patient, the OCT, nicely closed hole. So most of the time we peel ILM, but of late large macular holes and this hole like this, which is 1700 microns, in such patients we, instead of peeling ILM across the macular hole, we make multiple flaps of this. So same BBG dye, here direct pinch and peel technique, make multiple flaps of ILM and take it till the level of edge of the hole, make multiple flaps like a cabbage, cauliflower type, and these multiple flaps are then left at the edge of the hole, and at the end of it you can take a cutter and with this 50 millimeter suction, trim it and then do an airflow exchange. So this is the end result of the same patient which I had shown here. Again another patient where ILM flap surgery was done. So this video I will skip because of shortage of time. So OCT has made the job easier. New theories of PVD we have better understood, and a lot of these new drugs which I said came with a bang and went away. And with MIVS and staining agent, like 3 staining agents I told, the job has become relatively simpler, because staining helps you to identify the membrane, the culprit, and do a precise job. And a lot of these patients are very, very thankful patients, because not only symptoms but vision also improves in these patients. Thank you very much for your attention.
Thank you very much, Dr. Lalit, for the wonderful presentation. Very, very nice. I have a very simple query. Suppose you have a VMT, the cases you have shown, many of these VMT cases, and if the patient has to undergo cataract surgery, so what would be your advice like in that particular situation?
RP, excellent question, but honestly, most of the macular surgery, we combine cataract surgery along with the vitreous surgery. Majority of the patients of VMT, we take it, if there is a minimal cataract also, we will take it along. Because cataract tends to increase after vitreous surgery. So, a lot of times cataract surgery will come and do cataract surgery, after that we will do the surgery for VMT or the macular hole or the ERM. So, it's generally a combined surgery.
We need to combine both the surgery together.
So, that I have one video where I have labeled as a 4-in-1 surgery. 4-in-1 surgery means cataract out, then PHF out, then ERM out and ILM out. And all this thing will not take more time, maximum of 45 minutes or this will take. But trend is to do a combined surgery along with cataract surgery.
And any specific advice, like patient, those who have this huge amount of VMT, so any specific advice for their lifestyle?
No, I don't think so. These patients don't require positioning also, unlike macular hole, where we do position for a day or so. VMT does not require any kind of positioning post-operatively. And a lot of these times we leave under air only. We do not inject gas also. Silicone oil is out of question. Macular hole, we do inject gas, short-term gas, and advise them prone position for a day or so. Because macular hole, most of the times, if you have done a good job, close within 1 or 2 days. So therefore, the appeal to all the surgeons is do not say no to macular hole surgery. Even if the patient is obese like this and no neck, positioning is not paramount importance. Even if the patient can sit like this for some time, this will close the macular hole. It's not required that he has to be prone. Because I remember one patient who, on the operation table, this lady could not fit. We had to have another table for support. So this lady we operated, but macular closed because she was allowed to sit like this, because she could not lie prone at all.
And the patients, those who are not undergoing surgery, many of these patients, as an anterior segment surgeon, they keep asking us, like, sir, what are the precautions I should take? Patient has a VMT.
No, I don't see any precautions required.
Like
Those sudden jerky movements, all this Valsalva, sudden jerky movement, those are not advocated. We don't do that. That patient isolated VMT, like this lady I showed you, who are more than 10, we are not giving except for regular follow-up and this thing. So her right eye was operated for macular hole, left eye has VMT, is persisting, that's it.
I request Dr. Tinkawali, please come with the dais on with Dr. Lalit Verma. Now invite, thank you Dr. Lalit, always listening you, even for the entire segment we learn a lot from you. Dr. Tinku, better please. Now invite Dr. Malay Chaturvedi. He is a founding cataract surgeon. I don't know how cataract surgery he is doing. Let us see. Because I know from very beginning that he is a cataract surgeon. But now he is telling us, is diabetic retinopathy an inflammatory disease?
Yeah, thank you. So, basically how I went into the jargon of inflammation, and when I discussed this inflammation thing with uvea people, they said, you are not a uvea guy, why are you talking about inflammation? And how I came to the world of inflammation is because my physician keeps on discussing with me, and he teaches that all the diseases are actually related to inflammation. So when we are talking about inflammation, we are talking actually simultaneously about immunology. So immunology and inflammation go together, and ultimately we nudge down to etiology. And once we nudge down to etiology, then we come down to clinical practice. So everything seems to be related. Today there was a free paper presentation, and it was relating thyroid levels with diabetic retinopathy. So it is a very intriguing and very interesting field where you are going back from clinics to basics. And ultimately I ended up doing a program on inflammation and neovascularization, which was a program so very well covered, and we had a very huge response. And this parrot I today just took his photograph. He was sitting on my terrain. Such beautiful green parrots are not seen in our area. They are only in Uttarakhand. So we go ahead with diabetic retinopathy. And the question also came to my mind, because inflammation and neovascularization, they coexist in retinal diseases. So there is a natural question, are they a continuum of the same process? And that is how the entire thing started, and we did one program, inflammation and neovascularization. And when I asked JB that I want to do this program, I said, why you want to do this program? So I said, it's a program where commerce is not involved and we will be talking only science. And that is how when he got interested, and then we did this webinar and we had an audience of 5,000. So in diabetic retinopathy, only anti-VEGFs do not cure all the diseases. All diabetic macular edemas cannot be treated by anti-VEGFs, and refractory cases can respond to steroids. This is also very interesting finding. So this has incited the pursuit into the etiology of diabetic retinopathy. So we are going back. And this is a classical Kansky picture which discusses the basic pathological changes which we see in diabetic retinopathy. And it is good that I am actually targeting mainly to general ophthalmologists. And here, to simplify, the basic changes are leukostasis, basement membrane thickening, disturbance of inner blood retinal barrier, there is a pericyte loss, and there is microaneurysm formation. These are the 5 things which ultimately lead to the entire gamut or spectrum of diabetic retinopathy. And then there is extravasation. Now, hyperglycemia is the most consistent risk factor. This has been shown by the study. This causes metabolic changes. This results in pathological changes. And this causes signs and symptoms. So ultimately, it is the metabolic change on which we have to look. Now, hyperglycemia, all of us know this is the basic problem. And what does it cause? So don't worry about don't think that there will be a complicated cascade in front of you. But you might have heard these words like cytokines, prostaglandins, sorbitol, age product. And ultimately what happens, the metabolism increases and there is a pseudo-hypoxia. There is something known as ROI and PKC. These are all inflammatory mediators. And there may be people who say, no, this is not enough, but actually this is not complete. So there is a whole list of inflammatory mediators which we see in diabetic retinopathy, and believe me, even this is not the complete list. So, till now I was talking about inflammatory mediators, and as I told you that inflammation and immunity go hand in hand, and we always thought that in retina, their immune cells are not there. But when I went through the test book, these are the cells which are actually which are capable of giving an inflammatory reaction or immune reaction. Then there are 2 words. One is autoinflammation, which is expression of tissue response through innate immune system. The system where the cells existing in the tissue are causing inflammation. And there is autoimmunity, where T cells and B cells, they migrate and they cause inflammation. Now, the classical inflammation which we see in uveitis is a type which we call acute inflammation. And then there are some subtle changes, जैसे धीमी मंदी आंच होती है, उस तरीके की जो रिएक्शन होती है वो chronic inflammation कहलाती है, और that is known as non-uveitic or ischemic inflammation. And you will be surprised that AMD and diabetic retinopathy and BRVO, CRVO सबको अलग-अलग हम लोग पढ़ते हैं. When we are discussing the textbook of retina, all that is interrelated in a continuum. And when you go and read the Ryan's etiopathology especially, you will be surprised that there will be a common chapter. So all these things are interrelated, and that is very interesting part. And you will be surprised that actually understanding these things will decide the future course of management of the retinal diseases. So what we were told in our PGs that it is a microangiopathy, but it is not a microangiopathy, but it is a neurovascular degeneration. So neurons, blood vessels and supporting cells, they make a unit, they get degenerated in diabetic retinopathy. So metabolic disturbances cause oxidative stress, which releases pro-inflammatory mediators, which cause ischemic inflammatory response, which cause disturbance in vascular health, and that causes edema and angiogenesis. And then there's an interplay. So this is the whole thing, that microvascular changes cause clinical changes, expression. And once we understand the microvascular changes, we will be able to alter our treatment. Thank you very much. So basically, there was a discussion. I think Dr. Lalit has something to say, but you see, the question was, can we take steroid as first-line therapy in diabetic macular edema or not? So if you start going back to answer this question, because the whole world says no, the first-line therapy has to be anti-VEGF, then try to answer this question, you go back into etiology. And once inflammation is the basic etiology, why can't we give steroid as first-line therapy? They really do not cause that much of glaucoma or cataract. And there is a, yeah, sir.
Steroids do have a definitive role in the treatment of diabetic macular edema. There's no doubt about it. And in case you analyze the protocol I study which he was quoting and separate out pseudophakics and cataract patients, the response to steroids is virtually equivalent to that of anti-VEGF inhibitors. And you see, like he started with one slide that all patients of DME don't respond to anti-VEGFs. So generally around 20-30% patients will require steroids. And I do start steroids, but 90% if you do a questionnaire study, worldwide, first line of management is anti-VEGF agents. And the only thing is the threshold of shift to steroids may vary. Like I normally shift after 2 injections of anti-VEGF. If the response is not optimal, what is the response is that OCT has to decrease by some level or the vision has to improve by some level after 8 weeks or 12 weeks of assessment. Then we shift to steroids, irrespective of whether patient is pseudophakic, phakic or whatever. So I'm not very afraid of using steroids. And in patients who are pseudophakic or about to become pseudophakic, then we may combine both the cataract surgery and steroid. In fact, this stimulus came after a lot of good work was done by PGI group where they always combined cataract surgery and give Ozutrex along with the cataract surgery. So the question what you asked, steroids have a definite role, but as a first line answer is generally no, but threshold is very less of usage of Ozutrex. And the usage of Ozutrex, which was say much less couple of years back, now the percentage of Ozutrex users is reasonably high. And even in phakic patients, as I said, even in pseudophakic also. So, but we are trying to compare, you see, because Dr. Tinku Bali is a very fond user of aflibercept. So what should be done is give aflibercept in one and give steroid in other. This will answer this question whether which is better. The steroid generally, you see, we use steroids at the fag end of the disease. Once it is non-responsive, once it is recalcitrant edema, then we use steroid. And then already a lot of damage already has been done, not only by disease, but by waiting period of too long a time. So steroids, to my thinking, do have a role, but a lot of people have to start using it now as first line especially in patients who are contraindicated. Like one group is very clear where anti-VEGF is contraindicated, like recent stroke or MI or any vascular events. Then in any case we have used steroid as first line also. Suppose a patient comes who has had a MI or a cerebral vascular accident and patient requires treatment for diabetic macular edema, use Ozurdex as first line of management. No issue at all. You can, but if patient does not have no contraindication, then people tend to use aflibercept today. And the reason why aflibercept rather than ranibizumab or Avastin or bevacizumab, because multiple studies have shown, even meta-analysis, cooperative analysis have shown that out of these three anti-VEGF agents, the aflibercept, the ranibizumab, and the bevacizumab, the aflibercept shows superiority in all, whether it is 1 year follow-up, 2 year follow-up, and now 5 year follow-up also. So that should be choice number 1. And there's no doubt in my mind that today aflibercept enjoys superiority over the other 2 agents. And the other corollary is, suppose a patient comes who is already taking ranibizumab injections. He has taken multiple ranibizumab. So I will give him steroid. If patient is taking Avastin as a first line, so I will try aflibercept first, because the gap between aflibercept and bevacizumab is pretty high. But the gap between ranibizumab and aflibercept is not very high. The line diagram it shows. Does it answer your question or?
So one thing, just it's not related to what you said, but when I was going back into microbiology.
I wanted the question you said started is inflammatory disease. What is the answer?
It is definitely an inflammatory component is very significant, and that is what I was telling. That while I went back from clinics to basics, I realized that actually understanding basic is very important to do proper treatment. Number 1. Number 2, it decides it's the future course, what is going to come. And believe me, in next 5 years, I think something new is already in the pipeline. And when I discussed with the international product managers, they said, yes, we are looking beyond anti-VEGFs now. So very soon, you will be talking about something beyond VEGF.
No, you are right in a way, Malay, but still I think the wealth of evidence still supports, if patient is,
So till now, early on in the course of the disease, it is the VEGF drive that matters more. And as the disease gets more chronic, that was our understanding, it is the, these prostaglandins which kick in. So patients who have a chronic macular edema, long-standing macular edema, not been treated before, large cystoid spaces, they are the ones where the steroid cascade, the prostaglandin cascade is more dominant over the VEGF. So there are 2 subsets of patients with, where the VEGF may be more active, and in some where the prostaglandins. So where the prostaglandins are more active, those are the patients which would respond better to steroids at the first go itself.
They may not be mutually exclusive also. You see, there are a lot of OCT biomarkers also, or clinical biomarkers. Suppose you see a lot of hard exudates on the surface of retina, a lot of hard exudates. That may point towards inflammatory component more than the VEGF component. And suppose on OCT you see steroid spaces, what Tinku was saying, or you see a lot of HRF, hyperrefractive foci, then in these subcategory of patients, you tend to give steroids earlier than usual. There are a lot of inflammatory biomarkers. Yes.
An Ozurdex implant. So do you use combination of
Ozurdex is not
anti-VEGF?
expensive now. You see, if you do economic analysis of all these anti-VEGF steroids, ultimately Ozurdex comes out to be cheaper. Why? Because the frequency of Ozurdex is 3 injections in a year. 3 injections in a year in the beginning, and ultimately 2 injections in a year. And anti-VEGFs, if you say, as Tinku was saying in the other hall, 8 to 9 injections in 1 year in the first year. 8 to 9 injections means you multiply the cost of an average anti-VEGF, which is around 25,000-30,000 bucks. So Ozurdex ultimately may come out to be cheaper. But your question is from the efficacy point of view.
Yeah,
not
combination,
economics.
like having the best of both worlds in a patient rather than going.
So this was my favorite, in patients who had SRF component or chronic cystoid spaces. I used to combine, not Ozurdex, but I used to take IVT at that time and combine it with Avastin or ranibizumab. But now we are not using that because the wealth of data does not support this contention. There are very few studies which say that combination is better than isolated anti-VEGF.
Because
So
all
most
of us
the-
here agree that it is vascular and inflammatory both together. So rather than using one at a time, I think it also makes sense to use-
Theoretically, believe me, it looks good, but clinically it hasn't supported that consideration. Thank you.
Right, so thank you, sir.
So now I think, will you speak first? Let us.
Dr. Tinku, you are speaking, no?
Chalo, theek hai. Okay, you can come here. So now we have Dr. Tinku Bali, a prolific VR surgeon practicing Gangaram Hospital, Delhi, and she will be telling us more about epiretinal membranes. And she has a very good collection, I know. Let's hear how does she manage ERMs.
Is the mic on? Yeah. Good afternoon, everyone. So I'll be talking on epiretinal membranes and a few practical tips on how to manage epiretinal membranes. Dr. Lalit Varma has covered the pathogenesis of epiretinal membranes, so I won't be going into that. So what are epiretinal membranes? Epiretinal membrane is a fibrous proliferation of the retinal surface. Typically, it's idiopathic, but it may be secondary to retinal vascular diseases, uveitis, trauma, retinal detachment, or even lasers. Now, we all know that the epiretinal membrane may present as a highly reflective membrane on the retinal surface. The retina may have a corrugated appearance, there may be loss of the foveal contour, there may be retinal thickening, may even have frank edema. There will be vascular distortion, retinal folds, foveal ectopia, macular pseudohole, or even a macular hole in the late stages. So the most important symptoms of an epiretinal membrane are impaired visual acuity and metamorphopsia. So which are the patients that should be taken up for surgery? So a few years ago, the dictum that guided our management decision was that any patient, when he has a fall in vision below 612, should be taken up for surgery. Patients with good vision are best left alone. But with the improvement in surgical techniques, now metamorphopsia has become a very important indication of surgery. Just last month, I had a patient who was a jeweler, vision was 6/9, improving to maybe 6/6 parts, but very severe metamorphopsia. He wasn't able to do his work with the jewelry. So this was a patient that we had to take up for surgery. So the indications for surgery have to be tailor-made to the patient's profile, occupation, age, and other factors. The OCT guides us in our management decisions. So it helps us to it gives a picture of the adherence of the epiretinal membrane, tells us where the edge is, where we can start peeling. It tells us about the ellipsoid zone, that is the photoreceptor integrity line. And we can prognosticate and tell the patient if this photoreceptor line is intact, that he will have a good vision. Cases like a lamellar hole can sometimes, if they have good visual acuity, they can just be followed up without going in for an interventional surgery. Now, following surgery, the improvement in vision doesn't come immediately, and that is something that we have to reiterate to our patients. The vision may gradually improve and may not improve for several weeks following surgery. And there may be gradual improvement of 2 or more lines, even 6 to 12 months down the surgery. Poor preoperative vision and a long duration of symptoms have, of course, worse visual outcomes. The surgery is standard, a pars plana vitrectomy with PVD induction, most often stained by tricot, staining with dye, and epiretinal peeling, and sometimes in certain selected cases, an ILM peeling. There are 2 dyes which help us in this surgical procedure. One is trypan blue, 0.15%, which comes as reti blue. So the dye that the anterior segments use is a much diluted dye. The ones that retinal surgeons use is more concentrated, it's 0.15%. And the other dye is brilliant blue, that is ocu blue. So this dye selectively stains the ILM, and this dye selectively stains the epiretinal membrane. So it is a combination of these 2 dyes that we often use during our surgeries. If I want to stain the epiretinal membrane, I would use this. If I want to stain the ILM, I would use this dye more. Again, ILM peeling should be done or should not be done with epiretinal membranes, but there are certain cases like patients who have a lot of striae after removing the epiretinal membrane. These are the patients where I would do an ILM peel. Patients where you feel there would be a recurrence of the epiretinal membrane, like uveitis patients or diabetic patients, those are the cases where ILM peeling needs to be done. So I'll just move on to some videos. This is a standard epiretinal peeling. So this was a patient with vascular occlusion. So this is the trypan blue dye. You see here one drop over the macula. And here we get a very nicely stained edge of the membrane. So this can just be picked up, the edge, once we are fortunate enough to get an edge, it can just be picked up and the peeling is pretty simple. It's important to keep an eye on both the edges of the membrane when you're peeling, because it may sometimes be adherent to vascular structures or vessels at the disc. So you see here, there's an attachment here which very gently I am now severing from the disc. Now this was a patient who had a lot of striae at the macula. After removing the membrane, you see there are a lot of folds here which you can see. So these are the patients where I would like to combine an ILM peeling along with the epiretinal peeling. So such patients may have metamorphopsia if you do not do the ILM peeling. This was again a membrane here, where I would like to show you a negative staining of the ERM. So sometimes when we have only one dye, if you just have the brilliant blue dye, this dye would stain the internal limiting membrane. The epiretinal membrane does not get stained with this dye. It appears as a white structure. And then this is called negative staining, and then the membrane can easily be peeled off because that is not stained. It's seen in white against this blue background. So here the technique that we follow is a pinch and peel technique. So generally I do not use any instrument to lift up the edge of the membrane. Generally it's just a simple go onto the membrane, pinch it up and try to get a lift of the membrane and then just peel it away. Post-uveitic, just a small little video to show you the adherence of post-uveitis. So some membranes may be more adherent than the others. They are all not equally, equally made. So this is a very adherent membrane post-uveitis. So you see how tenacious this is. Another important point is that this patient had a bit of macular edema. He had some cystoid spaces. So in these cases, it's important not to peel right over the fovea, but to go circumferentially around and gently peel, so that you don't de-roof any large cystoid cavity and cause a macular hole to form. These small bleeds may occur because the membrane is very adherent to small structures, and you can just remove this hemorrhage at the end of your surgery. Now sometimes when the epiretinal membrane is very difficult to peel and you cannot get an edge, then what I do is I peel the internal limiting membrane, the ILM, from a little distance away from the epiretinal membrane. And then once you peel the ILM, the epiretinal membrane comes along with it. So this is a very good technique. In very adherent membranes, you can do ILM peeling, and the epiretinal membrane you see here comes up along with the ILM itself. So that's the membrane. This was a very firmly adherent membrane right around the macular hole, and then you can just cut this redundant ILM. Now diabetics, as Dr. Lalit Verma showed some beautiful videos, so I'll just show you a short video of an epiretinal membrane. Now in diabetics, it's very important to identify the attachment of this membrane to the vessels. In between, you'll get an area where you can go under the membrane, as I went in with the cutter. And then this membrane over the macula was peeled off using the cutter itself. So you can either use the forceps or you could use the cutter. In diabetics, generally we prefer to use the cutter. And you can go very close to the retina and remove the membrane. So in diabetics, like I said, I generally like to combine an ILM peeling along with the epiretinal membrane peeling. So the same patient followed by ILM peeling. Sometimes you may have very bizarre kind of, I'll just take 2 minutes more, some very bizarre kinds of epiretinal membrane. So this was a patient with vitreous hemorrhage who had a trauma. When we cleared the hemorrhage, this is the kind of epiretinal membrane that we saw here, which was covering the fovea. So for this epiretinal membrane, this was a very vascular edge of the membrane. So for this, cautery was done to the edge of the membrane, and after that it was taken off with the cutter.
So some membranes cannot be peeled off with the forceps and you have to use different strategies for them. Epiretinal membrane peeling in retinal detachments, it's very important to look at the macula, because you'll generally see in cases which have bad PVR, you'll see a thick sheet of hyaloid which forms a very thick epiretinal membrane right at the macula. It's very important to remove this for the success of your surgery, and you see here a thick epiretinal membrane at the macula in a case of retinal detachment, which generally comes off pretty easily. Sometimes you may have to use a stronger forceps to peel this off. And this is the last video. So this was an interesting case. It's not actually an epiretinal membrane. This was a case of vitreous hemorrhage. And when we cleared the hemorrhage, this is what we saw at the macula. So this is not an epiretinal membrane, it is the hyaloid cavity. So this patient had a subhyaloid hemorrhage, a preretinal hemorrhage below the hyaloid, which had leaked out into the vitreous to form vitreous hemorrhage, and this was the hyaloid cavity that was left behind. And this is actually the hyaloid that is being peeled and not the epiretinal membrane, as you could make out with that dome-shaped shiny structure. So those were some of the videos that I wanted to show you, and that's the end of my talk. Thank you so much.
So, yeah, wonderful videos, Tinku, as usual, a lot of good videos you have shown in various spectrum of epiretinal membranes. Believe me, last video is an award-winning video which you should highly submit to somewhere, because that kind of hyaloid very rarely you will see. But you know, this video reminds, I also have one video, but this clarity is much more than mine video. Very nice video, last video.
Thank you.
So any clarification or questions by anybody? Thanks, Tinku.
Thank you.
So now we have the last speaker, Dr. Kanika, who will talk about diabetic macular edema and its treatment. Kanika from Kashipur.
Am I audible? Yeah. So a very good afternoon to the chairpersons, my seniors and my dear friends. So I'll be speaking about diabetic macular edema, and my presentation will be relying heavily on Dr. Malay's and Dr. Lalit Marma's presentation, because a lot has been spoken already. So we'll be dividing this presentation into 4 parts. What is DME? Why does it happen? Investigations and its treatment. So what is it? So the eternal the ETDRS guidelines of CSME, which we already know. The more later ICO guidelines, which were given in 2018, the classification is basically center involving and non-center involving DME, where center is defined as a central 1 millimeter zone of fovea. So anything outside that is basically non-center involving DME. Now why does it occur? I won't go a lot into it, because Dr. Malay has spoken quite elaborately about it. So I'll just say a few words that it's basically chronic hyperglycemia leads to accumulation of advanced glycation end products, which disrupts the blood-retinal barrier. And there's upregulation of multiple pathways, which leads to increased inflammation, oxidative stress, and vascular dysfunction. So how do we investigate it? You can use an 90D. Fundus photography can be done, FFA and OCT. And more recently, OCT angiography. So what is the role of FFA in the management? It tells us the kind of maculopathy there is, whether it's discrete or it's diffuse, whether or not there is presence of ischemia, and it helps us guide the laser. So this is what focal macular edema looks like. It's more discrete. Diffuse is more, it's along with the microaneurysms, there's generalized leakage from the dilated capillary beds. Ischemic maculopathy will basically be enlargement and irregular FARS. So here you can see this shape change. Now going on to the OCT. So OCT helps us in detecting subtle edema. It helps us to find out the pattern of the disease. We can quantitatively measure the foveal thickness. After intervening in form of injections, you can track the results and whether or not vitrectomy is needed. There are several OCT patterns that have been defined. So this is spongy thickening, which basically looks like focal edema on FFA and responds well to laser. This is more homogeneous. Cystoid macular edema, this is optically clear spaces with bridges present. This responds poorly to laser and responds well to anti-VEGFs. There's subfoveal retinal detachment. Then there is tractional retinal detachment, which is basically an indication for pars planar vitrectomy and responds poorly to laser. And this is taut posterior hyaloid. So this can lead to recalcitrant macular edema with focal detachment. Now there are several modalities of treatment, which is systemic control and observation. We can go in for laser and various intravitreal interventions like steroids and anti-VEGFs, and finally VR surgery. So first let's start with systemic control and observation. Who are the people who can we can observe non-center involving DME and center involving DME with good visual acuity, mostly better than 6/9. Now what is systemic control? HbA1c less than 7, hypertension less than 130/80. Nephropathy needs to be controlled, hypolipidemia needs to be controlled, and anemia needs to be controlled, like Dr. Lalit Verma just explained. So there were some studies to back it up. So DCCT trial and the UK PDS trial was done in type 1 and type 2 diabetes mellitus respectively. More recently, the ACCORD study was done, which basically said that we've been keeping the HbA1c levels less than 7 for a really long time. So let's try keeping the HbA1c levels to less than 6 and see what happens. So they came to the conclusion that significantly lower rates of diabetic retinopathy progression were seen. Then we can do lasers. It works best in eyes where there's discrete areas of fluorescent angiography, mild to moderate thickening on OCT, and when there are no vitreomacular interface abnormalities on OCT. Now ischemic maculopathy does not respond to laser, but CNP does. Now there are various intravitreal interventions which we'll divide into two parts, steroids and anti-VEGFs. So let's start with the steroids first. We have IVTA, dexamethasone implants, fluocinolone implants, and more recently triamcinolones have been are being given in the suprachoroidal space. So again, like Dr. Lalit Verma said, the indications are basically refractory diabetic macular edema, hard exudates on and around the fovea, pregnant patients, and patients with previous thromboembolic events. So starting with IVTA, it's basically extremely cost effective, but there is high risk of IOP and cataract formation. The problem is it's very short acting and multiple doses are needed. Protocol B and Protocol I was conducted by drcr.net, which came to the conclusion that intravitreal triamcinolone was better than laser. In fact, IVTA was as good as ranibizumab in a lot of cases, but for approximately 1.5 months, after that the effect decreased swiftly because of cataract. Now next we have dexamethasone implant, which is commercially available as Ozurdex. So the Placid trial was done, which came to the conclusion that Dex plus laser was better than laser. MEET trial said whether 0.35 or 7 Dex was better than sham. Of course, the rates of cataract and IOP rise was higher. Vivodex study said that Dex is non-inferior to Avastin. Fluocinolone implants were started, where initially it was started with Retisert, which fell out of favor because of rise in IOP and cataract. Then Illumin was started, which I think proved a little better because there was no IOP rise risk. And FAME study was conducted, which said that either of the two doses was better than laser. Now moving on to the various anti-VEGFs available, there's ranibizumab, aflibercept, bevacizumab, brolucizumab, faricimab, and there's one ONS 5010. So first, ranibizumab. This is a recombinant humanized monoclonal antibody fragment binding VEGF-A. A lot of studies have been done which show brilliant results. Brilliant results of ranibizumab as compared to sham. Dosages, whether 0.3, 0.5, showed similar results. But when ranibizumab was combined with laser, then it showed that a lesser number of injections were used and the response was also prolonged. Now going on to aflibercept, commercially available as Eylea. This is a fusion protein. Da Vinci trial, Vivid and Vista were done, and various doses and various dosage frequencies were tried, and they both came to the conclusion that any dose or any dosing schedule was better than laser. Then moving on to bevacizumab, or most commonly known as Avastin. It's actually approved for colorectal cancer, so off-label use. Chances of endophthalmitis is higher. And some studies were conducted, like the BOLT and Protocol T. BOLT said that Avastin is better than laser. Okay, I'll just take around 2-3 minutes. Yeah. Okay, so Protocol T was a landmark trial, and it was a non-biased one, which came to the conclusion that aflibercept was much better. In the lesser number of injections were needed, less need of rescue laser, and much better visual outcomes, and better anatomical outcomes were seen. Now the latest in the horizon is brolucizumab, commercially available as Pagenex. Kite, Crestal and Merlin trial was conducted. All of them came to the conclusion that aflibercept, brolucizumab is non-inferior to aflibercept. Merlin said that intraocular inflammation was higher with Pagenex. Now next is faricimab, which is not available commercially in India, but the Boulevard trial has said that 6 mg of faricimab is much better than 0.3 mg of ranibizumab. Yosemite and Rhine trial studies are still awaited. This is an ophthalmic specific bevacizumab that's not available in the market yet. Then there's sustained release ranibizumab, again to decrease the number of injections, not available commercially. Biosimilars are basically approved replicas of original founder products, may be made after patent on the original expires. They're cost effective. And lastly, we can go for pars plana vitrectomy in refractory cases, in cases which have tractional or ERM component. The only problem is enhanced drug clearance from the vitreous cavity after vitrectomy has been done. So these are some of the newer drugs. Now I would just like to share some personal experiences. So this patient came to us initially, and he had right eye, there was VMA present, left eye spongy edema, serous detachment with HRF was present, injection eccentrics was given. After a month there was very good response, and just some hard exudates were of course present, and after that the patient was lost to follow up, and he came after 2 years approximately with a huge amount of hard exudate, but after that nothing could be done. Another one came with both eyes intraretinal cysts, septae were present, left eye injection Avastin was given, edema resolved. After that he came in January, about 3 months later left eye developed a little drill, and right eye injection was given, so everything resolved, but right eye developed some foveal atrophy, and left eye drill was present, but we didn't do anything about it. Another one came very similarly, but both eyes there was a serous detachment with intraretinal cysts and septae was present, both eye injection eccentrics was given. So right eye responded well, but the left eye there was the cysts and septae resolved, but serous detachment was present. So left eye Ozurdex was given, and after a month the serous detachment also resolved. This one is very similar, so we'll just move on to the next one. Okay, this one came with the right eye, there was vitreous hemorrhage with mild spongy edema. Left eye there was serous detachment, injection Avastin was given. After that there was no response at all to in the left eye. So we tried IVTA in the left eye. By that time the right eye vitreous hemorrhage had also cleared, and the subretinal fluid resolved. This is also very similar. So we'll just, okay, this case is very close to me because this is of a very, very active and very dynamic gynecologist who's practicing in my city. So her vision was around 6-9 parts in both the eyes, and her HbA1c was controlled, and she's been a diabetic for a really long time. So she came to us with massive edema, and there was a component of ERM also in the left eye, but because her vision was good, so and it was quite discontinuous, the ERM, so surgery was not attempted. So left eye eccentrics was given, but there was no response. Then she went to a higher center in Delhi where she was injected with injection Ozurdex. There was suboptimal response. After that, around a year later, she was injected with Ozurdex plus Eylea. Again, there was suboptimal response and the ERM is getting thicker. In September, we injected her with Pagenex. The results are still awaited, and if nothing happens, then next we would like to go for ILM and ERM peeling. So I would just like to ask sir and ma'am, is there anything else that could have been attempted with the lady, considering she doesn't have any problem in her daily routine. She's doing her ultrasounds, she's doing her surgeries. She's absolutely comfortable with around 6-9 parts vision. Okay.
You only answered this question in the beginning. Stent involving macular edema with good vision, don't do anything.
Can't hear you.
Your first slide was stent involving DME with good vision, don't do anything. This is what you said. Now you are asking this question.
Yeah, I agree.
Khadam ho gaya? Last.
Okay.
We started half an hour late. No? Started half an hour late.
Thank you.
So we'll hand over half an hour late. So in any case, I don't think so. If vision is 6-9, don't touch. Usually give what we call a holiday, drug holiday. Drug holiday mil jana chahiye, and pay attention to metabolic parameters. Once the vision drops, then
maybe something can be
because as I
considered.
said, never treat OCT.
Right.
Okay.
I agree with that.
Okay.
She's
So
had
no-
too many medications. I
Yes,
think just give
I
her a
agree.
break
I
and
agree.
concentrate on a metabolic profile.
Metabolic control
Yeah.
and no
She's not
ILM or ERM
responding to
peeling.
anything.
There's nothing that should be attempted.
No, not ERM peeling with
She's
this
doing-
vision. Not at all.
Okay. Okay. Thank you so much.
Okay, with this, thank you. I thank all the speakers. And with this, we come to the end of this session. Thanks to the audience also for a very patient hearing, and apologies for overstepping the time limit. Thank you.
Good afternoon, friends. I am Dr. Harbans Lal. With me on the chair are Dr. Anuj Jain. On my left side, Dr. Rohit Om Prakash. If he's there, please join us over here. Dr. Kamal Kapoor and Viraj Bhushan. So, with the permission of the Professor Jagat Ram, we invite Dr. Rajendra Prasad. He'll be demonstrating sieving needle microcapsulotomy, new technique to avoid Argentinian flag sign.
Yeah.
And we will request all of them to be dot on time, because we are already running nearly 30 minutes late in all our programs. So Dr. Rajendra Prasad
Thank
has
you.
got a very simple technique, and he has given two wonderful thoughts to us. One is the sieving needle, and all of you have heard the terminal chop. So Dr. Rajendra Prasad, please be brief.
Thank you, sir. Thank you very much. Good afternoon, friends, ladies and gentlemen. The topic which I am going to talk about is sieving needle microcapsulotomy. We do not have any financial interest in this subject. And you all know that these intumescent white cataracts, they present a variety of presentation is there. And we all have seen some of them have a fluid, some of them do not have fluid. We also come across Morgagnian cataract, where you have a very hard nucleus inside and the capsule is very tense and fluid is there. But these varieties you can many times confirm and differentiate with the help of the OCT images. So OCT is very helpful to differentiate these cataract. But one very important thing is, so whatever is the type of these white cataracts, the very common feature they all have is they have a thin and fragile capsular bag. So that is the most important thing. And the second important thing is all of them have a very high intralenticular pressure. And how you can see the high intralenticular pressure is because when you puncture these white intumescent cataract, you will see a volcanic eruption of the white fluid which is coming out of the capsular bag. Now this fluid is very, very dangerous because the fluid puts a dispersive force on the place where you have punctured the capsule. And this dispersive force erupts the puncture, and we may land up into the problem of the
capsular tear extension to the periphery, which is called as the Argentinian flag sign. So what you can see is here in this video, the moment you puncture the anterior capsule, what happens, the tear which we have created with the help of the needle on the anterior capsule starts extending to the periphery, and this is what happens, your capsule extends to the periphery completely. This is called as the Argentinian flag sign. This was described by De Perrone somewhere in 2000. And he said this is primarily because of the raised interlenticular pressure, which could be compartmental pressure, which we may have the anterior compartment, posterior compartment, and along with the thrust of the nucleus, which takes place on the back of the anterior capsule when we rupture the anterior capsule. This used to be one of the most common complication in the Argentinian flag sign. We all have seen in the intumescent cataract, the tear extend to the periphery, and the percentage is somewhere around 3.85 to 28.3% of the cases will come across with the extension of the capsular tear. But this is not important like what percentage. What is very, very important is almost 7 to 24% of the cases, this tear will go into the posterior capsule. So if it goes into the posterior capsule, and you all know that what kind of complication we can come across. So because of the complexity of this situation, the various techniques have been described and developed and shown by the various people. One of the important technique, the Indian technique, is phaco capsulotomy and the puncture-axis. Puncture-axis by Dr. Rajan, you have seen yesterday in the live surgery also. These techniques are not very helpful actually, and many of them could create some other complication. So we have to be very careful in using all these techniques. And even the small needle aspiration technique, we all have been using this. This is also an Indian developed technique. But what happens even with the small needle technique, when you puncture the anterior, we are using the 26 gauge needle, you puncture the anterior capsule, you create a tear, and many times before we could do any sort of aspiration upon the capsular bag, your tear extends to the periphery and results into the Argentinian flag sign. So we had a presupposition that it means it's not the raised interlenticular pressure, the only factor which is responsible for the creation of the tear. There had to be some other factors responsible which assist the raised interlenticular pressure to propagate the splitting of the capsular tear resulting into Argentinian flag sign. So we came out with a technique and we described the pathophysiology of the Argentinian flag sign. This is called as a sieving needle microcapsulotomy to avoid Argentinian flag sign. And according to this technique, what we actually never knew was, what was not known was, in reality, it's not the raised interlenticular pressure, the only factor responsible for the extension of the tear. It is the configuration of the puncture we create on the anterior capsule, whether we use the capsular axis forceps or we use the 26 gauge needle. What happens when you're using the capsular axis forceps, you create a tear on the anterior capsule, and then you start the capsular axis. Whether it's a mini axis or a small axis, whatever you do, you create a tear. And similarly, the 26 gauge needle also create a tear on the anterior capsule. As you can see, this is the 26 gauge needle. If you puncture the anterior capsule, this will create a linear tear on the anterior capsule. Now this linear tear has an open edges, and this open edges is the problem, because if you leave an open edges and if you have a high pressure inside, this open edges easily opens up and convert into the Argentinian flag sign. And you can see the capsular axis forceps also we create a tear on the anterior capsule. Now this tear, if you have a very high pressure inside, would open up the tear and lead to the Argentinian flag sign. So this is another important point which we never knew was like this tear always extends along the radially along the tear. It will never extend perpendicular to the tear. So this is another important, because it means something has to do with the tear or the cut we create on the anterior capsule. So we came out with an hypothesis that if instead of creating a tear on the anterior capsule like this, if we create a circular hole on the anterior capsule, now this circular hole would have a much better resistance against any kind of pressure which is there in the interlenticular space. So we created and developed this device which is called as the sieving needle microcapsulotome. Now this capsulotome is round and pointed. It's unlike the needle. Now this round and pointed tip, if you puncture the anterior capsule, this will create a hole. This will not create a tear. And if you are able to create a hole on the anterior capsule, this will never run out and never rupture, whatever is the kind of the pressure which is there. So there is the difference what you can see here in this picture. And if you do this, you have to stain the anterior capsule and you puncture. So fluid will, but this works mostly in the cases where there is an intralentricular fluid. A high pressure fluid is there, and you puncture, the fluid will start coming out, and you'll get a decompression of the bag, and the pressure is reduced, then you can start the capsular access in these cases. You can make one hole or you can make multiple holes on the anterior capsule. Multiple holes have to be within the 5 mm zone only, because you don't have to go beyond the 5 mm zone. And if you go beyond the 5 mm zone, then your capsular access would become a problem. So I'll just show you a small video. Now this is a intumescent white cataract. I'm already stained the anterior capsule and pressurizing the chamber, because you have to use a good viscoelastic to flatten the anterior capsule before you start using this device. So this is the capsulotome, a round tip, pointed. It's a round like a sieving needle. And my video is not running. So I just wanted to show the video. Okay. Something is gone wrong there. Just last bit, just half a minute video only. Wait. Okay. So you pressurize the anterior chamber. This is the microcapsulotome. The important point is you have to see the tip of this. Tip is round and circular and pointed. And when you puncture the anterior capsule, so you create a hole on the anterior capsule and you will get the evacuation of the fluid from the intralentricular space. Now you can use a straight sieving needle also to puncture this capsule, and you puncture it, you get a fluid evacuation. Now this evacuation of the fluid is very important, because when you are evacuating the fluid, you are decompressing the bag, and decompression would make the capsule easy, and then you can start the capsular access. Now this can be done even without staining the anterior capsule, because if you stain the anterior capsule, because you do not need to see the capsule exactly, because you don't stain, so that your capsule still remains elastic and you get a better puncture on the anterior capsule. But just for the purpose of demonstration, I am staining the capsule and see the hole. Sometimes you may not get a complete hole, you may get a C-flap. So even the C-flap is very, very protective, and C-flap will also never extend. You never get a distortion of the hole. You get a circular hole always. 99.9% of the cases you get a circular hole, and this circular hole is what prevents the rupture of the hole. And once your bag is decompressed, then you can start the capsular access. You don't have to worry for the extension at all, because now your bag is completely decompressed. So this is how you can complete the access. Thank you very much.
So he has won so many awards internationally and is a very regular and very well renowned internationally. So we are so proud of him, and he'll be talking about the periodic cataract surgery, which is his passion, and he really loves that subject.
Thank you, Dr. Harbans Lal, Chairman of the session, Dr. Harbans Lal, Dr. Arun Jain, and my dear friends. I will be, first of all, I am thankful to Uttarakhand Ophthalmological Society, Dr. Vinod Arora, Dr. Satanshu Mathur, and Dr. Gaurav Luthra, and all the executive committee for giving me this opportunity. I will be speaking on state-of-art pediatric cataract surgery and my proudest moment. I owe my sincere gratitude to all the founding fathers of the institute at PGI MER Chandigarh. These were the director of PGI before me. I was the 12th director of PGI. I also owe my gratitude to my mentor and teacher, Professor I.A. Jain, Professor Amod Gupta and Professor Tulsidas. Professor Tulsidas was the first head of the department of PGI, and I owe my gratitude to my mentor in pediatric cataract surgery while I was working with Dr. David Apple in 1993-94. I got opportunity to work with Dr. M.E. Wilson, who is a pediatric cataract surgeon. And of course, Dr. Abhay Vasavada is also my inspiration. My strength is my family, the greatest pillar of strength, and have been constantly providing me positive support and affection. This photograph is after 30 years. This first photograph is in 1990 and other is in 2022. Of course, we have an excellent team, and you can see starting from Professor I.A. Jain, Professor Amod Gupta, me and Professor Dogra, now even Dr. Arun Jain and Professor Pandav, we have a very, very long association. You can see in the photograph my colleagues at PGI Chandigarh. My journey has been very long and eventful. As I trace my route, it makes me immensely surprised and emotional to note how far one can reach by sheer hard work and persistent dedication. I joined PGI in 1979 and initially did intracapsular cataract surgery, then extracapsular, then phacoemulsification, and then of course flex with IOL implantation. In the outreach, 150 camps in Punjab, Haryana, Himachal, these are the mega camps, and at Radha Swami Satsang Byas. And I had opportunity to serve the Republic of Seychelles on deputation from PGI Chandigarh as a consultant from 2003 to 5 and successfully eliminated the backlog of cataract blindness. It was an honor to complete the complete issue of Survey Ophthalmology in 2000 and analyze the largest database of the world pseudophakic human eye obtained post-mortem. These were some of the publications images in New England Journal of Medicine. This is the patent. These techniques of artificial platform for intraocular lens implantation has been patented. From a small beginning, year after year, I have diligently worked to serve the thousands of children who were brought to us with millions of hope at our doorstep and to educate the hundreds of young minds. Why pediatric cataract surgery? Pediatric cataract surgery is a neglected surgical procedure in ophthalmology. High rate of complication because you have to see them lifelong. Most powerful draw was preventing childhood blindness due to pediatric cataract, and this became my biggest passion, mission and obsession. These were some of the publication with high indexed, high impact, in the high impact factor journal with citations. These children comes with visually significant cataract. We have to dilate each of the child. Most of them, they have bilateral cataract and some of them have unilateral cataract. After dilatation of the pupil, we know the exact anatomy of the cataract and how to deal them post-operatively or operatively. There are several issues of concern. We have to dilate each of the people, IOL power calculation, increase in the axial length of these growing eyes, whether to implant IOL or not, marked inflammation and management of amblyopia. Goal is to provide a clear visual axis and long-term visual rehabilitation. These are some of the surgical video of pediatric cataract, because this is a common these jonular cataracts, and this is to show the other that how we can do pediatric cataract. We have to stain the anterior capsule, particularly the beginner, and then do continuous curvilinear capsulorhexis. And this is how we make continuous curvilinear capsulorhexis in children, and the size of the anterior rhexis is kept around 5 mm or so. And then we do multi-quadrant hydrodissection and remove the cortex from the capsular bag. And then after filling the capsular bag with the viscoelastic, we do the posterior continuous curvilinear capsulorhexis. Here in this case, I am making a small nick with the needle cystitome, and then making a complete posterior rhexis by Uttara forceps. In this, there is a minimal or almost no vitreous disturbance, and here after limited central vitrectomy, we implant the IOL in the capsular bag. Of course, we plant hydrophobic acrylic IOL all the time. We have done research trial and thesis on femtosecond laser assisted pediatric cataract surgery. There may be no difference than the manual. These are some of the other procedure management of cataract associated with the PHPV, because PHPV is very common. I will show only very few of them. These are the vascularized membrane on the posterior capsule. Most of them are with stalk. It is very difficult, such as in this case, to make the continuous curvilinear capsulorhexis because it is a very thin capsule here. But we have succeeded in making capsulotomy. Then we do the cauterization of the posterior capsule. This is a vascularized posterior capsule, and it is difficult to cut with cutter. And here we have cut it with the venas, small vena scissor. Particularly retina people, they have such a scissor, and this is the stalk which we have to cauterize. And then cut the stalk and do limited vitrectomy and implant IOL in the capsular bag. We have done lot of such children. Initially there were lot of complications because we were not cauterizing the stalk, but later on, as we realized and we had a better technique, so we got much higher success in these patients. These are some of the publications in toric and multifocal IOL in children. These are some few of the publication in persistent fetal vasculature with cataract. Contribution in pediatric cataract, more than 12,000 pediatric cataract in children were operated. 134 publications are in the field of pediatric cataract. More than 172 lecture in this field, and 154 residents were trained, and more than 30 award and honors. This is one of the child who came in the first year of life in 1997. This child was followed up by me, and now at present at the age of 25 years he is MBBS student. He has passed MBBS and his vision continued to be 20/20. So surgery is the first step. The follow-up is essentially long, has to be long, and it has to be beyond surgery. Now I will like to show some of the proudest moment of my life. Most of them they were given by pediatric cataract surgery.
डॉक्टर जगत राम चिकित्सा नेत्र विज्ञान।
This was when I received Padma Shri from President of India in 2019. Here I got Best of the Best award at American Society of Cataract and Refractive Surgery 2-time and winner award, and also Oscar of Pediatric Ophthalmology. These were some of the awards which is shown, and this was when I got first time any of the award at the international level 2012, and other proudest moment was when I became director of PGI because I joined PGI family 43 years back in 1979, and I became director in 2017. These were the other proudest moment that our hospital at PGI Chandigarh were first to perform lung transplant, simultaneously liver and kidney transplant 2017 and 18. And other proudest moment was share your happiness and sorrow. I handed over the chairmanship to next of the person, Professor Dogra, when I became director PGI. I became the other proudest moment was member of Supreme Court mandated MCI Oversight Committee and later on NMC, National Medical Council. And PGI during my tenure was declared the second best institute for successive 4 years from 2014 till 2021, and was one of the cleanest hospital, and we also received the award 4 times, that is the best hospital in organ donation. These were some of the other proudest moments. This was the last video. While I retired in PGI from October 2021, it was the honor given by Advanced Eye Center PGI. This was a very long queue of the people standing on each side, and it took a lot of time to cross them, and I think any employee, particularly in the government sector, if one retire honorably, that is a big thing for any of the person. So I consider it one of the proudest moments, because while any government employee retire, it does not happen because there may be something or something. In summary, Swami Vivekananda once said, take up one idea, make that one idea your life, think of it, dream on it, and live on that idea. Let the brain, muscle, nerves, every part of your body be full of that idea, and just leave every other idea alone. This is the way to excellence. Thank you very much. Thank you so much.
Thank you, Professor Jagat Ram. It was really very nice and very good presentation. And now I invite Dr. Vinay Garodia. He'll be talking of circumferential train track capsulorhexis, a new technique to prevent Argentinian plaque sign in hypermature cataract.
Thank you, sir. I think that was really an awe-inspiring kind of a presentation, sir. Dr. Jagat Ram, sir.
Before Vinay start his session, there is important information. We will have inauguration in Hall A at 5 p.m. Request all the faculties to be present here because they will awarded the faculty certificates and faculty memento. Please join us at 5 p.m. Hall A. Yeah.
Thank you, sir. So I think, first of all, I was really in awe of, after hearing the presentation of Dr. Jagat Ram, sir, and especially that surgery in which he's dissected it so beautifully. I think it's great. I mean, we normally would leave a PHPV as nothing can be done, but then to see that something like that could be done for that child is really, thank you. And I'd like to invite, I'd like to thank UKSOS for inviting me. I'm going to be sharing one very small idea that came to me, which has changed my management. And since there are so many big surgeons, cataract surgeons available, I would like to have their idea, their opinions also. And I would like their honest feedback after trying out this technique in their own cases. So I'll be talking about a new technique that I'm working on, which is a circumferential real track capsulorhexis. So as we know, white cataracts is a challenge for most of us. And the biggest challenge being to do a good CCC, because especially in these intumescent cataracts which have got raised intralenticular pressure, you can suddenly have a radial extension happening, which is a Argentinian flag sign. As we know, this thing was named by Daniel Perron, and it resembles the Argentinian flag when there is a biradial extension of the blue stained capsule. It may occur at the first nick itself. Whatever you may try to do that, whatever technique you may try to work on, you just nick it and it can just happen in some of the cases. And the intumescent cataract may not be only because of fluid being there. Many times we have intumescence because of the swollen up lens matters also. So giving a nick and draining out the fluid may not work each and every time. So we have to have some way of managing these intumescent cataracts without having the runaway happening. And one thing that I think most of us would have noticed is that whenever the Argentinian flag sign happens, you are managing one end of the neck, but often the other end of the neck is the one that runs to the periphery, because that is the one which we have not actually looked at. One end we have just kind of folded it along or done something, so you're kind of taking care of that, but the other end just goes radially. So my technique basically, so this thing is working there, it's not here right now. So the complications of radial tear extension we all know, so we are not going to go into that. It can cause PCR, zonular rupture, nucleus drop, and all those issues. So this is a small video that I have that I'll just show to you. Okay, the audio is not there. So basically, as we know, this is the moment you give the neck, the extension can happen, which is called Argentinian flags. And here you see the extension is happening at both the ends. And often in this one, you will see that the surgeon is moving on one side, but the extension is happening from the other side. See, on the right side, everything is okay, but on the left side, suddenly the neck has extended. One way of handling that is by using femtorhexis or a zeptocapsulorhexis. This is one which is a show shot way, but this is a more expensive option. So what I have defined is it's a circumferential rail track. Here I'm going in the periphery, picking up a small V-shaped kind of a neck, and both the edges of the neck are circumferential in this case. So therefore the thing doesn't tend to extend. And I'm creating a kind of a rail track around the peak. So you're not touching the peak at all, just going around the peak, and you're doing it from the side port only, so you're not enlarged the incision, so it's a closed chamber technique. And with this kind of a technique, this can work in all kind of intumescent cataracts, whether it is a fluid-filled cataract or it's a normal one. When the fluid is coming out, you can just inject some viscoelastic to reform the chamber and also increase the visibility also by moving the fluid away. And you see that whatever you do, the chamber the capsule stays quite stable because both the limbs of the neck are circumferential. They don't tend to extend peripheral. So, I mean, this is a very, very simple idea that you start in the mid periphery at the edge and create a V kind of a tear on the rhexis. What we can also do, we can practice in some of our normal cataracts also to make our technique a bit stronger. I would suggest that we should stain and then do this, because so that when you're doing the initial tear, that becomes easier in a stained capsule because the capsule becomes a bit more brittle in those cases. So I would prefer that even when you're doing a transparent cataract, do it after staining, practice this, use it in your OT, and let me know the feedback, because in my hands, and there are 15 doctors who are operating at my center, all of them are using this and they have actually been quite happy with this technique, sir. So just to reiterate the steps, you make 2 side ports, stain with trypan blue. I'm using normal HPMC as viscoelastic, a normal 26K cystitome, and we just going from the side ports. in the mid-periphery make a circumferential V-shaped kind of initial tear. And then both the limbs are in circumferential direction, go around the peak the way I showed there, and in case required, most of the times I can manage with the needle itself, but if you require, you can use a microrhexis forceps, which goes through the side port. So don't make the main port, that is very, very important. So like this, these are a few screenshots of the video. So you can see the initial nick that is being made is in a V shape, with both the limbs being circumferential. And the same thing is being extended all around the peak of the lens in a kind of a rail track around that. The other options, as I think Dr. Prasad also had pointed out, we have to use high viscosity cohesive visco in these cases, but even that we all know that despite using Helon GV or whatever, the things tend to run away. Femto Zepto are effective, but they are expensive. Microrhexes, again, the initial nick may just run off. Some people even try a phaco punch, but I personally am very scared about using a phaco machine to kind of create a punched out thing. And the sewing needle capsulotomy, as it was shown earlier, it does work in the fluid-filled eyes, but it may not work in the other cases. Second, that when you're using a needle to create a puncture, you're not going to get a punched out circular hole. There'll be small, ragged edges which will be there. The advantage is instead of having two edges, there'll be multiple edges. So the forces will be equally divided. The chances of runoff in a sewing needle capsulotomy is much lesser than that in a 26 gauge needle. But in this but still the risks are still going to be there. In this technique, because both the edges are circumferential, chances of extension is very, very low. And in my hand, it's about 95% to 98% cases I'm able to complete the rhexis. So advantages are we create a tear, and we're not creating a rupture. We're not cutting the thing, we're just creating a tear. The two limbs are both circumferential, hence don't extend radially. We avoid the peak of the lens where there's a maximum pressure that is there. It's a closed chamber technique, can practice in normal cataracts also. And it has a very short and easy learning curve. And all the 15 surgeons at my center are using this technique, and I've gotten positive feedback from them and a few of other of my friends. So that's all, I think. Thanks, sir. I would like a lot of feedback, an honest feedback from everyone, sir. Thank you, sir.
Thank you, Dr. Harbanslal. So I'll be talking about some practical pearls about implanting toric IOLs. As we all know, I have no financial interest. As we all know, the prevalence of corneal astigmatism in cataract patient is to the tune of around 25% in around up to 1 to 2 diopters, and only 10% of the cataract patients have a high astigmatism of more than 2. At present, around 20% of the cataract patients who are undergoing phaco needs some sort of toric corrections. My surgical load is around 20% of my list. I do toric IOLs. And to have a successful toric IOL implantations, these are the important, sort of throughout from pre-op to post-op, these are the sort of things you have to take care of. A meticulous pre-operative workup, including a toric IOL power calculations, knowing one's own surgically induced astigmatism, and also noting down the pre-operative landmark, because sometime after marking with ink, those once you start the surgery, those landmarks just smudges and disappears. So you should have some guideline to go by how to align your toric IOL, and also proper making of incisions and toric IOL axis alignment, which is very important. Otherwise you will have a negation of the effect of the toric IOL, and also somehow prevent the toric sort of decentration or rotation, and if it does happen, how to correct that. So under these headings, I'll try to base my talk. So what are the patient selection criteria? I won't go into details of IOL power calculation because most of them are online, and what is the surgical technique pearls in these cases, and how to, if we do have a post-operative alignment problem and surprise refractive result, how to correct them. So patient selection is very important. Why we should be choosing a patient with the regular bow tie astigmatism. One should rule out cases with irregular astigmatism, though there are special indications in keratoconus. So rule out pellucid marginal degeneration and all cases with irregular astigmatism, and of course where there is a risk of decentration or subluxation. And so to rule out all these ocular surface problem where you have anterior basement membrane disorder, irregular astigmatism, one should know one's own surgically induced astigmatism, as well as one should take into account the posterior corneal astigmatism if you want to have good results, and try to avoid extremes of axial length, as well as do consider the IOL tails, rule out pseudoxolin, etc. So approximately when you start the toric IOLs for the first time, this is a study from USA, even there approximately 5% IOLs are implanted 90 degrees away from the intended axis first time. This could be because of confusion between the steep and flat power meridian and cylinder axis, because as we all know, when referring to steep axis or flat axis, the use of term axis is incorrect. The term meridian should be used when referring to direction of the corneal refractive power. The symbol, cross symbol or symbol X is used to represent the axis, and the symbol at the rate of is used to represent the power meridian. So this is the IOL power sheet for IOL power calculation. In this, if you notice, the IOL power shows flat and steeper meridians by the use of sign at the rate of which present the power meridian. However, the cylinder axis is also represented by at the rate of, which is wrong. It should be represented by X sign. So we wrote a letter way back in 2016 that these things should be avoided, because in the right-minded people it creates confusion and you can go wrong in IOL power calculation. So as I said, I will not go into details of IOL power calculation, though you should be using advanced methods to know accurate keratometry, be it a manual or a corneal topography, and you should confirm your astigmatism by at least 2 methods. Sometimes there is agreement between the two, so at least on 2 instruments it should match. And most of the IOL power calculations and alignment is based on online toric IOL power calculations with various different manufacturer of the IOL. So this is about the posterior corneal astigmatism. If you can see, this is the anterior corneal astigmatism, and there is a posterior corneal astigmatism around 0.7. So actually this negates this much, so actual will be around 2.7. So we have to take into account with the rule. So we are always under correcting, that is Baylor nomogram, but if you can actually measure the posterior corneal, you will be much more accurate. So coming to the surgical induced astigmatism, the location of the incision is important, because there is a flattening of the meridian in which you give the main incision, and there is a steepening of the opposite corneal meridian, and size of the incision does matter. A 2.2 millimeter incision usually gives rise to 0.1 to 0.31 of induced corneal astigmatism. It varies from side to side. So one should know for each meridian how much is the surgically induced astigmatism, which again can be calculated online. You can do 30-50 cases and note down your change in astigmatism. That will give you your personal surgically induced astigmatism. And axis marking is very important part of this toric IOL implantations, and almost 80% of the cases, this is again survey was conducted, almost 80% people will use some method of ink marking, whether manual one or slit lamp assisted. Only around 50% people will use those important anatomical landmarks or various digital instruments or intraoperative aberrometry for marking the axis of the toric axis. So I won't again go into details. There are various types of manual axis marker, but again, once you do a manual marking like this, if the pen tip is too broad, it is almost equal to 5 to 10 degree of your this thing. So where to align, you can go wrong by almost 5 to 10 degrees. So we have to have a very fine marking. So there are various types of bubble markers or even a sort of camera markers, but this study showed that using a pendulum on the slit lamp is most accurate in terms of manual marking. It is akin to a digital Turing marking. This is what this study showed. So on the slit lamp marking is very important, and to avoid this very broad marking, or sometimes even this instrument is not aligned to 0 to 180. So that to prevent that, we have devised one technique. You can use 30 gauge or 26 gauge needle on the slit lamp and mark very minutely on the fixed conjunctiva. So even on the note down these important landmarks. These are the axon field vessels on the sclera, which you can mark and mark the axis. On Hug slit, there is only 8 millimeter slit, but on a Zeiss you have 14 millimeter. So you can mark these important landmarks on the slit lamp and use them on the patient or during the surgery, so even if there is a smudging or fading away of the marks. And this is Hug slit slit lamp. You have a graticule and each degree is equivalent to 10 degree. If you want to divide into one, you can put a strip over it and divide it into different this thing, and you can very easily mark and even post-operatively know the alignment of the IOL in these cases. And these are the various type of digital markers available to us. There are various types of this is intraoperative barometer by Eyecon, which is opti-wave refractor analysis system, and we have Callisto variant eye trace as well with us. So I am using all this variant which takes a picture of the limbal vessels, and during the surgery you come to know about the software transmit the data from the variant to the surgical field, and you can easily align. It can be used with lenses also, and it also helps us in controlling the size of capsular axis as well as alignment of the lens accurately. This is during one surgery you can this is projected like this onto the eye, and there is no need of marking anything. So that's how you do it during the surgery. And this intraoperative overall, the main advantage of this thing is it takes care of the posterior corneal astigmatism also, which is sometimes difficult to measure with the different other instrument. So how you use it or going during the surgery after in pseudophakic mode, you choose this after toric implant, you choose this this thing, and you run this thing, and this tells continuously the refraction and the axis of the IOL implanted, and this tells us just another 2 minutes. So till the time you get a 0, no rotation recommended, you keep on rotating the IOL so that you are on the proper axis. So that is how you do. So this is one representative example. So he had a 2.6 for astigmatism, the posterior corneal astigmatism is 0.7, and I'll just skip over. And this is the post-op day 1, patient has 6/6 vision, and you can see the alignment on the slit lamp. This is exactly at 110. And so during surgery, what are the pulse? You have to mark, align the lens properly along the axis, be it a digital or a manual marking. Ensure very good wound constriction so that there is no leak. Otherwise, if there is a wound leak, there is a shallowing of chamber, and there is a chance of rotation of the IOL. Remove the viscoelastic from behind the lens, and after removing, press the lens so that there is because tackiness of the capsule to the lens, it stays there, and it doesn't rotate and have a watertight closure chamber. So if there is, even after the surgery, there is some residual astigmatism, it could be due to various reasons, whether our intraoperative alignment is not correct, inappropriate calculation, inappropriate marking, and not taking into account posterior corneal astigmatism. So we have to address that. This is one case where this is perfect alignment in right and left eye, and this is on the eye trace we can see that whether the lens is aligned and not. Here you can see the lens internal and corneal astigmatism is at same meridian, but in this patient the internal astigmatism is the lens is rotated by 7 degrees as compared to this. So eye trace tells us about the rotation of the lens. So this is one such case. So I'll just skip over, and this is on first post-op day. The patient has 6/18 vision. So we did the eye trace. You can see the internal higher order aberration as well as astigmatism, and you can see the alignment is not according to the corneal astigmatism, which is at 122, and the lens is aligned at 155, and it tells us we have to rotate the lens by this much amount, and it will lead to a change in this much degree of astigmatism. So we did that, and the patient improved to 6/9 on second day, and this is again we repeated this, and still the lens was little off, but there was no change in the it didn't suggest any further rotation. So that is how you can do it. There are other ways of doing the alignment. We have Callisto also. I will not go into detail of this thing. This patient has a very high astigmatism. So because this is a post-keratoplasty, so I'll just this is a Torby from Zeiss with high astigmatism. So after putting the lens, we are using Callisto to align the IOL. So patient had 6/9 vision on day 1. So this you can see the first post-op day post-keratoplasty, and if there is still a residual astigmatism, we have various online toric calculator analysis system which tells you, if you don't have access to eye trace or other fancy gadgets, you can have a pre and post operative data and feed into these various analyzers. One is available from Alpins, another is from Graham Barrett, which is Barrett's treatment formula. The third one is from these three guys, Bradal et al. And you can feed it and they will tell you how much the lens to rotate in which direction. And just to, this is the last slide. So to have a very successful toric IOL implantation result, you have to do a meticulous perioperative workup using good methods of topography, take into account your surgically induced astigmatism as well as posterior corneal astigmatism. The IOL power calculation should be accurate and identify the marks on the sclera, and proper marking of incision and toric IOL axis, that is very, very important, and precise alignment of toric axis, be it a manual or a digital, and prevent the post-operative rotation by taking into account various surgical pulse. And if there is still a residual astigmatism, do a real alignment or do a piggyback or a exchange of IOL, or in some cases laser touch-up. Thank you so much for your patient area. So now we have Dr. Harbans Lal. Maybe there is a repetition of many things. So
thank you, Dr. Arun Jain. I think all of you have heard the great academician teaching about the toric IOL, but I am sure many of you might be thinking it is too complicated to understand and do. So I'll try to simplify whatever he has already talked about. So they put on my presentation over here, please. Audiovisual guy, please put on my laptop over here. यहाँ पे तो लगा हुआ है. So the basic statement is, if patient can afford and surgeon is confident, all patients above 1 diopter of corneal astigmatism are candidate for toric IOLs, except progressive corneal pathology, contact lens user for irregular cornea, children below 12 years of age. Even if the corneal astigmatism is less than 1 diopter, if you are using multifocal or EDOF lenses, probably these patients need toricity correction, because toricity causes the blurring or loses the contrast, so does the multifocals. So both of them make the contrast much poorer. And if the other eye had a toric IOL, say 1.5 diopter, and this eye has got only 0.75 and you had an excellent result, probably this is also a candidate for the toric IOL correction, even if it is less than 1. Against the rule astigmatism, if you do not have access to the posterior corneal power assessment, and in borderline cases, suppose patient has got 0.88 diopter of astigmatism, 0.85, 0.75, but his refractive cylinder, the spectacles he is using is say 1.5 diopter, probably he is also a candidate for the toric IOL correction. If not, at least from 1.5 you can bring him down to the 0.75 or so. So the toric IOL, the most rewarding for the patient and doctors both. You cannot go wrong. No expensive equipment is needed. You don't need any Callisto, you don't need any Varion, you don't need any Pentacam if you don't have. You just have to have little extra effort to practice the toric IOL. So if you don't have access to those, you can still practice. To achieve a target post-op astigmatism of less than 0.5 diopter, due diligence is required, and factors affecting the post-op result to my mind are: measuring is the 70%. That means whenever you are erring, it is most of the time the measurement is not correct. Selecting the IOL is the second most important, and surgical skill only contributes to the 10% of the total factor. So that means measure and measure and measure. When you measure, it is access is more important than power, and the misalignment with the various studies, what you will see is hardly any. More than 10 degree of misalignment is only 2 to 3%. All others are within 10 degree. You can see in these all studies 4 degree, 3 degree, 5 degree. And this small misalignment causes no effect into the surgical outcome. Reason is that the nature never makes a pointed things. It makes all curvy things. So there is not at a 180 degree, it is 1.5 and it drops down immediately. There will be plateau and there will be range where it will be the more or less same power. So initial 3 to 5 degree of misalignment will cause no significant effect into your post-op result, because there is no sharp point over there. It is gradually curving the cornea. So the small misalignment causes no effect at all whatsoever. So the measurement is important. So measure by all the equipments, whatever you have, whether it's a keratometer, autokeratometer, IOL master, lens SR, corneal topographer, pentacam, what all you have. And important is that there is a rule of 2. That means there should be agreement between the 2 of the instruments. If you don't have the 2 instruments, there should be agreement between the 2 of the observers. That means one of the optometrists and you do it yourself, and independently, and find that both of you are getting the same estimate, same axis. Or even if you don't have an optometrist, the same person does the keratometry twice in a gap of a day or 2 and finds the same reading, probably you are not on. So the measurement is the key, and there should be at least agreement between the 2 instruments, 2 observers, or the same observer twice. So what I do in my practice is, because I have got access to the optical biometer, selecting the axis, as I already emphasized, is more important. So the pentacam and optical biometer, when you are trying to compare, it is important to remember that pentacam has got the separate reading for the anterior surface corneal astigmatism, and the total corneal astigmatism is separate, and the posterior corneal astigmatism is separate. So when you are comparing the optical biometer, whether your reading capture is all right or not, it should be compared with the pentacam's anterior surface. If you compare with the pentacam total corneal astigmatism, then you may find the different axis and a different power. So when you are comparing whether you have captured the data correct or not, then anterior to anterior should be compared. But you want to take posterior corneal astigmatism into the consideration. For correction of the astigmatism and for the axis, the total corneal astigmatism of the pentacam should be used. So for comparing, compare anterior to anterior, but use the total corneal value for correcting your toric IOL. And most important is, whenever the residents or your optometrist brings the reading, you have got to look at a crowding, and most of us get the average. So 1 or 2 odd readings, many times all the readings may be haywire, but the machine is going to give you some average. So that average may be totally wrong. So ask them to bring out the print out of the keratometer. Like once you ask for the lenses or IOL master, there is a separate keratometric chart. And if even one axis is wrong, one power is wrong, it will spoil all the averages. So you have got to look into the crowding of the readings, not the average of the readings. And discard the outlier. If there is no crowding, then you are either dealing with a regular cornea or you are dealing with the dry eye. That means every reading and the power is coming different. And most important culprit is the dry eye. If there is an intra or inter-equipment axis difference is more than 10 degree, you need to treat the patient for dry eye. Most crucial and most important, whenever I explanted my own IOL, it was because of the error of the dry eye. So all the patients, and this you can only find out when you have got a chart of the 5 readings. If you take the average, you will never know whether the dry eye was there or not. So you should have a chart. If you are getting a lot of hashtags, the axis coming 17, 27 and the haywire, you are dealing with the dry eye. So treat the dry eye with the mild steroids and a lubricant from 1 to 3 weeks, and then you will find that your all axis, all power are actually you are getting very nicely. So whenever there is a variation, please, single most important factor is the dry eye or irregular cornea, dry eye being the most prevalent. And most of the time because of the elderly patients, so the dry eye has to be taken care of. And many of the optometrists, they put the drops beforehand, the patient is going through so many tests, so that may be accentuating the dry eye effect. Now still if the disagreement persists between the two equipments, the pentacam is giving you different reading and the optical biometer is different, what do I do? And patient has got a significant cylinder, then the spectacle prescription becomes the most crucial for me to judge what axis should I implant this IOL. So the cornea is important, but spectacle cannot be ignored. I trust pentacam total corneal power and axis more than the optical biometer, but if my prescription or refraction is matching with the optical biometer, I'll go with the optical biometer or with the refraction. Like suppose for example, if the optical biometer is giving axis 17, pentacam is giving 34, and patient spectacle prescription is 10, I will implant the IOL at 17 degree. I will not go by the pentacam reading over here. So because the agreement between the spectacle and the optical biometer is better than the pentacam and optical biometer. Selecting the axis, again optical biometer is 10, pentacam is 20, what do I do? I will mark 2 axes, one is 20 degree, and then I'll also mark the axis of error, which side, because you are never always accurate, because the pen ink which you mark it itself is 5 to 10 degree thick. So I'll also mark the axis of my error. That means one axis is at 20 degree, another mark is at 15 degree. I know that it should not be 22, it could be 15, but it should not go towards 22, 23, 24. So you should also know if you are erring depending upon the various equipments, what is the site of the error you are going to have. So the axis of error, what axis you should mark, where you should err upon. Then there are many things which keep on confusing you, what I call as a power influencer, effect of the aging, with the rule, against the rule, posterior corneal power, SIA, incision site, anterior chamber depth, spectacles, all these things are the minor influencer. They are not the primary criteria for deciding. Distance visual acuity is totally dependent upon the volume, not the axis of the refractive error. That means irrespective of the axis of the refractive error, whether it's a 180 degree, 90 degree, 30 degree, it is the refractive error which will decide how clearly patient sees for the distance. But for near vision, if he is using minus cylinder at 90 degree, his near vision will be better as compared to if there is a minus cylinder at 180 degree. So if there is a slight minus cylinder left at a 90 degree, patient will have a better presbyopic correction. So though we try to overcorrect the against the rule astigmatism, but that is also not required because the cylinder left will be at 90 degree. So now I'll talk about our aim is all these influencer will come into the play. I'll explain you now. aim is to have a complete correction as of now. But toricity available at IUL is in the state of 0.75 diopter, which translates at the corneal plane to the 0.5 diopter. That means the patient has got, say, that the 1.75 diopter of corneal astigmatism, now which lens to use, 1.5 or 2 diopter. So here will come the role of all other factors which influence your selection of the IUL, like the posterior corneal curvature. We know that with the rule astigmatism keeps on decreasing with the age, because the posterior cornea is concave vertically, which acts as a minor cylinder. That means if you have got no access to the posterior corneal curvature, with the rule astigmatism what you are measuring, if you are measuring 1.5, it could be 0.9. But it is only true in 85% of the cases. That means in the 15% of the cases it may not be true. So if you can measure the posterior corneal curvature, that is the ideal. But with that presumption, people use that with the rule. That means the steep cornea vertically, they try to undercorrect. So, and the horizontally steep cornea temporally, they try to overcorrect, because to negate the posterior corneal curvature effect. But otherwise, if you are measuring on a pentacam, then this is not required. So if you are now with that presumption, if patient has got with the rule astigmatism, I'll use 1.5 diopter because of the posterior corneal effect, not 2 diopter, while patient needed 1.75, slightly undercorrect whenever it is vertically. But when I'm using horizontally, if I'm not measuring the posterior corneal curvature, I'll slightly overcorrect, because with the age also this is going to happen. Now same, aging, as we know that from with the rule, patient is going to keep on becoming against the rule. That means is, and 90% of the patient which we do are against the rule. 90%, 85% with patient, that means their steepness is most of the time temporal, and temporal steepness can be overcorrected, because over the period of time they will keep on becoming more and more steep on the temporal axis. But this is only true when you are operating comparatively younger patient. If you are operating say 65, 70 years old, really I mean for 10 years if there is a 0.2 diopter of difference, it doesn't bother me, I don't care about it. I want him to have a correct vision now. So if it is only you are operating 40, 45, 50 years of age, then maybe if you have got to err, not the, if you are getting the perfect match, do it perfect match. What happens after 10 years, if he develops 0.3 diopter of astigmatism, I am not concerned. He should have a good vision now. So but if you have got to choose between whether to undercorrect or overcorrect, then it comes into the play, not otherwise. Again, SIA and incision, if you are giving the incision is at the steep axis, where the, if suppose your incision is cylindrical power is at 180, you are going to give incision 180, then you can undercorrect, use the lens which undercorrects, because that 0.25, 0.5 will be taken care of by the incision. But if you are going to give the incision, patient needs a 90 degree, your incision is 180 degree, you can actually use the lens which is of little higher power, because it will increase the steepness over there. But again, if you are giving incision little posterior at a limbus site where slightly ooze, this hardly causes any effect onto the total corneal astigmatism. Again we come to the anterior chamber depth. We know that the same index of the IUL, if it is there, if you need a PC IUL, suppose if you need 20 diopter, in a sulcus fasciculate you will need 19.5, 19. You put the same IUL in the AC, you will probably need 15. That means the effect of the lens keeps on becoming more and more as you keep on coming closer to the cornea. And again, if the patient's chamber is shallow, that means the same lens will have more correction, whether it is for the toricity or for the total power. That means if the patient's depth is say 2 mm anterior chamber depth, I will use 1.5, not 2. But if patient is myopic, he needs 15 diopter and anterior chamber depth is 4 mm, the ELP will be far off, then I will use the 2 diopter, because the effect of that toricity is going to be less onto the cornea as compared to the lens which is closer to the cornea. Again I am emphasizing, but if I am getting the correct power, I am not bothered about what is the anterior chamber depth plus or minus. Then if I am getting the right power, I will use the right power. These factors only influence when I got to choose between slightly lens, use the lens power slightly less or slightly more. So use any method, whether it's a pendulum method, slip method, direct deviation, makes no difference whatever method you use. The tip here is you are marking a reference point. You are not marking a 90 or 180 degree. Because when you are putting your hand, it may not exactly go where you intended to go. It may be, 2-3 degree is this way or that way. Actually, you can't really assess. And when you are putting a ink blob, it itself is 10 degree, 5 degree, 7 degree thick. Like a confrontation test, I do notice the anatomical landmark when I am marking. This is the vessel. My 6 o'clock should be how much away from this vessel. And then I try to put a mark over there. And after putting the mark like a confrontation test, I will try to check where, according to me, is exact 90 degree, whether it's in the center of the mark, left side of the mark, or right side of the mark. Because you're marking a reference point, not a 90 degree or 180 degree. Because your brain cannot, because even when you use a pendulum marker, if you are looking at the center, you will miss on the periphery. When putting any ring, if you are looking on this side, temporal side, you may miss down, up and down. So the brain is not able to focus all around, so you may miss one or the other point. So when you do the IOL implantation, never use the methyl cellulose to inflate the back, because methyl cellulose cannot be completely removed from the capsular bag, and there will be chances of post-op rotation. Either you should use the sodium hyaluronate, which comes out very easily from behind the lens without any problem, or you should do the hydro implantation. Never use methyl cellulose. So to sum up, if you see these influential, the dry eye management is the most important. Pentacam is the most crucial and more accurate as compared to the optical biometer, and the refraction plays very, very crucial roles in an irregular cornea. And whenever I got any confusion about there is a mismatch between the two axes, axis is more important than power. The power influencer are to be used only for deciding a fine-tuning your surgical skill. Per se, they do not bother you much, but particularly when you are using now a lens like Vitry toric, Symphony toric, Synergy toric, which are high-end lenses, over there even the 0.5 diopter of residual astigmatism can make a lot of difference. So these power influencer come into play, but in routine toric lenses may not. You are marking a reference point, you are not marking exact 90 degree or 180 degree. Mark and at least keep a mental picture which side to err upon. Whether if my lens is misaligned, whether it should be on the right side or the left side, so that you know. And do not use methyl cellulose at all. So with this, thank you very much for your kind attention. And if there are any questions, I'll be more than happy to answer. Yeah.
So one question. Suppose if I take the patient on a slit lamp to see whether the 90 degree or 180 degree. Now my question is, number one, when your slit is vertical, you can tilt the slit to different angles, right sir? Second point, why use 26 gauge needle to scratch? The scratch is also more than 4 or 5 degrees. So my intention to tell you is, and ask you whether I'm right or not, put the beam at the axis where you want to put the lens, take the crescent blade, put it there, slightly press it there in the upper quadrant and slightly press in the lower quadrant, you are the axis. So half the job is done. Take the patient to the operation theatre, put a the trypan blue, it stains there, and you can put the dial the lens in that direction.
Excellent. So I 100% agree with you. Every surgeon has got its own experience and they are doing their own way. But the important thing is when you are placing your any instrument, even if it is marked, because your beam itself will be 5 degree thick. So when you are marking, when you are looking at the beam, when you are looking at the center, patient slightly moved, your beam is well aligned or not, so patient is looking at the right point or not. So what I am saying, after you have put on your mark, irrespective the type of method you are using, you need to reassess whether your mark is where you wanted it to be there or it is slightly right or left. That's the only point. Once you put on a mark, make sure that your mark where you intended, whether it is exactly there or not. If it is actually there, go ahead. But again, you reassess whether your mark, and everybody has got its own method. This is excellent method. Many of our friends are using it. So wherever you feel comfortable, it is your comfort zone. Every method is good, and 3 to 5 degree of misalignment causes no difference.
I will again disagree here. So if the patient has got 6 diopter cylinder, 7 diopter cylinder, even few degrees they're not going to matter, like in spectacles. So higher is the astigmatism, more is the difficulty, even if there is a little bit of a shift.
No, I mean this is other way around actually. See I don't know whether, is there any presentation over here after this?
It's mine, sir. It's me.
Is there any presentation after this?
Yeah, I have to present.
We have a lot of time till 5 o'clock.
You have a lot of time?
Inauguration is at 5, so we have 20 minutes to go. But
I'll just because there was another topic which Dr. Anujan touched upon, the misalignment, and this your discussion brought up that topic once again. The patient has got 6-7 diopter of astigmatism, or you are using a 6-7 diopter of lens, then whether the misalignment of 5-7 degrees is going to make a difference or not. So just I'll run through this. So toric eye will surprise how to manage the misalignment. So the presence of cylindrical refractive error of more than 0.5 diopter, my simple logic is that the toric eye will work best into the steep axis. Finish. If you put them in a steep axis, best align, best outcome. You don't have to worry about anything else. So does preoperative keratometric power and axis matter? No, because you need to know once the lens is in sight what is the keratometric axis now and what is the power now of the cornea. It makes no difference what it was when you put the lens in sight. So do we need any app like astigmatisfix.com? No. Well, you just need to know where is the steep axis and put the lens over there, finish. This is where. So do we need to take any photograph on slit lamp? No. Do we need to do calculation, do any app, anything, whatever we don't need anything. We need to just put the lens into a steep axis. Only thing we need to know whether putting this lens into a steep axis is going to help the patient or not. That's the only thing.
That is what exactly eye test does. That is what I have shown.
No, it's perfectly all right. I mean, this is another. See, I'm giving a simpler method which anybody can understand. All your talks were excellent. I'm not challenging your talks or knowledge. I'm trying to just simplify the things for the average setup. My talk always has been focused on the average eye surgeons. My talk is not focused on the PGI Chandigarh, Shankar Netralaya, RP Center, where all the gadgets, all the gadgets are available.
I am supporting you in the sense that I am telling it is the accurate marking of the steep axis.
Yeah.
All these gadgets help us to mark the steep axis in an accurate manner.
Yeah.
So whatever inaccuracies are there, post-operatively we have to try.
So I'll
find
just.
that.
So the एक मिनट सर ये बात खत्म हो जाने दो.
Yeah. Okay.
So you need to find out whether rotating or realigning the lens is going to help or not. So whenever there is a toric, I will surprise there are two components, correctable and non-correctable. That means if the patient had a corneal astigmatism with 3 diopter, you put on a lens which can correct only 2 diopter, the 1 diopter you cannot correct, whatever you might do. Whether you put a 27 degree rotate or you 17 degree rotate or 1 degree rotate cannot be corrected. So simple is whether there is a correctable astigmatism is possible and whether it is because of the significant misalignment. If you can calculate these two things, you can correct the residual astigmatism. So how to find out whether there is uncorrectable astigmatism? If the patient's refraction is 3 diopter and the lens can correct only 2 diopter, so the 1 diopter cannot be corrected. So if the patient's residual refraction is 1 diopter, that means nothing is going to work. So with this, once we have found out what is non-correctable, if suppose non-correctable is 1 diopter, patient has got 2 diopter of cylinder, that means now 1 can be corrected. The 1 is because of the misalignment of the IOL. So we need to find out how much the misalignment of the IOL is causing. It is the component of the refractive surprise.
And
so the mismatch of the toric IOL power and the keratometric IOL power cannot be corrected.
So
if there is a refractive error more than that, suppose the mismatch is 0.5 but the refractive error is 1.5, that means 1 can be corrected. So now when we want to know 1 can be corrected, so whether how much is the misalignment. So when we calculate misalignment, 30 degree of misalignment, there will be no effect of the toric IOL. That means if the patient had 1 diopter of residual astigmatism and you put the toric IOL which was supposed to correct 1.5 diopter, that means misalignment is 20 degree. It was supposed to correct 1.5, it could not correct 2/3 of it is missing, 20 degree. You can rotate this 20 degree. But suppose the misalignment, the residual correctable astigmatism is 1 diopter, but you put on a toric IOL which was supposed to correct 6 diopter, That means you have already achieved 85% of the result. That means misalignment is only 5 degree. 5 degree of misalignment you cannot correct. So the residual refractive error is the same, 1 diopter. But the lens was supposed to correct 6. It could not correct 1. That means it was slightly misaligned. But lens was supposed to correct 1.5. It could not correct 1. That means grossly misaligned. So the refractive error surprise is the same. But in a low power lens, you can rotate and go and correct it. But in a high power lens, because the misalignment component is small, though the refractive error is more. So the misalignment, when you are correcting, you need to find out 2 things. Whether the repositioning of the lens is going to help or not. So repositioning, you can find out what is the factor, how much of it is left, what it was supposed to correct and how much it could not correct. So if there is a significant under correction by that IOL, if it was 3 and it could not correct 1, it was supposed to correct 3, that means it's 10 degree misalignment, you can still attempt. But if it was 6, 5, there is no point of attempting. So this is important to know, that you need to put on a lens on a steep axis, finish. Pre-op K doesn't matter, post-op K matters, and how much can be corrected by the realignment. I will not go into detail and videos of this. Anyway, so now Dr. Jan, you can say what word.
Yeah, we have discussed the axis error, but what we are talking about is the residual astigmatism. If no more of residual astigmatism is corrected by rotation, it means there is a miscalculation on our part in terms of measuring the magnitude of the astigmatism. So that everything we have to take into account. So that amount which cannot be corrected by that IOL, either we have to replace the IOL, or we have to put a piggyback IOL, or we can do a LASIK touch-up. So those are the ways of correcting a residual astigmatism. It means we have gone somewhere in measuring the accurate power of the toric IOL, which will fully correct the astigmatism.
Perfectly all right. I mean, there will be methods, whatever cannot be corrected by misalignment, there are methods to handle with those.
Yeah, thank you, Dr. Harbans Lal. So very good discussion.
Thank you, sir. Thank you, sir.
So now we have a talk by Dr. Kashyap. That is at 5 o'clock. Inauguration is at 5. Abhi to 4:45 hai. No. He is the Kashyap is going to talk about single pass 4th row pupilloplasty in different situation. Professor Kashyap. Yeah.
The SFT has been made popular by Dr. Amar Agarwal, and it is very, very helpful. So in case of open sky keratoplasty, so we have removed the cornea, did the pupilloplasty, and then there is the post-op. If there is deficient iris, we repaired the iris with SFT, works fantastic. Post-op and post-op. There might be some optical capture. You can see here. So for this also we can do pupilloplasty, SFT. If there is a superior PS or ABK, we can do it before the cornea surgery. If there is a traumatic rupture of the pupil, we can repair that. These are all pseudo-phakic. Post PKIL, little bit of exudates are there post-op, but then clears up. There are exudates, pupil membranes, and it clears up later on. If there is a coloboma, you can repair it. Sometimes you have to do the pupillectomy also. Pupil dilates, there is no problem. Pupil movement, there is no problem. Therapeutic keratoplasty, when we are doing, we do not know what we'll find inside. So SFT done, good result. Rupture, sphincter pupillae repaired. and the upper hole works like a PBHI. So in deficient iris, there is the post-op picture. Remaining gap works like a inferior PI. In traumatic mydriasis, you can put these stitches so that the optic doesn't come out. This is the done in superior quadrant. Now this is a phakic eye. So what I do, it is not illustrated by anybody. So what I do is put a phakic IOL and then do the SFT. So now the crystalline clear lens is safe. While putting the 26 gauge needle, it is better not to pierce the iris through that. It should be pierced by the needle, 10-0 needle. So in phakic eye, I gave one pass. This is in a lower quadrant and this is from the upper quadrant. And in such cases, I always measure the bend of the 10-0 nylon stitches, measure it and then bend it there. And after giving these two stitches, I remove the phakic IOL . And then tie the knot. Thank you very much.
So why the phakic IOL was, phakic IOL was removed? What was the indication for that?
The pupil had to be repaired. That there was traumatic mydriasis, rupture sphincter pupillae. So I had to repair that pupil. So since the patient is phakic, you cannot put the needle there because you have to leave this hand and tackle the iris on the other side, so the needle can rupture, the needle can damage the lens, clear lens. So to avoid the damage to the clear lens, I put the phakic IOL.
Okay.
So this is,
thank you.
Quite a expensive proposition.
That's one way of preventing the damage to the lens capsule.
No,
so Dr. Partha, you please prepare your talk. So that's a very good idea, Dr. Bharti. So, Dr. Kashyap, I think just put on a ICL you keep in inventory and how you...
I have got zero power phakic IOLs, a lot of them. And in such cases, if the patient is phakic, to save his lens from getting traumatized, I put the phakic IOL, do this, give the stitches, and then remove the phakic IOL and then tie it in knots.
Great, great. Very good idea. Thank you.
Thank you,
Very
sir.
good idea.
Waiting for the connector, sir.
So now our next speaker is none other than Partha Vishwas. I think everybody knows he is chairman scientific committee and has done a wonderful job as a chairman ARC for 6 years and 3 years as chairman scientific committee. So I think it's great to listen from him, and he'll be talking about one of the very key topics as his keynote address. IOL placement in PCR.
Connected देना भैया. As the connector is on the way, so I will take this opportunity to invite all of you to the midterm AIOC that is in Patna, and that's between 6th and 8th of January. So request all of you to be there, and Patna is a great place. And in the winter, we are going to have a very, very different type of session. It's not going to be like the ordinary sessions that we always have. and we are trying to make it as innovative as possible. So request all of you to be there. How many of you have given submissions? Dr. Kashyap, have you given a submission? All of them you've done. Sir, request all of you to please come and join us at AIOS Patna. Hi. So, posterior capsular rent and intraocular lens positioning, how can we do it, and what are the nuances to it? It happens once in a while for all of us. It happens more for our junior colleagues, and it is important to understand the nitty-gritty of the placements. So the placement depends upon the one and very important factor is the integrity of the capsular bag even after there has been a posterior capsular rent. So how can the integrity be ensured? The integrity is ensured if you are able to convert that rent into a rhexis. So if a posterior capsular rhexis is possible, then you have a near full bag where you can place even a single piece lens or a multi-piece lens. However, what are the situations, and let's go through these few situations where a PCC is not possible. So let's see this video in which the PCC is not possible, and okay, so one video is clipped anyway. In this case, there is a central rupture, and we are going to see this is at the last moment, and I'll just come back actually. The first video was missed. Let's hope this plays. Okay, so this is where it's a large PCR and the nucleus and the whole cortex is there. So it's important to compartmentalize this capsular bag, the rent and the nucleus with high molecular viscoelastic, and if it can actually separate the posterior capsule provided the vitreous has not prolapsed, then by very slow motion movements and phaco and injecting viscoelastic time and again, this nucleus can be removed. But what one was to watch is the eye should be fixated on the strands of the viscoelastic that you have placed, because if the strands of the viscoelastic are the telltale, and if they show that the vitreous is actually coming, and if you feel that the vitreous is there, so the vitrectomy has to be done even if the nucleus is half inside. So doing vitrectomy, removing the nucleus, exerting as little traction on the posterior, on the base of the vitreous, and that way the whole nucleus can be removed. Now look at the strength of the zonules in such cases, and you could see that while I was rotating the IOL, it went very far into the periphery, which is not a good idea. But just to show you that this is a possibility, and you can place this lens in the bag, in the sulcus, and capture it. But what is mandatory is to see whether there are any remnants of vitreous in the anterior chamber, tricot assisted vitrectomy, and that should close the case. Let's look at the next one, and this is a patient which had, everything was going on fine, and when we last we were taking out the last few fibrils, and inadvertently there was a small rupture of the posterior capsule. Now this was a very central rupture. it did not progress, and we could place viscoelastic in the anterior chamber, and with the microforceps we could carve out a small posterior rhexis out of this posterior rent that there was. So again, the equilibrium between the anterior capsule, the posterior capsule, the anterior chamber and the vitreous face is very important. So that if it can be maintained as much as possible, you can do a very neat and a round rhexis, and it's not so difficult at all. But again, before closing, vitrectomy needs to be done if there is vitreous, which can be ascertained by the triamcin alone. Now let us look at this one, in which we have, again it's moved out. So So this is a large, again, PCR that has occurred, and we have a lot of material inside, and this material can be removed again by slow motion phaco as much as possible, keeping watch that there is no vitreous coming into the anterior chamber, and if that is done well, then the next part is placing in, while removal of the phaco probe, the anterior chamber should definitely be filled with viscoelastic, and then whatever cortical matter is there, it's very important that the cortical matter be taken out only if there is no vitreous in the anterior chamber. Again, if vitreous comes into the anterior chamber, it's always mandatory to do a vitrectomy, settle it, and then place in the intraocular lens after doing a full removal of the cortical matter. At times you can leave a little bit of the cortical matter also inside and remove it after the placement of the intraocular lens. So these are little decisions that have to be taken on the table, and whatever is to the best of intention for the patient at that point of time is what is required. And again, capturing these intraocular lenses into the anterior capsule is what is very important. Now let us look at this case in which we have again a PCR with nucleus and the cortex is there, and this was to be a toric IOL, and it is a small tear, and we are able to get rid of this tear and carve it out into a small posterior capsular rhexis. And once the posterior rhexis is carved out, the amount of cortex can be removed, and everything has to go in so that the posterior capsule does not get enlarged, and once a rhexis is done, the enlargement of the posterior capsule will never be there. And as you can see that there is a little bit of cortical matter and a little bit of nucleus in the anterior chamber, which actually I am leaving behind till I have placed in the lens. So once the lens is placed in, and it can assume its own position because it's a toric IOL, and this is one way in which even a toric IOL can be placed if a bag has been ruptured, if we are able to make a posterior capsular rhexis out of this bag. So the removal of the rest part of the nucleus matter or the cortical matter can be done after placement of the lens as well. Now let's look at the last scenarios in which there is no posterior capsule, or the posterior capsule cannot be salvaged, and but the IOL can be placed in the bag. So in this particular patient, there is, as you can see, a transverse rupture. A posterior capsular tear has occurred, and this was one of our typical cases in which the transverse rupture has occurred, and I have been able to delineate the ruptured posterior capsule from the anterior capsule. Now, this technique is not possible for every patient, for every situation. But if the vitreous has not come, if you are able to open up that space between the ruptured posterior capsule and the anterior capsule, this is the technique in which even a single piece lens can be placed into that hammock. And if you see that the maneuver is very important, you have to make a pivot of the angle of between the haptic of the lens and the optic, and then place it in. The landing of the first haptic has to be over the iris, and then the maneuvers have to be done. One should not aim in such a situation to put it directly into the space between the anterior capsule and the posterior capsule, because if that is done, what happens immediately, the vitreous starts shallowing it up and the posterior capsule actually tends to float up. So this is a technique, again, not for all posterior capsular ruptures, but once in a while, when you are able to have a proper difference between the ruptured capsule and the anterior capsule, one can do this. And can you also do it with, if it is a multifocal or a trifocal lens that there was? This was a very unfortunate patient of ours in which we had a trifocal lens in one eye, in the first eye. This is the second eye, and we had a rupture for this one. So should I put a trifocal or not? That was the first question that I had to answer to myself on the table. And since the vitreous had not prolapsed, I did take the advantage of the ruptured bag, the space between the ruptured posterior capsule and the anterior capsule, and in that same technique we fixed the patient's lens within the bag. Now these lenses will stay very stable if there is no vitreous into the anterior chamber and if that space is maintained. So all these patients do very well, but of course, again, time and again, we must remember that these patients are not, this technique is not for every patient that we do. Now here is the last video that I'm going to show you, and here we have a longitudinal rip. Instead of the transverse rip that I showed in the first case, this is a longitudinal rip. Therefore, when I land the lens on this particular patient, after of course removal of the cortical matter, so the lens has to come in and it has to be maneuvered so that it sits in a position and the haptics go into the hammock of the ruptured capsule in between. So as you can see that I'm landing the lens, the haptic of the lens over the iris, and then with a maneuver we'll have to rotate it so that it comes and occupies that hammock of that difference between the posterior capsule and the anterior capsule. And as you can see that it is not a straight tear, that is, the tear has not bisected. There is a difference between one half and the other half, but it can sit in very well, and this maneuver and this technique can be done, and it usually has very good outcomes. So instead of putting in a three-piece lens in the sulcus, this can be done and with good results. But again, it's not for every case. Thank you very much for your kind attention.
Thank you, Dr. Partha, for excellent presentation. With this, we come to the end of this session. And thank you, everybody.
So there will be a 30-minute break. This hall has to be prepared for inauguration and installation. So meanwhile, you can have all tea and others. Please be there. Request salt. We'll just trying to start as early as possible. So another 30 minutes we'll be starting it.
So we request all faculty to be here in 10 minutes time. Dr. Harvansh Lal sir, Dr. Arun Jain, all faculty has to be here in 10 minutes time. Have a cup of coffee. We are studying 10 minutes. We have all the memento of faculty will be awarded here only. Laptop to complete